My name is David Murray. I'm the NIH Associate Director for Prevention and the Director of the Office of Disease Prevention. The Office of Disease Prevention is hosting today's meeting. So I want to call the meeting to order and move immediately to introduce our opening speaker. It's my pleasure to introduce Dr. Eliseo Perez-Stable. He is the Director of the National Institute of Minority Health and Health Disparities here at NIH. NIMHD conducts and supports research to advance knowledge and understanding of mechanisms to improve minority health, identifies and understands health disparities, and develops effective interventions to reduce these disparities in community and clinical settings. Dr. Perez-Stable's research interests have centered on improving the health of racial and ethnic minorities and underserved populations, advancing patient-centered care, improving cross-cultural communication skills among healthcare professionals, and promoting diversity in the biomedical workforce. Prior to joining NIH in 2015, Dr. Perez-Stable built a career at the University of California, San Francisco, where he was professor of medicine and chief of the Division of Internal Medicine. He was also director of the Center for Aging in Diverse Communities. He was also director of the UCSF Medical Effectiveness Research Center for Diverse Populations, which addresses issues for African Americans, Asians, and Latinos in the areas of cancer, cardiovascular disease, aging, and reproductive health. Dr. Perez-Stable has received many honors and awards throughout his career, including UCSF's Kaiser Award for Excellence in Teaching, the Society of General Internal Medicine's John M. Eisenberg National Award for Career Achievement in Research, and election to the National Academy of Medicine. He was honored with the UCSF Lifetime Achievement in Mentoring Award in 2015. He was born in Cuba, grew up in Miami, obtained his undergraduate degree from the University of Miami and his MD from their School of Medicine. He completed his primary care internal medicine residency and research fellowship at UCSF. Please join me in welcoming Dr. Eliseo Perez-Stable.
Thank you very much, David. I was charged with giving introductory remarks and sort of setting the stage. I'll be able to stay for much of part of today and look forward to seeing other parts of it on video. Let's see if I can speak without, and how do I get this going forward here?
This device.
Oh, this one. Okay,
yeah,
great.
Thank you.
All right, got it. Full disclosure, no conflicts. As a federal employee, you're not allowed, and as an IC director, I'm even more restricted. But as a general intern, as primary care faculty member, I never had any conflicts, so I'm proud to lay that out. I want to emphasize that we have 3 other institutes supporting this effort. My colleague and friend Gary Gibbons will be presenting a video vignette from the NHLBI perspective. Bob Corll, a longtime friend and colleague in NCI and the director of the Division of Cancer Control and Population Sciences, which, by the way, has a bigger budget than our institute, will also be talking by video. And then finally, Griff Rogers from the National Institute on Diabetes and Digestive and Kidney Diseases will also be presenting. So I've watched all 3 vignettes, and they're brief, but they're to the point. I know this audience is familiar with all this, but I just want to get us started with sort of a common ground about minority health and health disparities. We look at minority health as research that focuses on race, ethnic, minority groups, everything and anything related to those groups, whether the outcomes are good or not good, both mechanistic as well as improving outcomes and promoting equity. We also endorse the idea that all race, ethnic, minority groups, as well as all disparity populations, share a common theme of being subject to discrimination in our society, and that this has led to a certain amount of social disadvantage, even though this varies by group. These are the Office of Management and Budget census, race, ethnic categories, and the census will be distributed next year. We're a federal agency, we endorse this, but more importantly, I think that we need to be standardized in how we use terminology. A couple of quick points. Native Hawaiian Pacific Islanders are not Asian, and they should not be combined. Asian PI is wrong, and we should stop doing it. We should also abandon the term Caucasian, which frequently appears still in the medical literature. It comes from the physical anthropologists of the 19th century who firmly believed that humans originated in the Caucasus, and we now know that's scientifically incorrect. The census still offers more than one race category. We'll see what happens next year. 2 to 3% of Americans have endorsed that box, even though we know that's more. And then Latino or Hispanics are the only ethnic group that is acknowledged by the census. Why this matters, I still get that question depending on the audience. This is a simple response. It predicts life expectancy and mortality in directions that are not fully understood. While whites and U.S. overall has been losing life expectancy, a grave concern, I might add, for our society that has not received, I think, sufficient attention. African Americans have actually gained beyond expectations over the last 20 years, and Latinos continue to be unexplained better life expectancy than other groups. Our mandate on disparities includes other populations besides race, ethnic minorities. All poor people, regardless of race, are included in our target population. We're also interested in underserved rural residents. This is in the original legislation of NIMHD. And in October of 2016, alongside the Agency for Healthcare Research and Quality, we declared sexual gender minorities a disparity population for NIH research purposes. And I think this has stimulated more research in this area. So a health outcome that is worse in any of these 4 population groups compared to a reference group will define a health disparity from our perspective. And again, we endorse this common theme of social disadvantage due to discrimination. And frequently, since we're talking about services, many of these populations, if not most, are underserved in healthcare. Why does socioeconomic status matter? It predicts mortality as well, income. This is from adapted data from the census that has been looked at various ways. If you're at the poverty level, you're 3 times more likely to die from anything than if your income, if household of 4 is $115,000. This is as robust a predictor of mortality as things like blood pressure, BMI, and cigarette smoking that we pay a lot of attention to in preventive services. So I think this is a message of why we need to incorporate these social determinants, demographic determinants, in our thinking about all healthcare. NMHD developed a framework that's really intended to identify sort of the direction and not the factors involved in development of disparities and in ascertaining minority health outcomes. And I think I just want to emphasize the different levels and domains of influence, both from the biological, behavioral, environmental, and then how these interact with the healthcare system. Since we're here talking about services, I think, again, reemphasize that as a former primary care doctor, I very much appreciate the importance of what can happen in the clinical setting. A message of success has been vaccinations in children. We can see these data, they're dated, but the numbers haven't changed. If anything, we'll see a tendency towards upper middle class whites decreasing in their vaccination rates, as we've noted, with the recent epidemic of measles this year. But achieving over 90% vaccination rates for all groups is a major success, and this is something that I think access has driven. We don't do as well with adult vaccinations, which would be something to pay attention to, where we do see inequity by race, ethnicity, and access. So in thinking about global issues about promoting health equity and preventive services, I have 5 points to make. One is that clearly, if you're getting services, you need more access. And access is not just insurance, but also a place and a clinician as being fundamental drivers of this. So this is combining the clinical and public health perspectives in incorporating everyday public health into clinical medicine. Since more and more people go to see a clinician independent of their chronic disease issues, I think this is a fundamental issue. We also need to consider differences by race in prevalence and severity. Not all prevention is equal. is an equal opportunity issue. So the example of hypertension I'll come back to in a minute in terms of prevalence and severity being different by race. Negative clinical trials of screening without diverse participants cannot be the final word. And I'll make this point about prostate cancer screening, independent of what you believe is the right thing to do with PSAs. And then I think that as we've seen over the last 20, 25 years, the development of the expansion of biological knowledge associated with social constructs, particularly around race, need to be considered in developing prevention guidelines. And I think that we have not been as nuanced and as astute on this topic as we could be. And that's one of the goals that I wanted to see this workshop, is to push the field to move in this direction. Finally, I'm a fundamental believer in primary care. I was pleased to see data come out that primary care saves lives. I think that there's a lot to be done in the setting of clinician-patient relationship over time, particularly when there's chronic disease, the importance of effective communication, of precision in cultural competence and cultural care, and then in having these kinds of systems that coordinate care and not depend on subspecialty referrals all the time for care. The example of hypertension, I think, is a good one. We know African Americans have a higher prevalence. The REGARD study, a large cohort study in the South, has shown that for the same level of hypertension, an African American person has 2 times the risk of stroke. And this is blood pressure in what we used to call the mild range or stage 1 compared to white. So even though we know it's more common, it's more severe, and has a higher risk of a bad outcome, blacks are less likely to be controlled based on national data, except in the West, where there is more population health approaches. Northern California, Kaiser, a number of years ago, published a study showing that you can get 80% of patients controlled, and yet we don't do it. And I think this is a challenge for our healthcare systems. And if you get to 80%, you're saying, well, next level we'll push to 90, but get to 80. Multi-level interventions involving doctors, patients, and system. We know that cancer varies by our crude social construct of race. Prostate cancer stands out, double the rate for blacks compared to Latinos, and much higher than whites or Asians. Lung cancer is also higher, and I'll quickly run through a couple examples here. So where is the evidence about PSA screening for African Americans? Last year, there was a publication about a UK trial that was negative, a cluster randomized trial. I mean, it was a well-done study, 10-year follow-up, no difference in mortality. So the US, European, and UK trials had over 640,000 participants. A grand total of 4.4% were black. 4.4% in the US study, I should mind. The UK study and the European study had negligible diversity given when they set up and recruited. So we recommend that prostate cancer be a discussion. At one point we said, no, don't do it. Another time people were doing it. Yet cancer is twice as common, occurs at younger ages, is more aggressive. And do we conclusively say it's not useful in African Americans? And I think we can't default and say, well, there's not enough evidence. We have to get more creative about how we make these recommendations to our populations. The case of lung cancer is also important. We now have, I think, reasonable evidence that it's a differential effect of smoking based on race ethnicity. So in this follow-up from the multi-ethnic cohort study, almost 5,000 cases of lung cancer ascertained prospectively by 2012, and then modeling excess relative risk of smoking 50 years at 10 cigarettes per day, so 25 pack-year equivalent. Native Hawaiians had the highest risk and was unexplained based on all the data that they had available. And Latinos had a much lower risk, less than half, also unexplained. For African Americans, the higher risk was thought to be explainable on the basis of total nicotine equivalents present in the sub-study analysis that was done. And also for Japanese Americans, and perhaps this is partly due to metabolism differences. So again, we see this differential effect, known carcinogen, bad outcome in a preventable intervention. Yet lung cancer screening rates are not great. We have evidence of a 20% decrease in overall mortality from a randomized trial of screening CT scan. We don't have uptake, and I think that's a challenge. Why are we not doing this? And there are other examples in the past that I won't get into now. We don't see 3%, 5% of eligible smokers being screened. This is a challenge. So let me come back and just finish with patient-clinician communication. It is linked to linked to satisfaction scores. We have good evidence about race concordant visits for African Americans and language concordant visits for non-English speaking patients. African American and Latino physicians actually are more likely to see minority patients, to see immigrant patients, to see limited English proficiency patients. And one analysis showed that they see well over half of these populations across the country, even though they only make up about 12% of all physicians in the U.S. And this is a crisis that needs to be addressed, and I think we have enough evidence to say it's an intervention that could work to promote equity in healthcare as well as in preventive care. My final comments would be that we really should shift the models of care to population health with primary care at the center, and that this will go a long way to addressing equity. We should collect and use standardized measures of social determinants of health. We should really leverage the electronic health records as a way to promote equity with a variety of methods and rethink about how this burden has fallen on clinicians, how we engage community resources in promoting health, and then recognize and manage discrimination. So thank you for your attention.
As I indicated at the outset, my name is David Murray. I'm the Director of the Office of Disease Prevention. Our office has as its mission to improve public health by increasing the scope, quality, dissemination, and impact of prevention research supported by NIH. We do that in partnership with the institutes and centers who control all the resources. We just provide encouragement and ideas. We've recently released our second strategic plan for 2019-23. You can find it on our website. We have 6 strategic priorities that are listed here. We also have 3 cross-cutting themes that are important for the office, one of which is health disparities. So it's quite natural for us to be involved in this workshop. The workshop is on achieving health equity and preventive services. This addresses our interest under our second strategic priority, which is identifying research gaps. And our goal is to assess the available scientific evidence to identify future research needs to achieve health equity in 10 clinical preventive services that target the 3 leading causes of death in the U.S. That's cancer, heart disease, diabetes. All 10 of these clinical preventive services have received A or B recommendations from the U.S. Preventive Services Task Force, and under the Affordable Care Act are available to patients at no charge. The workshops begin with a systematic evidence review. So this work got underway 2 years ago. It takes quite a while to get one of these workshops together. The systematic evidence review is provided to our panel. They also, over the course of 2 days, hear a number of interesting presentations from our speakers. We encourage audience participation, both from those of you who are here in the room. You can step to microphones in the aisles and ask questions. And those of you online can submit questions via email and Twitter. The independent panel, I warned them this morning. I hope they got plenty of sleep before they got here, because they're not going to get that much beginning this morning. They'll be working late tonight. They'll be working late tomorrow night, putting together their synthesis of the evidence and preparing a draft panel report. The panel report will be posted on our website and open for 30 days for public comment. And the panel will then revise the report based on the comments, and it will be published in approximately 6 months in Annals of Internal Medicine. The P2P program, as we call it, Pathways to Prevention program, has done pretty well over the last several years. The registrants represent a broad spectrum of participants. The publications draw widespread attention and engagement. The panel graphic shown here shows relative citation ratios for publications from 2 of our recent workshops. All of these were in the top 5% of all publications in PubMed, and the last 2 on the opioids panel were in the top 1%. The research gaps that are identified in these reports are disseminated broadly and stimulate not only public discussion, but research funding opportunities from NIH. The workshop has a number of key participants. Representatives from my office have been involved in planning the workshop for the last 2 years, working closely with institute coordinators, and we have 4 institutes here at NIH that are involved with this workshop, and I will identify them at the end of my remarks. They worked with content area experts to plan the meeting, identify the questions that the meeting is structured around. They commissioned the Evidence-Based Practice Center through ARC to do the evidence review. They nominated independent panel members, and then our office vetted them and recruited them, and I'll introduce them in a moment. The planning group also identified workshop speakers, and our staff recruited those. We're very grateful to have you all here, both in the room and participating online. And we look forward to working with our federal partners to implement activities to address the recommendations once we have them. The Evidence-Based Practice Center, The Evidence-Based Practice Center does conduct a systematic evidence review through a contract with AHRQ. We fund that through an interagency agreement. The Pacific Northwest Evidence-Based Practice Center at Oregon Health and Science University is the center that performed the evidence review for this workshop, and we will hear from Heidi Nelson and Amy Cantor about the results of their review. The independent panel is a very important part of this workshop process. They're recruited specifically because they do not have financial or intellectual conflicts of interest. People ask me, David, why don't you have experts on the content area working on the panel for these workshops? We specifically want people who have not spent their careers working in the content area so that they can be independent and open-minded and not have any biases coming into hearing the evidence. They are multidisciplinary, they have expertise in a variety of fields, and they produce a very important report that synthesizes the findings and makes recommendations for future research. The charge to the panel is shown here. We certainly ask that you listen to all of the workshop proceedings and attend all the executive writing sessions and prepare the draft report. Importantly, we ask that you gather at least virtually in about a month or 6 weeks to review and incorporate public comments into the draft, and then finalize the report before it is submitted to Annals for publication. The panel members I'm happy to identify and introduce at this point, and I would ask them to come up on the stage so that the audience can see them. Dr. Tim Carey from the University of North Carolina at Chapel Hill School of Medicine is our workshop and panel chair, and he will be speaking to us in a few moments. Dr. Betty Beckemeyer is from the University of Washington Center for Public Health Practice. Dr. Doug Campos-Outcalt is from the University of Arizona School of Public Health. Dr. Susan Koch-Vaser is from Tufts University School of Medicine. Dr. Sandra Millen Underwood is from the University of Wisconsin-Milwaukee College of Nursing. And finally, Dr. Stephen Teutsch is from the UCLA Fielding School of Public Health. The speakers have been asked to disclose all relevant financial conflicts and to read their disclosures aloud. Please refer to disclosure statements on our website to the website for speaker bios. The panelists have no conflicts. We've studied that very carefully. And I would just make a few other comments before I turn things over to our chair. We have over 1,400 people registered for this workshop. We have maybe 100 so far in the room, but I expect that will grow as people work their way through the Gateway Center Many people not familiar with NIH may have arrived at 8:30 thinking they could get through in 30 seconds. It does take a little longer. And I know that we have hundreds of people watching the video cast, and hundreds more will watch the video cast over the next several weeks because it will be available online. Our opening panel is comprised of distinguished researchers who will share their thoughts and lead a discussion with the audience. We have 4 NIH institutes and centers co-sponsoring the workshop, and 3 directors will share their perspectives via videos, and we've already heard from one this morning. Finally, we have a closing keynote speaker, Dr. John Iranian, who's a distinguished health services researcher, clinician, and thought leader in healthcare disparities. And I've forgotten to advance my slides as we've been going along. I've just been looking at my notes. I do want to thank the Institute coordinators, Rick Berzon from NIMHD, Melissa Green-Parker from NHLBI, Antoinette Percy-Laurie from NCI, LaShondra Price from NHLBI, and Pamela Thornton from NIDDK. We've had important help from AHRQ, from the Pacific Northwest EPC team. Our workshop speakers and independent panel members have done a lot of work to get ready for the meeting. We're looking forward to hearing from them over the next 2 days. I want to thank Westat, who operates our support services contract and is providing logistical support for the meeting. And finally, I want to thank the staff in my office who've worked so hard to put the meeting together, and particularly Kate Winsick and Carrie Klabunde, who've led the effort. And now I want to thank the panel members for coming up, and you're welcome to take your seats again. And I want to introduce the panel chair, Dr. Timothy Carey from the University of North Carolina. He's been a faculty member at UNC since 1985. He's a health services researcher and remains very active as a clinician in both inpatient and outpatient care. He's a senior advisor to the UNC Evidence-Based Practice Center and is associate director of UNC's program on ethnicity, culture, and health outcomes. His current activities include ongoing work in comparative effectiveness research, examination of treatment patterns and clinical effectiveness in chronic musculoskeletal problems, and he serves in the leadership of their CTSA program, focusing on type 2 translational research and cross-disciplinary collaboration. He's a co-chair of the National CTSA Consortium, Key Function Committee on Comparative Effectiveness Research. He's received funding support for investigator-initiated research and training grants from a number of groups, including AHRQ and NIH, and also from foundations. He has recently served as a consultant for PCORI on research prioritization, and he works with medical students, doctoral students, and postdoctoral fellows. Please join me in welcoming our chair, Dr. Timothy Carey.
Thanks very much and good morning. I will be very brief so we can get right to it. I do not have any disclosures. You've already met our panel members. Bios are on the website. Just click on the name under when you look at the agenda. And that's going to be true for all of our speakers. We're going to try to keep introductions really short so that we can spend our time on the important content. So the panel activities, you've already heard this. We will draft a report summarizing the literature, briefly address evidence from the speakers and from comments we hear here today and tomorrow, and comments we get from folks watching online. I think hearing from patients, the public, and advocates is really important in this process for this topic. We do a draft report, and the final report, after public comment, it's posted for a month, will be published in Annals of Internal Medicine. So the systematic review is already done and will be posted this morning, so will be available for you all to read it, looking at 10 preventive services that are A or B recommendations from the USPSTF. Each session today is going to focus on one of the key questions, and you'll be hearing about those with presentations today and tomorrow from the Oregon EPC, summarizing the rather lengthy report. So each session will start with an EPC speaker, then have some subsequent talks addressing some of the cutting research, perceived gaps in this literature, et cetera. The speakers, again, will introduce themselves, and the presentation will be followed by a 40-minute discussion period. Not each presentation, but each sort of bundle of the key questions. So we will have 5 40-minute discussion periods. The first Questions may come from panel members if they have clarifying questions, and then we will go to questions from members of the audience here or people watching online. Now, members of the audience here will go left microphone, right microphone. However, 40 minutes, although it's a good period of time, we want to hear from as many of y'all as possible. So we're asking you to restrict your question or comment to 2 minutes. And I will say thank you very much at 2 minutes. So bear with us on that because we want as many people to submit comments as possible. If you have more to say, feel free to comment online. We will try to get comments in from folks sending via Twitter, email, or whatever social media mechanism NIH uses to discuss them during the conference here. But also the panel members will get those comments tonight and tomorrow. And I think I just said that. We will have breaks of 10 minutes between sessions, but we really want to start and end on time so that the last speaker of the day will have sufficient time as the first speaker of the day does. And we want to hear from you. And I think on the website, for those looking online, there's those various addresses and Twitter handles. There's also a computer station by the registration desk that I haven't seen. Thanks very much.
Good morning. I'm Rick Berzon. I'm a program director in clinical and health services research at the National Institute on Minority Health and Health Disparities. I'd like to provide brief background and context for the NIH Pathways to Prevention workshop and reflect on why the topic of achieving health equity in clinical preventive services is so important to the NIH and to its sister agencies. I have no conflict of interest to disclose. So evidence-based preventive practice screening and counseling services recommended by the U.S. Preventive Services Task Force, the Centers for Disease Control and Prevention's Advisory Committee on Immunization Practices, and the Health Resources and Services Administration's Bright Futures recommendations for women and children, are designed to help all Americans stay healthy, avoid or delay the onset of disease, improve longevity and productivity, and reduce individual and societal financial burden. Despite their proven value, however, Americans use preventive services, including cancer screenings, preventive visits, injury prevention recommendations, and vaccinations, at only half the recommended rate. Chronic diseases such as heart disease, cancer, and diabetes are responsible for 7 of every 10 deaths among Americans each year and account for 75% of the nation's health spending. Many of these chronic conditions can be prevented or delayed and detected and treated early when patients work closely with their primary care providers. There are particular public health consequences for at-risk populations. Despite clinician guidance, substantial racial and ethnic variance in perception and comprehension of risk exist with respect to how patients manage health-related information. As an example, more than 2 million Americans have cardiovascular disorders, and 800,000 die from myocardial infarction or stroke every year. These incidents are the leading contributors to racial disparities in life expectancy. African Americans are nearly twice as likely as whites to die from heart disease and stroke. American Indians and Alaska Natives die from heart disease at younger ages than other racial and ethnic groups in the United States. Many of the deaths caused by cardiovascular diseases are preventable. Now, for example, primary care practices have the evidence to adopt the ABCs of cardiovascular disease prevention: aspirin in high-risk individuals, blood pressure control, cholesterol management, and smoking cessation. Greater use of proven clinical preventive services in the United States could prevent the loss of more than 2 million life years annually and result in total savings of $3.7 billion. However, adoption by providers and implementation by patients of such preventive practices varies for multiple reasons, including socio-behavioral, economic, and environmental considerations, among others. The U.S. Preventive Services Task Force makes recommendations to Congress about the effectiveness of specific preventive care services. In 2016, the task force's 6th annual report to Congress on high-priority evidence gaps for clinical preventive services identified specific populations for which evidence gaps exist, including screening for breast cancer in African American women, screening for cervical cancer in Hispanic and African American women, and screening for colorectal cancer in African Americans and American Indians, Alaska Natives. In 2017, the task force added screening for prostate cancer in African American men as another evidence gap that prevents it from making recommendations for this population. Research in these areas will generate much needed evidence for important new recommendations to improve the health and healthcare of Americans. Dr. Kristen Bibbins-Domingo, who was chair of the task force in 2016, is with us today and will moderate the opening panel. Differences in the use of healthcare preventive services between racial and ethnic minorities and white populations contribute to disparities in clinical health outcomes and health status. Strategies that connect timely utilization of appropriate health services to clinical need improve the health of minority groups and help to eliminate disparities. Low levels of cancer screening, for example, mammography screening, pap smears, and colorectal screening, can result in a diagnosis at a later stage of the disease, resulting in more limited treatment options, greater disparity, and higher mortality. Selected challenges to receiving preventive services are revealed by these bullets. Blacks and Hispanics, groups with high diabetes prevalence, have lower preventive services than whites and Asian Pacific Islanders. American Indians, Alaska Natives, the group with the highest diabetes prevalence, had the lowest use levels of all the services. The Hispanic population is made up of numerous subpopulations, and nation of origin is not consistently associated with differences in receipt of preventive services within the Hispanic population. However, Mexican Americans, when compared with blacks and non-Hispanic whites, have been found to have a higher awareness of and treatment for hypertension. Lower awareness of and treatment for hypertension. Rural residents, whether Hispanic or non-Hispanic white, are generally less likely to receive preventive services. Lack of health insurance and lack of a usual source of care have been found to be among the strongest predictors of failure to receive preventive services. Hispanics are significantly less likely than whites to report having received many of the preventive services studied. These differences were not present when selected characteristics of respondents, including income and health and education, were held equal in multivariate analysis. The following few slides illustrate variance in disease diagnosis and in use of preventive services across racial and ethnic populations. Undiagnosed cases of hypertension, diabetes, high cholesterol, and kidney disease have all been found to be higher in health disparities population in comparison with non-Hispanic whites. The black bars at the top illustrate these undiagnosed cases. National estimates of undiagnosed kidney disease in blacks is especially striking. Preventive practice screening and counseling services recommended by the U.S. Services Task Force could, if adopted, implemented, and followed, prevent or delay many of these types of chronic conditions, assuming equity in diagnosis. Undiagnosed diabetes in adults by race ethnicity is highlighted in this slide. Here we see the largest percentage of undiagnosed diabetes is in non-Hispanic Asians at 48% and Hispanics at 43%, followed by Mexican Americans at 39% and by non-Hispanic blacks at 35%. The lowest percentage of undiagnosed diabetes is in non-Hispanic whites at 31%. The differences between Hispanics, Mexican Americans, non-Hispanic blacks, and non-Hispanic Asians relative to non-Hispanic whites are significant. And these data are from the National Health and Nutrition Examination Survey in years 2011-2014. Non-Hispanic whites have the highest percentages of some types of colorectal cancer screening. The percentage of non-Hispanic blacks in the triangle and Hispanics, looking at the diamond line, obtaining colorectal cancer screening were found to be lower. Although colorectal cancer test use increased among racial ethnic minorities and the health disparity gap between whites and blacks is closing, those without health insurance and those with lower household incomes, less than $35,000 annually, and those with less than a high school education have a substantially lower prevalence in colorectal test use than did the comparison groups surveyed. Geographic disparities in smoking are highlighted in this slide, which shows higher rates of current smoking in the South Central and parts of the North Central regions of the U.S. when compared with other regions. Demographic and geographic disparities across preventive service use are significant. Such disparities warrant further investigative research regarding the inadequate implementation of evidence-based preventive guidelines in practice among primary care providers and minority and health disparity patients. There are a variety of structural and non-structural barriers, both known and hypothesized, to the use of preventive health services in health disparity populations. These exist at the community, programmatic, and individual levels. There are significant interactions among these categories of barriers and relationships between them with respect to their effects on use of preventive services will be examined during the workshop. The Pathways to Preventive workshop will address research gaps, impediments, and barriers regarding the adoption and implementation by providers and the uptake by health disparity populations of evidence-based preventive services. The workshop will seek to answer a number of research questions about the effectiveness of different approaches and strategies between patients and providers that could increase the use of such preventive services. The National Institute on Minority Health and Health Disparities, the National Cancer Institute, the National Heart, Lung, and Blood Institute, and the National Institute of Diabetes and Digestive and Kidney Diseases, as well as the NIH Office of Disease Prevention and the Agency for Healthcare Research and Quality, collaborated to develop this program to focus on the importance of achieving health equity in preventive services. There are 5 key topic questions that will be addressed during the workshop. These questions are listed in the next 2 slides and appear on the ODP website as well as in your agenda. Topics range from an examination of barriers to the adoption of preventive services by clinicians and health disparity populations, to inspecting best practices for integration and shared decision-making between providers and patients, to examining health information technologies and digital enterprises in settings that serve health disparity populations, to considering the role of healthcare organizations and systems with respect to reducing disparities in preventive service use. I'd like to end my remarks by noting 10 unique preventive services recommended by the U.S. Preventive Services Task Force that will be discussed during the workshop. These are characterized as well-established, current, and evidence-based practices in primary care for which only a very high level of evidence would justify a change in grade. These preventive services currently have an A or B recommendation indicating that there is a high certainty that the net benefit of the service is substantial or moderate. The services are listed in the next 2 slides and appear on the ODP website. And here are the remaining preventive services to be discussed during the workshop. I'd like to acknowledge those individuals from other ICs and sister agencies who are co-sponsoring the NIH Pathways to Prevention workshop with NIMHD. And now I would like to introduce Dr. Kirsten Bibbins-Domingo, the moderator for the opening panel. The panel is entitled Catalyzing Health Equity Innovations. The bio and background for Dr. Bibbins-Domingo and for all speakers can be found on the ODP website. Thank you.
Yes. I'm going to invite my panelists to come up and join me. So thank you very much for the invitation and for putting on this really terrific workshop. My name is Kirsten Bibbins-Domingo. I was on the task force from 2010 to 2017 and was a vice chair and chair towards the end of that time period. I just want to offer a few remarks before we start the panel discussion. When I started on the task force in 2010, that was right after our mammography recommendation had come out in 2009. And we were really engaged at that time in really enhancing our ability to communicate with stakeholder groups. We did a lot of more listening tours and talking with organizations we wanted to engage in the work that we were doing. And so that was my first introduction to being on the task force. And I remember the one meeting that we had with the heads of several patient advocacy groups that represented different racial and ethnic minority groups within the U.S. And these were the national leaders, and they met with us as members of the task force, a few of us. And I still remember very distinctly one of the leaders of these groups saying to me when we came around the room to talk about our different recommendations, saying without any animosity, without any snark, or without any irony, I really had no idea the task force was actually writing recommendations for my community. And I thought, whoa, that was a big punch to the gut for me, because I, of course, had joined the task force thinking we were doing all of this great work. And to hear someone who really had come to engage with us saying that there was nothing we were communicating at that time that was really she viewed as being relevant to the community that she represented was really quite eye-opening. And I think that informed much of what we did over a period of time to try to engage with stakeholder organizations early, to try to enlist their input in how we thought about recommendations from start to finish, and to help us in the process both of understanding whether our frameworks related to the specific issues that were relevant in their communities, as well as to help us disseminate as we got to the end of our process. So getting the word out was clearly something we viewed as important and still do and still take very, very seriously. I think there's three, though, questions, because clearly getting the word out is not enough. And I think that there are three big categories of questions that I really hope during the course of today we can discuss more, and certainly the panel will provide more insights on. The first is, so you have the evidence, you get the word out, but how do we actually do this in actual practice? There's nothing like your home family to keep you honest, and so when I would fly back from the Washington, D.C. and the task force meetings to my colleagues where I practice at Zuckerberg San Francisco General Hospital, which is a safety net hospital in the city and county of San Francisco, and they would say to me, we cannot implement these recommendations. We have no idea how we're going to approach what you're recommending. My colleagues were outstanding and are outstanding clinicians. They work in a resource-limited setting. There was nothing in the guidelines as we issued them, except for a few paragraphs on general approaches to implementation. And my colleagues were terrific and very vocal in providing the task force feedback. I remember in particular on the lung cancer screening recommendation saying, you know, this recommendation, we cannot implement this. We are basically trading smoking cessation programs with CT scans for lung cancer screening. We don't know how to do this, and this recommendation as written is not useful. And certainly was important in much of the way the task force then thought about how we shift those recommendations to try to provide additional language. So how we actually implement, how we study what's effective in implementation, how we disseminate best practices on what's effective in implementation, I think is a really important part of what we will be doing today. A second question is really, when is the evidence just really not enough to make recommendations for the particular populations that we're talking about? Eliseo alluded to this, and you all know that our evidence base is still from a very specific sets of populations. Not all of the communities and populations we'd like to reach with our recommendations are actually represented in the evidence base. And while I believe that everyone deserves to have evidence that's based on people and communities that look like them, the question is what evidence is enough to actually say something now before that evidence exists? Is epidemiology enough? Is it enough to know that we have patterns of disease that differ and therefore we should make different recommendations for different populations if disease starts earlier or is more aggressive? How do we think about that evidence base in the face of also the urgent need to address some of the disparities that we're talking about? And then finally, we are talking about prevention generally, but about a particular slice, clinical prevention. And there are many players in the prevention space. Public health organizations think about prevention as well. As we understand and intervene more at all different levels on social determinants of health, how do we think about prevention, even in the clinical space, in a way that recognizes sort of these broader other institutional players, as well as ways in which we might intervene on the social determinants of health that ultimately play a role in our ability to effectively prevent the types of things that we want to prevent. Luckily for me, I don't have to come up with the answers to all of these questions. I just have to introduce this lovely panel that actually is going to answer these for us. So you are going to hear Giselle Corby-Smith, Susan Strong, Herman A. Taylor, and Bruce Y. Lee. I'm going to ask each of them to come up in order and to present, and then we'll have a moderated panel discussion. Thank you.
Thank you, Kirsten. I just shared with one of my other panelists, I'm not sure if I will give you any answers, but probably more questions for us to think about. I have no information, nothing to disclose. I also am a general internist and have never had anything to disclose, unfortunately. So the first two speakers, Eliseo and Rick, really very beautifully talked about the health inequalities that we face each day as we think about the use of clinical preventive services. I'm going to give the sort of the flip side, the other side of this, and really think about health equity. I was really grateful to see in the title of these 2 days. So health equity is the assurance of the conditions for optimal health for all people. This is a deceptively simple statement, right? It requires that we value all individuals and populations equally, that we rectify and recognize historical injustices that lead to health inequalities, that we provide the resources according to need. This is not a situation where we float all boats, but we understand what each boat needs. And it's a fundamental shift in how we think about those that are at the margins, those that are in the disparity populations that Eliseo described and Rick talked about those health inequalities. Health disparities will be eliminated when we achieve health equity. This is an enduring, and this assurance of the conditions for optimal health requires a consistent monitoring of those conditions and the changes that we put in place to achieve health equity. It's not a one and done situation. How do we create opportunities so everyone has a chance to live a healthy life? The first I would suggest is to reframe with a strengths-based approach to health equity. We've focused, for as long as we've collected differences in health by race and ethnicity, on the differences and used a deficit model to think about health. I would suggest that in communities, disparity communities, there are many strengths that we need to think about building on. Bell Hooks talks about centering the margins, those, as in her critique of the feminist movement, thinking about those women that are at the margins that were not reflected in the feminist movement. And this new interest and push to think about disparity populations, I would suggest that we center those at the margins, that we prioritize and the wants and needs of those patients and communities we hope to serve in this work. We think about a way to democratize the process to include direct participation. I think the process has been reflected in this work that has gone into this workshop by direct participation of stakeholders and making sure that they're giving a meaningful voice. And I think you'll see that reflected even in our panel today. That we design and evaluate the impact of our research in this area according to the stakeholders' wished outcomes. As clinicians, as researchers, we know the literature and we have a set of outcomes that we think are important, but we need those stakeholder voices. As Kirsten mentioned, the providers on the ground to help us ground our work to make sure that reflects what the reality is in communities and in disparity populations. This current emphasis on patient and community engagement, I think, reflects this idea of centering the margins, but still marks, even though we've been doing this for quite a while, a radical shift in power dynamics. And we have to be willing to accept that shift. If we want something different, we need to actually have a different way of doing things. I see that I have 1 minute. That was a quick 4 minutes. There's a growing interest in engaging communities, patients, families, and stakeholders as partners in the process of research. And we often use this approach to address the health of populations who identify with underserved, economically constrained, or minority communities. This shifts the role of the researcher from the sole creator of knowledge to co-creator with stakeholders and acknowledges the particular expertise that patients, families, and other stakeholders bring that's critical to solving what has been and in reality will always be a complex problems in health and healthcare. It creates a better process and outcomes by integrating and highlighting diverse perspectives. Our health systems then lead to address things that matter to patients, families, caregivers, and communities. And there's clear evidence of improved health outcomes, patient safety, patient-centered practice improvements, and sustained research policy partnerships. Kristen started talking about this trajectory of from outreach to actually shared leadership. And I think what we've started to see is the outreach, and we still have some places to move on this continuum. There's been considerable attention recently to social determinants of health, where people are born, grow, work, live, and age. And most of this work, I think, needs to really center at this more upstream area. Most of the work currently, though, is still focused downstream, what happens in the clinical practice. But rather, I think if we're hoping to shift and advance health equity, we need to start pushing further upstream. And so with that, I'll end and thank you and look forward to the discussion.
Good morning. My name is Susan Strong, and I have no disclosures. I am a patient advocate, a speaker, and the patient engagement director for Heart Valve Voice. I have been a practicing patient for 36 years. That illustrious career started when I was 17 years old and diagnosed with Hodgkin's lymphoma, and it has continued. I was cured of Hodgkin's lymphoma in 1984 after a regimen of MOP chemotherapy, which is nitrogen mustard based, and 36 GYs of radiation. Grateful to be here. About 5 years ago, I learned about radiation-induced valvular heart disease. And I did want to give a shout out to my pediatrician who diagnosed the Hodgkin's lymphoma after a year of seeing specialists. I was a little embarrassed to go back to his office when I was 17, but he did the trick. So thank you, Dr. Bill Simon from Enid, Oklahoma. About 5 years ago, in just a visit to my primary care physician, she noticed a change in my heart murmur, and that went on to a diagnosis of severe aortic stenosis, which was treated via TAVR, transcatheter aortic valve replacement, 5 years ago this November. Very grateful for that, in that medical intervention. And then 2 years ago next month, I was diagnosed with HER2-positive breast cancer, had a double mastectomy chemotherapy, year of Herceptin. So 5 years ago, I learned about the importance of preventative care, and frankly, that it saved my life twice in the last 5 years, with a heart valve visit to my primary care doctor and then a mammogram, and being aware that I was at high risk for breast cancer. So the value of preventative care services from a patient point of view is immeasurable. It saves lives, and it saves money as well. So it's kind of like, what's the problem? Why are we here talking about it? Because we all know it's a good thing. And yet we all know, too, that it's underutilized. And I think that is a problem, obviously, that we're here to solve. I'm sorry I don't have the answer for you today. It's a complex issue, and we're dealing with individuals that are members of groups who are experiencing barriers to care. And I was reading and realized that only 12% of adults have proficient health literacy. And I consider myself to be one of that 12%, actually, and I still, even after I've become a patient advocate, am not completely aware of the preventative services that are covered under my insurance and that sort of thing. So there's a lot of opportunity for education for patients from all groups to learn more about how to utilize preventative care, to learn about what screenings they need to have, that sort of thing. So I think communication and education are really big parts of that. I think communication that's outbound from providers is really important in initiating care for the preventative services. Those phone calls, emails, texts, patient portal messages that encourage patients to make an appointment that they're due for preventative care. I think that's extremely important. And so I think those were the main things that I wanted to mention. But again, just grateful for preventative services and what it does and the lives that it saves, because it saved my life multiple times. Thank you also, NIH, for including the patient voice in this discussion. It's very important, and I'm always happy to see that done. Thank you.
Thank you very much. I really appreciate the preceding talks and the different perspectives. And I want to offer perhaps a slightly different perspective than you may be used to hearing in this context. And that is, we are very much in the habit of focusing on risk and not the flip side, which might be encapsulated in the term resilience or resistance to disease as you might expect it to occur in conditions of adverse risk, adverse exposures. And propose that there is actually a black paradox that perhaps is underappreciated in terms of the expected outcomes for African Americans when very often we view black health as monolithically bad, monolithically characterized by shortened lifespan and high levels of morbidity. I have nothing to disclose. I'm a cardiologist, but I have nothing to disclose, which you may be surprised about. But I want to point out that health disparities are a tragic reality. Anything that could be characterized as an excess death is obviously an individual tragedy, but we talk about 83,000 excess deaths among African Americans each year, as calculated by former Surgeon General David Satcher and his colleague, Dr. George Rust and others. But is anyone surprised by that? Consider comments by W.B. Du Bois back at the turn of the 20th century, where he said, one thing we should expect to find is that a much higher death rate at present among Negroes than whites. They have in the past lived under vastly different conditions, and they still do so. And we all know the sort of consequences, if you will, as they manifest in the literature that we're all very immersed in day out. These conclusions that you see in a variety of studies that usually wind up saying something like, after controlling for all conceivable risk factors, we still couldn't resolve the excess morbidity or mortality that we saw in the black population. And these things are seen, again, repeatedly in the literature. We're all aware of them. They stimulate things like the Jackson Heart Study, which I've been involved in for many years and directed for many years. And there, too, the emphasis on risk was the precipitant, really, for the formation and the continuation of the Jackson Heart Study, and I think appropriately so. There are aspects, however, of heterogeneity that the Jackson Heart Study will, I believe, shed a lot of light on, but I think each of us need to remain aware of as we go about our business of looking after the public health. One among several of interesting, unexpected findings is the Evans County Heart Study, which I think many of you are already familiar with, wherein in this rural community out in Georgia, it was found back in the 60s at least, that coronary heart disease prevalence was dramatically less among African Americans who had risk factor profiles that would have predicted substantially higher disease. Now, that's variably been explained by the radical social stratification of the society in Evans County at that time, with blacks occupying the ranks of sharecroppers and vigorous individuals, and whites more displaced towards shopkeepers and other more sedentary professions. But I don't believe we understand that phenomenon fully. And in our own work in metropolitan Atlanta, begun recently, we see the surprising result of, after controlling for SES differences across neighborhoods in the community, black neighborhoods in the community, we see dramatically different levels of cardiovascular disease, differences in mortality rate, in emergency room visits, and admission rates in communities that are often geographically contiguous with each other, and we don't have full explanations of why that heterogeneity exists. And my simple thesis is that we may have an opportunity to look at the current state of affairs and find promoters of health that we perhaps are overlooking presently. And I'm down to 1 minute. And I would like to introduce or endorse this idea of centering the margins. And in in the realm of technological approaches to the public's health. Moya, which we'll probably get a chance to talk about more in the discussion, is a community-driven and co-designed data collection and intervention vehicle that we hope to launch in the Atlanta metropolitan area with possibilities of spreading beyond. And the idea is that rather than African Americans and other traditionally marginalized communities being the last to benefit from technological advances and innovations, that in fact they be the center of the development of innovative approaches that include IT towards gathering granular data on a non-time restricted, in a non-time restricted fashion, as many longitudinal epidemiological studies have done, and open up an opportunity to look for these granular, for these new possibilities in terms of health promotion, community-driven, and something that, since I'm out of time, something that we can talk about further in terms of the types of data we're able to collect, and again, hopefully see new pathways to the resolution of health disparities. Thank you.
Great. So thank you again for the opportunity to speak on this panel. My name is Bruce Lee. I'm going to be talking about systems, approaches, and methods for health equity. Slide. So the only thing I have to disclose is that I've never been in any martial arts movies myself. So I wanted to talk about how everyone in society is connected to each other via complex systems. So I think one of the challenges is we tend to forget that we are all connected, that we're all part of these complex systems, complex social systems, economic systems, behavioral systems. We ourselves are complex systems ourselves. And there's a tendency to think that we're individual islands that don't really depend on each other and also don't affect each other. But the opposite is true. And when you don't really appreciate and understand these complex systems, there are tremendous risks. So first of all, you come up with band-aids rather than solutions. So there's a tendency to think, okay, single cause, single effect. There's a single reason why this phenomenon, this health phenomenon or finance phenomenon or what have you, is being caused. And then if you try to address that cause, then you've solved the problem. As a result, we develop a lot of band-aids rather than actual solutions because we aren't fixing the system's problems. And it results in unsustainable solutions. So something might look great for a year or two, but it's like pushing a gigantic water balloon. So if you push down a problem in one part of the balloon, it's going to crop up elsewhere. Additionally, you can miss secondary and tertiary effects, and these can be negative effects. So sometimes you can have very well-meaning initiatives or efforts, but then it results in negative consequences, at least for some people, or maybe even all the people, because you didn't really understand the system. And on the flip side, it also can underestimate the positive effects of an intervention. And this is especially true with preventive measures. So as we know, the preventive measures tend to be an investment up front, and then subsequently you have these reverberating effects that are positive effects, and they can occur over people's lifetimes, over many years. And if you don't really understand the system or appreciate the whole system, then you can actually undervalue and underestimate the value of a policy or an intervention, and this frequently occurs with preventive measures. And finally, you can expend tremendous time, effort, and resources if you don't understand the system, because it can be like throwing money into the ocean. You're hoping something will happen when you're not really sure. So let me give you some examples of systems approaches or methods. So systems approaches and methods are techniques that are used to better understand these complex systems. So we as human beings, regardless of how smart, regardless of how much experience or expertise we have, we're limited in terms of what we can actually see. So we can see immediate effects. I push a chair and it moves along the stage. But, that's a direct effect. Secondary, tertiary effects, quaternary effects, et cetera, can be very difficult to understand. So here's an example where we build a complex simulation model of the Washington, D.C. metro area, representing all the individuals within the location. And we simulate the spread of flu. This is during the 2009 pandemic. And we try to determine if you have a limited number of vaccines available, who should get those vaccines first. And this was basically published in Health Affairs, and we simulated all these different scenarios. And we found, I'll quickly go to punchline since we're short in time, that if you vaccinate the lowest income neighborhoods and populations first, that's where you benefit society the most, as opposed to higher income populations or middle income populations. Because lower income populations tend to be more densely populated, and you tend to have more movement of people for work from low income neighborhoods to higher income neighborhoods. You don't have as many people from high income neighborhoods working in low income neighborhoods. So therefore, there's a greater tendency to be able to spread the flu through lower income populations. So protecting them can actually benefit the entire population. So I have a minute to go. So a second example, we build a simulation model of the entire United States. We look at we simulate what would happen if you increase physical activity among kids, which is appallingly low these days. And we showed the benefits in terms of costs, savings, productivity loss savings, as well as direct medical costs, and they're tremendous. So every cohort, you can save billions of dollars by increasing their physical activity. This benefits everyone in the entire United States, even if you are already physically active. So this is the example of the systems connecting all of us. A third example is we built a simulation model of Washington, D.C., and we found that the impact of crime is quite significant in terms of preventing people from getting exercise, preventing people from getting physical activity. So this is connecting one social problem or issue, which is crime, to health. And many times we think of these problems as separate, but they're interconnected. So you can't ask a population, say, oh, you guys need to get more physically active, without actually changing the system. If they have a situation where there's crime or other impediments to actually getting physical activity, you have to try to fix those systems as well. So happy to go through these in greater detail when it comes to questions. But just in summary, everyone in society is interconnected with each other through complex systems. We can't think of ourselves as separate. We're all in it together. Secondly, inequity can end up affecting everyone in complex ways. So there are actually utilitarian benefits to resolving inequity. In other words, even if you don't care about inequities yourself, you are actually affected by it. And we've shown that through some of our work. So there's a selfish reason to want to solve these inequity problems. And finally, systems approaches and methods can help us understand these complex systems and demonstrate the value of reducing disparities, as well as better understanding preventive care. So with that, happy to engage in the discussion. So thank you.
Great. So thank you to all of our speakers and for the range of perspectives. I think it was really great. So we have a few questions just to guide our discussion today. And so I want people to feel comfortable jumping right in. So the first one is, it's either completely self-evident, but I want you to make it evident to the audience. So why should prevention be the target when we're talking about health equity, right? So, we have other places we could focus. We could focus on making sure everyone gets treatments for the diseases that they get. But make the case that prevention is the thing. You started off by saying you were so being a real cheerleader for prevention, but make the case for us that prevention is really the area to focus. Go ahead.
Jump in. So that second study that I mentioned is an example of what happens if you increase the physical activity among children, among youth. And then the resulting savings, it's a cascade effect. So what we did is we ran this model and we said, okay, what happens if we increase the physical activity among children, and then what happens year by year in terms of their, for instance, body mass index, and in subsequent development of diabetes, cardiac disease, cancer, et cetera. And so if you aren't intervening early on, then you start going down this cascade, and especially once you have chronic diseases develop, then it's challenging because it just starts building upon each other, and it inhibits the ability to exercise, and it inhibits the ability to then potentially work, and so you don't want to get caught in the spiral. And I think the challenge is many communities already they start off in the hole, right? So they don't have the preventive services, they don't have the opportunity to engage in healthy behaviors because they have a lot of other things that are weighing them down. And then if you wait until later in the cycle, and we've shown through our models, and you're intervening later once the diseases develop or once the problems develop, you can never go back. Like, you can never reclaim those cost savings if you want to look strictly economically. So the return on investment for preventive services is so high if you actually measure the system-wide effects. And also, I mean, of course, from a health benefit standpoint, you can't go back.
Great.
Yeah,
Great.
I totally agree. I think, and I mentioned George Rust prior to this because I admire his work so much, but he's made a very good case, as have others, that disparities tend to be amplified at every stage as you go along a continuum of accessing care and getting the care. So, for instance, if you are not diagnosed for high blood pressure until late in the game, then your target organ damage is higher. If people are screening you for target organ damage later in the process, the chances of your going on to things like stroke, kidney disease, and so forth are amplified. And the cost, the human cost, the consequences in terms of morbidity and mortality amplify as you go along. He also used a breast cancer analogy, whereas if you look at African American women who may get screened later, they have more advanced disease, and they have a more difficult course from that point forward. That has, again, huge economic consequences as well as personal human consequences.
I would add, while I'm a general internist and I see adult people that are not pregnant, that's the way I have to characterize my practice, having a life course perspective, I think, is particularly important as well, and I think ties together what Bruce and Herman are sort of suggesting, that this is a multiplicative effect as we think about trajectories of health and illness that start in utero and continue to be disparate as people age. We think about those critical life moments where, is there a time, is there an inflection point where exercise is going to be important in childhood, not only to decrease risk, but to also in pattern and sort of other health behaviors as we think about it, as we think about, what a future health could look like for an adult. Then the human toll, not just for an individual, but for a community. What does it mean to have, particularly in communities that have dense social networks, what does it mean to have multiple chronic conditions amongst multiple people in a community? And what does it mean for community well-being and being able to thrive in this society? So I think that it seems like, one of the Preventive Task Force has really focused on individual preventive services, but if we think about it as a cluster and think about a life course perspective, the amplification that Bruce sort of very eloquently describes in his studies, I think is incredibly compelling.
Great. Susan, maybe you can talk, so as a primary care provider, I love that you shouted out your pediatrician and your adult primary care provider. That's
still
awesome.
alive.
But talk to us for a second about when you think about prevention, is that something you think of as starting in the doctor's office, or is it something you think about as taking place sort of outside of the doctor's office?
That's a great question. Thank you. I think prevention absolutely has to start in individuals and making good choices in their lives about exercise and eating and following up with a doctor. It is a group, I think, experience for educating the population about what good prevention looks like, but it's certainly not the doctor's responsibility. I think it's individual responsibility, but we have to work together in partnership.
But it was natural for you that a doctor would be making recommendations about prevention, that a doctor is a place not just to go to when you're sick?
Oh, absolutely. Absolutely. And the preventative services and the screening and not only prevention but early detection, as was mentioned before, I think is so crucial, and especially for high risk and vulnerable populations.
So, but in the prevention landscape, the doctor's office is only one piece of it, right? So and that is true all the time. It is particularly true when we think about patterns of inequities, right? Because as long as you're looking upstream, then you have to think about the broader context. How do we think about clinical prevention, knowing that prevention has a much broader context?
Yeah, so I think one of the challenges is there's been a focus, in the doctor's office in just pure education. You say, okay, someone comes in and say, oh, you really should quit smoking, et cetera. And my experience is many times patients understand that they need to, when you have an unhealthy behavior, very few people say, well, I don't get enough exercise and I really want to decrease my exercise. They don't do that. So, it's usually because they might have two jobs they have to work at. They're just too busy to do this, or they step outside and like, I can't exercise in this environment. I need to go 5 miles to the baseball field where I don't know anyone to actually exercise there. So there's a tendency to think, okay, great, at the doctor's office, you tell a patient what to do, and then they go out and they do it. And if they don't do it, it's because they don't understand. But if you don't fix the environment, if you don't change the environmental situation, the economic situation, healthy food is more expensive. It's more costly if you want to eat fruits and vegetables. You can eat a lot of fast food. You could basically subsist on fast food for, every college student knows that, right? But it's more expensive many times to live these healthy lifestyles. So if there's economic barriers, environmental barriers, there can be social barriers. Even if you want to go exercise in a certain location, you may not feel accepted, or there might not be people that you relate to. So all these different things, if they're not fixed or addressed, it's hard to really have an impact.
So what's our role in doing that?
So I'm just sitting here thinking about Jack Geiger, who in his work in the Mississippi Delta around community health centers, and I practice in a community health center, talked about in the 60s and 70s as hunger being a social determinant of health, and writing prescriptions for food for the people that he was serving in those communities. So there's been we're finally coming around to Jack's genius in terms of thinking about how do we, within the clinical context, address social determinants of health. But the reality is that while we might be able to write a prescription for, a food pantry or exercise, and there's some incredibly innovative work that's happening around the country, thinking about how you can integrate that into the electronic health record and address the felt need at that moment in time. To be able to have the opportunity to be healthy, to have equal opportunity to be healthy, whether it's around crime, availability of parks and recreational facilities, we must actually, as those of us that are within this field, think, I believe, further upstream. It's important, but insufficient to think about it within the clinical context. We have to move further upstream, and that's where community voices can actually help us think about where are those levers, where are those places that we can actually keep moving. It's not good. Jack talked about hunger, 50, 60 years ago. So it may be in lifetimes, it may be over time that we need to be willing to look at this, but we need to get the perspective from the communities that we're hoping to serve with this work to understand how the environment that they're working and living and playing in affects their ability to avail themselves of clinical preventive services and all of the other things that happen outside of our offices.
I agree with the statements that have been made wholeheartedly. one of the early findings as we are looking for promoters of health to help explain some of the heterogeneity that we're seeing across Atlanta, one of the interesting findings early on is that communities, those neighborhoods that are like these mini blue zones, if you will, within the metro area, one of the key things that we see is that those communities have, residents in those communities respond positively to the question, how many get-togethers and how much social interaction characterizes your neighborhood. Those that rated high in answer to that question were the healthiest neighborhoods by and large. And that factor was at least as important as their sense of ambient crime, which was important, very much so, as the presence of or absence of availability of nutritious foods. Those things were important, but we were surprised that the leading indicator was this social networking within the community. And I think that speaks to the community voices point and your point that we're all embedded in systems. And if we have positive interactions, that these things can lead to downstream impact on health.
Yeah, so, yeah.
Can I just jump in? Thank you, Herman, for the work on that, but also calling it out. This idea of social capital and what happens between networks. So not solely the connectedness, but what are the resources that move between networks? I just want to also highlight the work by Brita Roy and Carly Riley in looking at community well-being and social capital as a sort of one of those anchor concepts and domains in community well-being is critical.
Yeah, I mean, I think you've all very nicely pointed out that both the sort of individual risk, but also individual resilience, and then understanding in the context of community and system connectivity, which both has elements of risk, as well as these community well-being and resilience and things that we could, that can be powerful forces for health. I'd love to, we have a question that's asking you each you're all leaders in your own areas. What's the most exciting thing or innovative thing that you're excited about when it comes to prevention, particularly as it relates to reaching more vulnerable communities and populations? And then we'll open it up to the audience.
Okay, I'll start. I think there are a lot of exciting things. One of my slides pointed to something that we call moyo, which is a Swahili term for heart. And it is aimed at engaging young people around healthful behaviors and information. But I think more generally, technology as an expander of the impact of the clinic or the physician or the nurse is a very important concept. And I think community health workers, individuals who are trained not to the level of nursing or doctors, but people who have high school educations. In fact, we even have high schoolers doing some of this, but who are assisted in delivering education, delivering screening ideas or strategies to the population. If they carry a cell phone that really, in a very simple way, takes them through steps in given situations for individuals who may be at risk for a variety of diseases, I think that's a very powerful thing. If we put that in the hands of people who may have high school educations, we amplify the potential impact for spreading preventive services or encouraging people to access those services.
Yeah, I like that one as well. I think just to amplify that oftentimes we think of technology that in more resource-limited settings is not applicable, and we found that it's easily both applicable and is actually a very cost-efficient way to scale. And so when it is adapted in the appropriate way.
So yeah, I would agree. My homeless patients have cell phones. I don't have to put it in their hands. They bring them with them. So the idea for me, of high touch and high tech, and how do we bring that together? How do we understand not only how we can how we can use it to support patients, but how can patients use it to connect with others? How can we think about social innovation within communities to, again, to address some of those more upstream ideas through technology? I think that the idea of how do we bring technology to bear on these upstream factors is really exciting to me.
So over the past decade, I've actually seen quite a significant shift in terms of the conversations, so past decade or two. I mean, it used to be a lot of focus was, again, the single cause, single effect, or, how do we develop a pill to address each of these different things, or, what's the magic diet, or what's the magic physical activity program. And there's an increasing understanding that these systems are actually involved. Like you literally can see the shift, through different federal agencies, through different organizations throughout the world, where you're starting to talk more about these systems and how do we fix these things. Part of the reason for that, I think, is we've had these intractable problems since the 70s and 80s. Obesity epidemic is one example. Non-communicable diseases going up. So people are, as a whole, realizing more and more, like single cause, single effect is not going to work. So you start seeing these movements to try to expand healthcare beyond the office, beyond the hospital. There's more talk of saying, okay, you really got to get to know the communities. You have to do situations. You have to figure out from patients, what's the status of your community? What's your social status? Asking more of those questions. And then I was also chatting with Vivek Murthy, who was the previous Surgeon General. He was talking about, the need to expand the definition of healthcare out to the community. And I think all of those movements, we're moving in the right direction when it comes to that. So that's exciting.
Great.
Yes, I see a theme here, because the thing that I'm most excited about as well is the opportunity for patients to develop meaningful community in virtual ways, be it online or on telephone apps. And that community is a place for support and education that is extremely meaningful to patients. And I'm excited that that's continuing to grow and improve.
Fantastic. Okay,
And
great.
I would just
Please.
thank you for that comment, Susan, and the other comments. The word community has been said over and over, and I hope that's not lost on anyone. The co-design of some of these interventions with community members, using principles that you might group together as community-based participatory research-type principles, but really seeking their input and having them shoulder to shoulder with you as you're developing these possible interventions is really critical, and something that we've emphasized, and I think to good effect in Atlanta.
Can I add one quick thing as well? Speaking about the merging of technology, I mean, we now have these methods and computational approaches that can really help us better understand these things. So really finding a way to leverage all these technologies, and that's really exciting. So we can see things which previously we're not able to see.
Right.
Can you give us an example?
So when we're building a lot of these computer models and these simulation models, now we have a lot more data available. We're in the era of big data. We've got things such as wearables and things like that, where we can really figure out what's going on. And then the computational approaches have advanced so that we can actually simulate what's going on, and there's more knowledge in terms of the actual behaviors and things like that. So all of that allows us to then, for example, create these simulation models where you can see what's actually happening, and then you can then target your efforts and build different strategies. So this whole space is moving forward. In fact, I was just in a couple other meetings here at NIH where we're discussing, how can you leverage technology, electronic medical records, and all these type of things. And I think that really dovetails with the discussion here.
Yeah, so sorry. We all apparently all excited about a lot of things. So, right. So in this space of system science work, group model building, participatory model building is another really exciting space where patients, other stakeholders are part of building these models so that they're actually reflect the reality and actually are more accurate in terms of predicting outcomes. So there's a lot of great stuff that's happening now.
Fantastic. That's wonderful. Okay, I want to make sure that we have time for the audience to, if you have questions.
My name is Li Yang. Thanks for your presentation. I have a question and also some comments. My question is, if the library or the hospital, they can provide the reading material, would that be helpful? Or why don't they do something like that with some kind of comment line or boxes so patient can really communicate with the health providers directly or indirectly? And my comments really say why recently, I think you know, some parents who really refuse themselves or their children to have vaccine, and maybe they really have experienced that some health provider didn't really provide the health. Instead, they are victimized the patients.
Thank you very much. So I think for the question, I want to make sure I understand. So you are asking us, our panel, to comment on the library or hospitals making educational materials available or ways to communicate with the doctor about their health.
Right.
Yeah. Do we have examples where that's been effective? I know in my own hospital, we've been very interested in the use of patient portals, right? So ways in which patients can engage with their doctors via essentially online way of communicating more directly. I work in a safety net setting, and patient portals, again, we start with the presumption that something this high tech is not going to work with our lower income patients, but actually we found that there are higher, we have to do more to educate, to get people comfortable in terms of these platforms. But once we do that, they've been actually very engaged. We've also worked with tech companies for exactly the same types of things. Again, there are lots of tools now for chronic disease management and to help patients think about managing their diseases, sort of at home. Again, the barrier up front, it takes a little bit more work up front to make sure that everyone knows how to use the platform, is comfortable using the platform. But in our experience, it's been really important, and in fact, it has really improved both on health measures, but also in engagement measures for lots of things related to prevention and management.
I would say you're right on sort of the cutting edge in terms of libraries as sort of trusted entities within communities, and there's a growing interest in how do we leverage that, not only the trust but also the information technology that often exists within libraries to reach communities around health prevention. So I've seen a lot of interest recently, and even our community academic partnerships, we actually meet in a library in the community. So it really speaks to the potential for that anchor organization.
So we're in a sort of a strange period where there's been an explosion of information that's available now online. So previously there was less information that was readily available to communities, and now there's an excess of information that's potentially available. So I think one of the challenges right now is, one is how do you curate that information, and then how do you identify, what are the trusted sources versus the not trusted sources. And then the third situation is some of these sources are written to particular people and do not resonate with everyone else. And the trouble is, then you have these messages on social media and the internet that are designed to resonate with particular communities that are not being included. But that might be information that's incorrect or spread with an agenda. So I think we're in a very interesting tipping point where the next steps is to really figure out how do you then make information that's reliable, that's backed by strong sources that's also understandable by all communities and resonate with them. So
Great.
It's a great question. If I can just, just reiterate what's been said. This isn't a hospital, but as a part of what we did in the Jackson Heart Study, and it's still ongoing, we had trained community health workers. So they became more like living brochures, if you will, about information, particularly regarding cardiovascular health. And the issue of trust that Giselle alluded to, and the issue of reliability that's also been mentioned, are really sort of, not completely necessarily in every case, but are largely addressed by having a human being who's well informed and who's tied into greater sources of information. So I think that model of having individuals, and some of our best community health workers in this regard actually were librarians, but there were other people of other backgrounds who we took through a series of informational sessions to help them learn about cardiovascular risk factors, and they in turn would have these small teas or get-togethers after church or whatever, where they answer questions, and when they reached a point where they couldn't answer a question, they had an immediate resource in the investigators of the Jackson Heart Study.
Great.
Good morning. I'm Robert Hahn. I lead a team at the CDC that conducts systematic reviews on health equity in public health. We've done this for the past 10 years. I have 2 points themes actually that come out of your discussion that will make your life, Dr. Bibbins-Domingo, more complicated in terms of talking to your colleagues. The first is what is the issue of what is prevention? And Professor Rucker Johnson has demonstrated that if you desegregate schools, he did a systematic study of 850 desegregation cases and showed that black kids who go to a desegregated school are more likely to finish high school, have better incomes, have better long-term health outcomes. Also, other studies have indicated that if kids graduate from high school, you promote as much longevity as you do by getting rid of tobacco. So I think we should think about prevention more broadly than immunization and colorectal screening. Not that we want to forget about those. The second point is what are the barriers, some barriers to prevention? And I think about a single parent in a racially segregated community who has 3 kids, and the transportation is terrible, and she's concerned about violence. She has a hard time getting her kids to places where she can get immunization. She has a lot of other things to worry about. I think we should think about barriers to prevention, not only in the health system itself, but much more broadly, or maybe we should think about the health system much more broadly. Thank you.
Yeah, thank you very much. I think your first point really speaks to what we've been talking about here, sort of the social structural factors that ultimately, the most upstream factors that ultimately determine health. And I think the second point you're speaking to is much more granular, sort of at that interface with the health system. So what do we need to know about more immediate social determinants, and what's the responsibility in clinical practice to sort of intervene to figure out how to make that better? I don't know who would like to.
Perhaps this may be a bit provocative, but let me introduce another, I think, complementary point of view. When we think of these social determinants of health, particularly the ones that you mentioned, like school desegregation, even just residential desegregation, as being these awful and powerful determinants of health, it begins to get a little bit overwhelming. These things historically have changed with a sort of glacial rapidity, right? And it's not even linear, okay? So you desegregate a school,
what happens 20 years later? It's resegregated, right? So it can be discouraging. One, we have to, I think, as a community of researchers and practitioners and patients, be constantly attentive to and vigorous in our attempts to address these social determinants of health. I mean, it's absolutely important. There's another thing, though, in the midst of all of this, through, 12 generations of slavery, Jim Crow, racial discrimination that is still apparent even today, there are remarkable examples of heterogeneity and positive outcomes. How does that happen? How does an African American man who is, say, 80 years old now get to the 80? How does he not have high blood pressure, given all of the travail he has experienced personally as a part of the black community? I think trying our best to understand those outcomes will potentially open up new insights, new doors for us to explore, because some people, in the words of the anthem of the Civil Rights Movement, overcame, right? What are the secrets there? Are they secret? Are they all behavioral? Is it all a psychological construct that we're talking about here? Or are there physiologic and other, even epigenetic underpinnings of that survivability? Because ultimately, the story of African Americans in the Western Hemisphere is really a story of survival, right? And despite incredible odds. Of course, there are disparities. But these examples of vigor despite that, or success despite that, I think bear investigation much more vigorously than we've done in the past.
Right. So somebody gave me a 5-minute warning, and I see for many people at the mic.
I think we just take as many as we can, and I know one of our panelists has a question, so I just wanted to let her chime in because it's hard for you to see, Kirsten.
Oh, perfect. Okay,
yep,
so
thank you.
let me, panelist prerogative here. So,
No, excellent presentation. And in the spirit of the focus of this particular initiative in achieving health equity in preventive health services, I want your thoughts relative to recommendations for future research. And given the fact that ultimately what we're trying to do is to identify, interventions, that are indeed effective for addressing the needs of the disparate populations, that's outstanding. But as you all have emphasized, there are challenges within our communities, challenges with the lived experience. And taking a look at a lot of the research that's been done in controlled environments, where many of these co-founders have been corrected and controlled for, that it doesn't reflect the reality of many of the individuals that we're speaking of, that we are talking of in these presentations. So ultimately, especially as it relates to the system's needs, and many of the disparate populations that we're focused on, they're receiving their health care in community centers, as you mentioned, federally qualified health centers, free and charitable clinics, and the Indian Health Services. So what are your thoughts relative to advancing science in these institutions as well as we're trying to reach these populations at greatest risk? That's a fantastic question. Thank you for it. My immediate thought is around multiple chronic conditions. When we were looking at the implementation of Premier, an NHLBI evidence-based intervention in Eastern North Carolina, Premier had very strict inclusion criteria. We shared that with our community partners, and they said there is absolutely no way we're going to find people with one cardiovascular risk factor. That's just not going to happen. We will not be able to recruit for this study. And so we had to loosen those criteria. So I think understanding that as we're thinking about disparity populations, that we must be thinking about multiple chronic conditions. Not only, and when it comes to prevention, as a clinician, each time I'm in clinic, have to make a decision about which preventive service am I going to advocate for amongst those multiple chronic conditions that are indicated. Which guidelines and how am I going to leverage that 20-minute, 15-minute visit to ensure that they have the best care, and that's not always clear in terms of what I can offer to patients. In addition to all of the other life factors that I have to deal with housing insecurity, food insecurity, home health aid, and all those other things.
Let me just say, I think we should be studying more in those systems where a large number of the populations that we're talking about are served. It doesn't mean that should be, they're not synonymous, right? So we need to be studying these health disparity populations in all of the many places that they are seen. But in the settings you're talking about, those are settings that also have their own sort of resource restrictions, resource limitations, other practice. So those are and in many for many populations, they disproportionately see the populations we're talking about, right? So I think that it's that overlap of the two that I think really we need to see more studies in those contexts. So the study that Eliseo alluded to, Kaiser getting 80% blood pressure control. So we decided to do that same thing in our safety net setting, right? We had to adapt every single thing that Kaiser did, but we worked with Kaiser to understand not how they did it, but what were the principles behind their approach to doing it. And then we went to our sort of stakeholders. So we're not Kaiser, and what do we have to do? And so we adapted every single thing to our patient population, to our insurance system, to the fact that many of our patients don't have insurance, to the fact that you can't start with diuretics if patients don't, have different schedules, have whatever. But we also achieved 80% control rate, right? And so that's what we have to have more of, I think, is to actually studies in the settings and the populations that we're talking about.
And then possibly even maybe some recommendations for future research that collaborates with research-intensive academic medical centers and these types of centers in future research, and possibly even making that as a strong recommendation.
That sounds, I see that as I would strongly recommend that.
It's more of an answer than a question. This is also a situation where you can actually combine systems methods with different types of studies, because the goal of the systems methods is to also understand the mechanisms and the drivers behind results. So as you mentioned, you do a study in one location, everything's set. Does that actually apply to other locations? You can use the data collected from different studies to then help inform the models, which can then you can run and figure out what are the key drivers and where's the information that's lacking. And then that in turn can then drive additional studies. So it's this iterative approach that can help us achieve better understanding.
So I got the sign that said stop. This has been a really wonderful conversation, and thank you. Sorry, I hope we can continue this all at the breaks, but please join me in thanking our panelists for listening.
We will restart promptly in 10 minutes. So we're just going to start, okay? And there are many restrooms, which I think we may need to use. Thank you. And thanks to the panel. This was great.
So are we?
Let me introduce Heidi Nelson from OHSU. And maybe somebody could wave at people talking outside the door. All right. Thank you.
Great. Can everybody hear me all right? No. How about now? Is this any better? Yes. Okay, great. I especially want the panel to pay attention to every word, because we're going to walk you through the evidence review, this is the first of 5 presentations that between me and my colleague Amy Kenter, we will be presenting you the evidence review that was commissioned for this workshop. My name is Heidi Nelson. I'm from the Pacific Northwest Evidence-Based Practice Center at Oregon Health and Science University, and it's a pleasure to be here. Over the next 2 days, you'll hear each piece of the evidence review as it relates to one of the 5 key questions. The first presentation will focus on the methods of the evidence review as well as the results of the first key question. I have no information to disclose. And before I start, I want to acknowledge the hard work of the other members of the Evidence-Based Practice Center team listed in this slide, and the input of numerous other individuals, which I'll show you in a few minutes here as we go through the processes. First, we'll go through the purpose, scope, and key questions of the review itself. The review serves two main purposes. First, to summarize research on achieving health equity in 10 preventive services for cancer, cardiovascular disease, and diabetes in adults by identifying the effects of impediments and barriers that create disparities and the effectiveness of strategies and interventions to reduce them. Secondly, this report was made specifically to inform this workshop on achieving health equity and prevention services. This topic is important to improving health in the United States, as described by some of the previous speakers. Overall, Americans use preventive services at approximately half the recommended rates. Also, it's widely recognized that access to and utilization of preventive health care differs across specific population groups. However, evidence about ways to reduce health disparities is often not available to inform clinical recommendations, particularly noted in the U.S. Preventive Services Task Force report, citing gaps in this type of research. The review reflects the input of many stakeholders and experts at several points in its development, and I'd like to point out that the scope and key questions were developed by members of an NIH planning committee. The systematic review protocol was finalized with input from non-federal subject matters experts, including a technical expert panel and a content areas expert group. Earlier drafts of the report have been reviewed by NIH and ARC partners and experts in the field. And now you have a chance, everyone has a chance to provide input, because the draft evidence review was posted today on a website, and I'll give you that link at the end of my talk. And it will be posted for a 4-week public comment period. And we welcome your input and your references and any other comments you have to make the review as useful as possible. The report uses current established definitions of health equity and health disparity. Health equity is the attainment of the highest level of health for all people. Health disparity is a health difference that adversely affects disadvantaged populations based on one or more health outcomes. The populations adversely affected by disparities are defined by definitions from the National Institute of Minority Health and Health Disparities. The earlier talk today outlined this very well. These populations generally include racial or ethnic minority populations, socioeconomically disadvantaged populations, underserved rural populations, sexual and gender minorities, and others subject to discrimination. So for the evidence review itself, we had a very open-ended definition of a population that might be affected. Achieving health equity and prevention is particularly challenging because nearly everyone in the population is eligible for a preventive service. And disparities can exist across multiple socio-demographic dimensions. The complexity of this issue is illustrated in an example of a clinical pathway for a preventive service in the conceptual diagram listed in this slide. Along the bottom part of the slide is the preventive services pathway. This first step involves gaining access to health care. After gaining access, eligibility for the preventive service must be determined by identifying risk factors or other criteria. These preventive services are intended for specific target populations, so we need to identify who belongs in that target population before moving on to the delivery of the prevention service. This needs to be followed up if there are any abnormal results or follow-up plans, and either a diagnosis of the targeted health condition or resumptive of routine interval screening is at specific intervals is indicated after that. Each step in this pathway represents a potential gap or barrier that might give rise to a disparity. And this could lead to inadequate prevention care for disadvantaged groups. Different preventive services would create variations of this pathway. So this is meant to be a generic example, but you can plug in practically any type of clinical service and create a pathway that's unique to that and find out where the gaps would be for that particular one. Successful navigation of the preventive service pathway is also subject to multiple levels of influence that are shown by the arrow coming down the side of the slide. These include those at the societal, health system, clinician, and patient levels. So with this conceptual diagram in mind, the review addresses 5 key questions on achieving health equity and prevention services rated to 3 high-burden diseases in the United States: cancer, cardiovascular disease, and diabetes. This is a thin slice of the whole issue, And so I want to, at the beginning, point out that the evidence review is one deep dive into one small part of the problem, but it's an important slice of the problem. So as I describe what the evidence review did, we're certainly well aware and keep in mind that it's part of a much bigger picture. But the specific preventive services that were chosen to be evaluated are based on 10 A or B level recommendations from the U.S. Preventive Services Task Force. These recommendations establish standards of care for clinical practice and are covered without copay or deductible charges for most public and private insurance plans under the Affordable Care Act. The first two questions evaluate the effect of impediments and barriers to preventive services. They focus on provider-level barriers for key question 1 and population-level barriers for key question 2. The next three questions are about the effectiveness of interventions to reduce disparities. These include interventions centered on clinical providers and patients for key question 3, and health information technologies and digital enterprises for key question 4. Key question 5 focuses on healthcare organization and systems interventions. So you'll see those in separate presentations, with some of these being presented tomorrow. In order to answer these key questions, we need to clearly define the scope of the review. So one way to do this is to look at the different levels of disparities research, which is often categorized into 3 phases. These include the first phase studies that show disparities exist, and these types of studies are not included in this review. This is a big important literature, but this is outside the scope of the review. What we're doing here is to look at second phase studies that actually explore potential causes of disparities, where we're looking for effects of these disparities. And so these are reviewed in key questions 1 and 2 on impediments and barriers. The third phase research involves studies that evaluate interventions to reduce disparities, so these fall to key questions 3, 4, and 5. The analytic framework for this review illustrates how the populations, interventions, and outcomes relate to the key questions. It essentially is a big picture view of the project, kind of a roadmap for the systematic review and how these questions were addressed. So at the far left side of the screen, you'll see the target population, and I'll define those for you in a minute. All the arrows indicate steps of interventions or actions to reduce disparities, and then the boxes indicate outcomes that are measured. So we have the more intermediate level outcomes, and these are measures of access to preventive services. So they're more at the front end of that preventive pathway I showed you. And what we're looking for here are studies of rates of screening and follow-up procedures, utilization of services, behavior change, improvement in some intermediate health outcomes. And then finally, in the box at the far end, are health outcomes, which are also looked at in the systematic review that measure disease-specific incidence, morbidity, mortality, function, quality of life, and any other relevant health outcomes. And these are often the stronger studies to show that an intervention leads to actual improvement in health. So we're looking for those as well in this systematic review. The included services and populations are listed in this slide. I think one of the previous speakers listed the services. There are 4 preventive services related to cancer screening, including colorectal, breast, cervical, and lung cancer. And the target populations for these groups vary by age, and some are specific to women, breast cancer screening and cervical cancer screening. Lung cancer screening is specific to adults with a heavy smoking history. We also included behavioral and pharmacotherapy interventions for tobacco smoking cessation in adults, aspirin use to prevent cardiovascular disease and colorectal cancer in adults, specifically aged 50 to 59 years with more than a 10% 10-year cardiovascular disease risk, which is a very specific targeted group. Healthful diet and physical activity, behavioral counseling for CVD prevention in adults with risk factors. So these are adults with obesity and other defined cardiovascular risk factors. High blood pressure screening in all adults. Abnormal blood glucose and type 2 diabetes screening for adults aged 40 to 70 years who are overweight or obese. And finally, screening for obesity in all adults and management of obesity in adults who are overweight or obese. So as you can see, each target population varies a little bit with each preventive service. So the next step in defining all of these factors, the scope of the review and the analytic framework and looking at the questions, is we create inclusion criteria. And these more explicitly define the population, which includes all the patients from those target populations for the 10 preventive services, but they're also those who are adversely affected by disparities. So immediately that focuses our search in the literature for papers to those populations. The interventions are those to reduce disparities in use of 10 preventive services. Comparators are the types of comparisons in studies. So to look at effects and effectiveness, we need to have comparisons between interventions or no interventions, or looking at populations that are adversely affected by disparities versus those unaffected. So we're looking for effect sizes there. Our outcomes, as we described in our analytic framework, include those intermediate outcomes that look at rates and access, and then those clinical outcomes, incidence, morbidity, mortality, the rest of those. And those, of course, depend on the prevention service itself. For the timing, we talk about any kind of follow-ups, duration of follow-up in different studies. And we want to make sure each study is relevant to current practice. We don't want to find studies that have practices that are no longer part of current standards of care. And the setting is broadly applicable to U.S. primary care. So those criteria are very important as we select abstracts and papers and include studies in the actual report. We defined impediments and barriers in kind of a broad sense. A barrier is a factor that blocks access to or completion of a preventive service. An impediment complicates or delays access to or completion of that service. Dividing up a barrier or impediment as to whether it is a provider barrier or a population barrier is sometimes very clear, but oftentimes not. So teasing apart the study to see what the intention was and what the measures are, were the measures obtained from patients or were the measures obtained from providers, makes that a very difficult literature to sift through. Eligible studies for key questions 1 and 2 reported the effects of barriers and impediments, so that phase 2 type of research, not just their association. So studies were examined if the barrier or impediment resulted in or explained differential use of preventive service. So those were a very specific type of study that we were looking for. Finally, we tried to clearly define the settings for different interventions to occur. The U.S. Preventive Services Task Force are generally intended for primary care practice settings, although the task force describes primary care in a very broad sense at times as well. Studies of the effectiveness of clinician-patient interventions, which is key question 3, were differentiated from studies of the effectiveness of health system interventions, key question 5, by having a major component of care in the clinician's domain. Maybe there are other parts of that are in the health system domain, but the main point is in the clinician's domain, so that was a bit of sorting with some of those studies. And quite honestly, some could fall in either direction. Interventions occurring outside the healthcare settings were only used if they had direct connections to healthcare settings or clinician settings. And these were the direct links were more defined by the solid line arrows. An indirect link was also considered if it actually did lead back to a referral or some connection back to a health system. There, as mentioned in the previous discussion, there's a big body of research of community research that doesn't connect to a health system. For the purposes of this review, those were not included. This is primarily a review looking at any studies that connect to the health system enterprise, the clinician domain as well. So just to make that clear, that's another big body of evidence and could well be another report. Okay, the reviews follows standard methods for systematic reviews. And briefly, this includes a research literature search that involves a strategy developed with research librarians, reviewed by a second librarian, goes to the usual large databases. Our dates include January 1st, 1996 to mid-July of 2018. We're doing an update in a few weeks, so the final version of our report will include more papers. We're already finding some that will probably be included. So what you see today and what you can comment on is the most recent draft. Secondary searching was also conducted to look at other studies. We had independent dual review of abstracts, the articles, and the articles themselves using those predefined inclusion criteria. Data were abstracted into evidence tables that are available in the review itself and dual reviewed for accuracy. And then there was dual independent review of the study quality and applicability of each study using established criteria. Now, you'll be seeing some grades of evidence in some of the tables of results that we'll show you. The grading is based on several characteristics, and what the strength of evidence actually means is how confident are we that the results are actually the truth. So a high-level grade means that we're very confident the effect is true. Another study probably won't change things. Low would mean a limited confidence, that we need more evidence, and insufficient would mean no evidence or no confidence in the evidence. Grading applicability includes these characteristics. High applicability means that the results of studies apply widely to the United States practice. Low means it could apply to some populations, and so it's still valuable, but it's limited in its applicability. We also did statistical meta-analyses. We won't be showing these studies till tomorrow, and I won't go through the methods in much detail, except that we used established standards, and it's very well described in our report. And so meta-analyses statistically combine results of studies to create summary results, which are sometimes easier to interpret. So we identified over 16,000 abstracts. We reviewed 1,800 full-text articles and ended up with 84 articles of 80 unique studies. The studies mostly zeroed in on colorectal, breast cancer, and cervical cancer screening. There were very few studies of other prevention services. And for key question 1, which is the effect of impediments and barriers on the part of providers, if you were paying attention to those earlier tables, you might have noticed we found no studies that met inclusion criteria for key question 1. There were many studies of provider factors that influence treatment decision, but not those 10 preventive services. There are studies on patient factors, and we'll talk about that this afternoon. And there are also many first phase association studies. So future research needs are kind of obvious. We need research to fill this gap. There are not studies that show the effects of provider barriers on these prevention services as we've drafted in the inclusion criteria. So I think my time is about ended. I wanted to point out our full evidence report is available at this website, and I encourage you to give us some comments so we can make this report even more useful for you. Thank you.
I'm Carol Mangione. I'm a professor in the School of Medicine and the School of Public Health at UCLA, and really appreciate this opportunity to talk to you about provider and health system barriers to the delivery of preventive services. After coming behind Dr. Nelson's talk, you could think my talk is going to be very short, right? But I have the liberty of maybe making some extrapolations and using some lower quality evidence, and so I will give that disclaimer right off the bat. I do not have any conflicts. I do want to mention that I am a current member of the United States Preventive Services Task Force, but this presentation solely represents my views and policies and not those of the task force. I'm also a practicing primary care doctor and a little burned out and a little beleaguered, and as I go through the physician level barriers, you may get a hint of some of that. So I'm going to first give you a definition of the preventive services and the Healthy People 2020 goals that we're trying to achieve, and then talk about some variation in use of preventive services, and you heard a more detailed presentation of that earlier today. And then I'm going to summarize what's known about provider and system level barriers, and then make some kind of high-level recommendations, because you'll really be hearing more about the evidence-based recommendations tomorrow. The one thing about my talk that I want you to keep in mind, and that's that Dr. Nelson clearly indicated that when we look for high-quality studies, very little has been studied in the space of the drivers of physician barriers or system barriers for not delivering preventive services. So I went to the literature looking at what are the barriers to access to primary care. So you're going to need to make a bit of an extrapolation. If someone can't get to a primary care visit,
I'm going to hope that you'll agree with me that they probably aren't going to get a clinic-based preventive service. So I'm allowed to make that extrapolation because I'm not in the framework of the evidence review. So what are we talking about? Mainly I'm going to focus on clinical preventive services, and these include immunizations, screening tests, and counseling, as noted before. And a lot of this literature on care delivery actually is more in cancer prevention and immunization, so that will be the focus of the talk. We know that there are gaps for certain populations who are socioeconomically or environmentally disadvantaged. We know that low income and ethnic and racial minorities, as well as people who live in rural or remote areas, are less likely to receive these services, so I won't be going over that ground. But we also know that the elderly, especially the elderly who are low income and live in rural areas, are less likely to receive these services. So age in and of itself is a risk, and we're going to have many older people in the next decade or so. So what are the Healthy People 2020 national objectives for delivering preventive services? And I would say these are relatively modest goals. I mean, right now, we know that only about half of the services that this population should get are being received. And so what is being proposed is a relative increase of about 10%, or an absolute increase of about 5% for men and women who are in this age group. And the core services for this age group are 4 immunizations, as shown on the slide, screening for lipid disorders, colorectal cancer screening, and breast cancer screening in women. So we have low rates of use of preventive services overall. Only 25% of adults between 50 and 64 years of age in the U.S., and less than half of the adults over 65 are up to date on their screening recommendations. So I think as we think about disparities, realize that we're thinking about it in a context where we're not doing a very good job with anybody, right? And this is really true, despite the fact that these services are paid for nearly by all insurance plans, including Medicare and Medicaid. So we're really talking about those grade A and B level services that are a covered benefit because of the ACA. But even with that overlay, we know there are persistent and significant racial and ethnic disparities on getting vaccinations. So, for example, 44% of African Americans report not receiving influenza vaccines compared to 29% of whites, for an absolute difference of 15%. We also know that for other groups, such as Hispanics or Native Americans, that the difference is about 10% in those groups too. I'm going to talk a little bit about cervical cancer disparities, because this is really an example. Again, as a primary care doctor, we can pay for a preventive service, such as cervical cancer screening. But if the downstream costs of treatment aren't paid for, we've done little to bend the curve on health disparities with regard to cervical cancer. So, I think as we think in this prevention space, fixing the gap in prevention will not fix the gap in healthcare delivery for some of the cancers that we know of that have good evidence-based treatments. And so, I think we want to keep that in mind. So we know that mortality rates from cervical cancer among African American women is more than twice the rate observed for white women. And yet we're getting very close to having the same screening rate. So why is that? So we know that there is inadequate follow-up after screening, and we also know that it's possible that African American women may have potentially a more aggressive form. We also know that Native American women have higher rates of cervical cancer mortality than the U.S. average. In this population, it looks like lower screening rates is a bigger contributor than it is with African Americans, but there also is inadequate follow-up. And we know that Hispanic women have significantly higher incidence and slightly higher mortality, especially for Hispanic women who live in underserved areas, such as the Tex-Mex border. So white women in geographically isolated areas and underserved areas also have higher mortality. So again, this points to things outside of the healthcare system, such as income, rural areas, geographic isolation as drivers of some of these disparities. Insurance coverage plays an important role in access to screening. 23% of women without health insurance and 25% with no regular source of care report that they didn't receive a pap smear in the last 5 years. And this compares to 11% in the general population. So again, that primary care extrapolation, if you don't have a usual source of primary care, whether you're insured or not, you're much less likely to get these services. So what about colorectal cancer screening? We know that male sex and Black race is associated with higher colorectal cancer incidence and mortality. Black adults have the highest incident and mortality rates compared to all the other groups. And studies have documented inequalities in screening, but also in diagnostic follow-up and treatment. And so this is important to keep in mind. So what are the barriers to colorectal cancer screening for African Americans? And this is a result from a systematic review that used more liberal criteria than our evidence-based centers. But we know that provider-level barriers include poor knowledge of patient barriers, such as fear, patients' lack of knowledge about the potential benefits of screening, and competing demands for time. This systematic review also identified that providers were confused about the age threshold for initiating screening. And I would say, in general, as a primary care doctor, oftentimes faced with a 15-minute visit and a lot of competing activities for that visit, that my own knowledge deficits often are a barrier to getting timely preventive services to patients. And we have not developed the systems to help primary care doctors do that better. We also know that there's insufficient patient counseling. There are system factors too, though, such as inadequate health insurance coverage, and this was particularly true pre-ACA, and high out-of-pocket costs for patients. We know that patients who come to fewer PCP visits are less likely to get preventive services, and we know that patients with poor access to specialists are less likely to get preventive services, as is lack of care coordination. What about breast cancer mortality? We know that white women have historically higher incident rates than African American women, but the incidence rates have become closer recently. But about 30% more African American women die each year from breast cancer than white women. So we have similar incidence, but different death rates. So why is that? And again, we don't have really clear evidence of exactly why this is. There is some signal that there may be a difference in biology, that African American women are disproportionately affected by more aggressive and treatment-resistant forms of breast cancer. But there also are socioeconomic differences and greater health system failures, such as delays in care, inappropriate treatment, or no treatment at all for many African American women. The USPSTF notes that African American women are also substantially underrepresented in randomized controlled trials of mammography. So we don't know that if we had more aggressive or more frequent screening in this population that clearly does poorer with the disease, whether that would begin to mitigate the disparity. So this point was brought up earlier, and I really want to emphasize it, that when we're in a situation with no evidence, and when we have to extrapolate from one population to another, that we're really at risk for drawing the wrong conclusions. And so this is a big evidence gap. We really do need better studies of mammographic screening in African American women. So what are the system level barriers? So I'm going to start with health insurance, because health insurance is so important. And here you can see that at baseline, about 83% of persons in the US in 2008 had health insurance. And certainly since the ACA, we've seen better coverage, and you see that here in this picture, but you also see variation by race and ethnicity. So the ACA lowered the cost of covering routine preventive services that are graded A or B. Basically, they're no cost, and lowered the cost for recommended immunizations. But the problem is that tests and procedures to evaluate a positive test result, costs are not lowered. And we know especially that we're having, really an epidemic of high deductible health plans that are creating a barrier in this country for many people, even with health insurance, to be able to afford treatment. What about barriers to healthcare utilization among publicly insured persons? So when we look around for evidence of this, there is a statewide survey that was done in Minnesota, and it had a 44% response rate, so not wonderful, but at least some evidence. And the goal of the survey was to estimate the effects of perceived patient, provider, and system-level barriers on past year delayed, foregone, or lack of preventive services. And in this survey, 29% of people had delayed needed care. 14 additional percent had foregone needed care. And 24% had not had any preventive services during the past year, not one of those 10 services. Rates of delay or foregoing care were highest for American Indians at 56% and for U.S.-born blacks at 50%. Perceived racial, gender, or socioeconomic discrimination were all associated with delays in foregone care, as well as lack of delivery of preventive services. Again, this type of a study doesn't meet the quality grade needed for to be included in an evidence review, but it's showing us a signal. And I think that it really is that call for better studies that can really close the information gap and can determine whether these lower quality studies with lower response rates are actually hitting at the right signals for how to address disparities in preventive service delivery. On this slide, we're comparing the use of preventive services for people who are insured versus uninsured. So the first ellipse shows you that there was a smoking cessation discussion for 59% of the insured people, whereas it was 32% for uninsured people. In terms of influenza vaccination, 44%, which is really quite low compared to what we would like to see, but compared to a striking 14% among uninsured people. So having health insurance matters. I probably don't need to tell this group that. But we still see, pretty persistent gaps in terms of immunization rates by insurance status. And, why is that? Because there are free places to get immunizations. Well, if you don't have insurance, I would say as a primary care doctor, you're unlikely to have a usual source of care unless you're lucky enough to be nearby a federally qualified health center or some other good safety net clinic. And I think that may be one of the drivers here. So this study really tried to look at, did uptake of mammography and colorectal cancer screening change after the Affordable Care Act for fee-for-service Medicare beneficiaries? And this is a Medicare claims analysis that identified women over the age of 70 who had not had a mammogram within 2 years, and men and women over the age of 70 at increased risk for colon cancer who had not had colonoscopy in 5 years. So these are people on a previous study were in that category where they should have had a 5-year follow-up. And for mammography, rates of uptake were lower for the lowest socioeconomic status quartile. And post-ACA, the disparity was smaller, but it still existed. For colon cancer, both in the pre- and post-ACA periods, there was an association between uptake and educational status. But there were not any changes with colonoscopy use by socioeconomic status. So there's something bigger than just insurance going on that's really driving this. And I think you heard the earlier speakers really talking about the multifactorial nature of this and the likelihood that we will have to intervene on many factors simultaneously to solve these problems. In 2017, the National Academy of Medicine and the Office of the National Coordinator for Health Information got together to identify barriers for clinical decision support. And they came to the conclusion that there was a lack of reliable shared clinical decision support content and capabilities that could be easily adopted across organizations, and that there was an absence of systematic means to validate content for provision across delivery venues that was reliable, and that there were many technical difficulties. You're going to hear more about what can be done in this space later on in the conference, but I think this is a system-level barrier to care delivery that we all need to keep in mind. So other important barriers, and this is really where we do have a gap in the evidence base, is that we really don't have an easy way to identify which patients need which services. And we don't have a way to do this quickly in most settings that have electronic health records. And I would contend, as a primary care doctor, that since the onset of the electronic health record, I have less time to look for this in the chart and to actually identify where people have gaps, because now I have many competing demands that are foisted on me by the electronic record, which takes up those precious minutes. So rather than the EHR of today helping most of us deliver these services better, I would say in many settings it hinders us. And we're going to have to tackle that with interventions and study those interventions to be able to make any progress. We really lack simple tracking to identify those who've received services, and in many systems, we don't have good ways to track when abnormal results from preventive tests happen. So the lack of primary care workflows also that engage allied health professionals to take some of this burden and make it shared at the practice level, rather than having this bottleneck where everything goes through the PCP, are going to be needed if we are going to be able to really address these gaps. So what about providers? Why don't more people get preventive services? Well, as mentioned, many healthcare providers lack systems or fail to use systems that track patients, that contact patients to remind them that they need services, that have systems in place to remind themselves when they need to deliver services, or to make certain that patients understand why they need services. So provider-level barriers, and again, these came from lower quality studies, but time is mentioned a lot, competing priorities, implicit racial bias, and lack of knowledge. Facilitators of delivering services are mentioned a lot too. Community-based resources, redesign of workflows. I'm going to wrap up here and skip over this. You can look at this study yourself, but the role of trust is clearly critical. And I would say that in most care settings, as time pressures have increased, it's harder to establish trust. So possible solutions, I'm going to leave for others to discuss, since we will have other sessions about that. And I'm going to just wrap up here so that I don't step on the time of my other panelists. So thank you very much for your attention.
So good morning, everyone. I'm Raquel Greer. I'm a general internist and health services researcher at Johns Hopkins, and I'm also a core faculty member in the Center of Health Equity at Johns Hopkins as well. I have no disclosures. And during my talk today, I'll describe the benefits of effective patient-centered communication in primary care, particularly among disadvantaged populations. I'll review the disparities that have been described in patient-centered communication. I'll also spend the bulk of my time discussing the key clinician factors contributing to these disparities. And then I'll briefly review some of the strategies to enhance patient-centered communication. And I'll conclude by providing directions for future research. So there's greater emphasis that the care be patient-centered, and that patient-centeredness is a key strategy for reducing disparities and improving healthcare quality. And it's defined by the Institute of Medicine as providing care that is respectful of and responsible to individual patient preferences, needs, and values, and ensuring that patients' values guide all clinical decisions. And patient-centered communication is a key component of patient-centered care. So what do we mean when we say that communication between a patient and their provider is patient-centered? Well, patient-centered communication aims to achieve 4 goals. It aims to elicit and understand the patient's perspective, their concerns, ideas, their needs, and feelings. It also aims to understand the patient within his or her unique psychosocial context. And it also aims to achieve shared decision-making, reaching a shared understanding of the problem and its treatment with the patient that is aligned with their values, and also inviting patients to be active participants in medical decision-making to the degree that they wish. And there's been increasing evidence to demonstrate that a consistent and effective patient-centered communication in primary care is associated with important outcomes. It leads to improved patient knowledge and recall of information that is shared during the visit. It also improves patient self-management behaviors and continuity of care. It's been shown to lead to greater patient satisfaction and trust in their providers, as well as important health outcomes related to emotional health and chronic illness control, such as hypertension and diabetes. And it's also been shown to improve the receipt of preventative services. However, these results or these findings are concerning when we know that disparities exist and have been described in patient-centered communication. And they've been described by ethnicity, race, by health literacy, language concordance, and also by racial and social discordance. And I'll review each of these briefly. So racial disparities in patient-centered communication are well documented. This figure on the right is from a study conducted by Rachel Johnson and Lisa Cooper and colleagues at Johns Hopkins, where they recruited 450 patients and used audio-taped and questionnaire data to assess differences in the quality of patient-physician communication during medical encounters and to see whether or not there were differences between Black and white patients. And what they saw was that even though the duration of the visits were the same, when they looked at physician verbal dominance and physician patient-centeredness, there were greater physician verbal dominance, meaning that providers were doing more information giving and talking the majority of the time, and lower physician patient-centeredness, meaning less engagement of patients during visits among African-American patients compared to whites. They also found that among African-American patients and their providers, that there was lower positive affect scores and rapport building compared to white patients. And these findings have consistently been demonstrated in a number of studies. Low health literacy and limited English proficiency are also barriers to high-quality patient-centered communication. Due to their limited health literacy and English proficiency, they're less engaged in care. And this was nicely illustrated in a study by Suter and colleagues of 771 outpatients with diabetes and or cardiac disease in safety net settings in San Francisco. And the investigators here categorized patients on their health literacy status at the top of the figure. So patients with adequate health literacy are represented in the gray bars, and patients with limited health literacy are represented in the black bars. And patients with limited health literacy had higher ratings of reported poor communication with their providers, including poor comprehension of physicians' instructions and poor interactive communication. They also categorized patients based on their language category. So they looked at patients, native English speakers, which are represented in light gray, Spanish concordant visits, which are represented in dark gray, which is Spanish-speaking patients seeing Spanish-speaking providers. And they also looked at visits with Spanish discordance, where there were Spanish-speaking patients with providers who were non-Spanish speaking. And what you see again here is in those Spanish discordant visits that there were higher rates of poor communication. And low health literacy and limited English proficiency have also been shown to be associated with lower satisfaction with care. There's also been systematic reviews that have shown that racial discordance between patients and providers is a consistent predictor of poor patient-centered communication. So race discordant visits, where patients and providers are of different races, tend to be shorter, have less positive affect, more information giving, and less partnership building or engagement of patients in that care. In addition, social discordance across multiple characteristics, such as age, gender, race, and education, also has been shown to have cumulative negative effects on patient-provider communication and patients' perceptions of care. And ethnic minority patients also perceived more biased treatment in healthcare settings. This table is from data from the Commonwealth Fund Healthcare Quality Survey, where they asked participants their perception of bias in healthcare systems. And they asked them the extent to which they agree with the following statements. I would have received better care if I were of a different race, ethnicity. I was treated unfairly based on my race or ethnicity, or I was treated unfairly based on how I speak English. And compared to whites, which are represented here in these red numbers, Black, Hispanic, and Asian patients all reported higher rates of perceiving more biased treatment in their health care. And all of these comparisons were statistically significant. So I've demonstrated that there are disparities in patient-physician communication on a number of different factors. So what are the key clinician factors that contribute to these disparities in patient-centered communication? Again, during this talk, I'm going to focus on clinician factors, including cultural competency, communication skills, and implicit bias. Medical knowledge or limited medical knowledge can also impact the degree to which providers engage patients in decision-making around certain topics. But what I want you to make clear is that multiple factors influence the quality of patient-centered communication during a medical encounter. There's patient factors, including their characteristics, their attitudes, beliefs, and their preferences and involvement in care, as well as system factors such as limited visit time, workforce diversity, and limited resources such as access to available interpreters also influence how well providers are able to build effective partnerships with their patients. But during this talk, I'm going to primarily focus on those clinician factors. So provider cultural competence, their ability to effectively care for patients with diverse populations, has been recognized as a key strategy to reducing healthcare disparities. And it's defined as the ability of individual healthcare professionals to establish effective interpersonal and working relationships with patients and each other that supersede cultural differences. And this concept of cultural competence also extends to the healthcare system, the ability of organizations and the healthcare providers within them to understand and respond effectively to the cultural and linguistic needs brought by patients to the healthcare encounter. And this includes availability of services to address those social needs, availability of interpreters, as well as availability of written educational materials that are culturally, linguistically, and literacy appropriate for the populations that they serve. And studies have shown that cultural competence is positively associated with the quality of patient-physician relationship and outcomes. For cultural competence, patients and physicians with more culturally competent attitudes and behaviors are more satisfied with their medical visit. They also perceive providers engage them in care, and there's also early evidence that they receive more equitable care and outcomes. In terms of linguistic competence, that is using medical interpreters or provision of care by bilingual healthcare providers, has also been associated with improved patient satisfaction, fewer utilization disparities, as well as more receipt of preventative care, such as receipt of colorectal cancer screening. However, providers are often ill-equipped to deliver culturally competent, patient-centered care. This big table on the right is of a survey of over 2,000 residents in training from U.S. academic medical centers. And in this table, describes the proportion of residents who reported receiving little or no instructions in cross-cultural care. And the percentages here that they report are actually quite high. Residents felt unskilled to provide many aspects of cultural competent care. And just to name a few, it included difficulty assessing patients' understanding of their illness, negotiating the treatment plan, identifying decision-making structure, and working with an interpreter. And the challenges that they face is that they often, once they leave medical school, really report suboptimal training. And this is true for attendings and healthcare trainees. And there's also a lack of role models or mentors to improve their skills in this area. Also important is that communication skills also deteriorate over time. And if many of these providers are receiving their skills in medical school, you can imagine that they've degraded somewhat by the time they're on faculty. Also, providers report poor access to resources, particularly availability, easy access to interpreters, or sufficient time during these 15, 20-minute primary care visits to really deliver culturally competent care. Clinicians also experience communication difficulties during cross-language encounters. For example, this is a cross-sectional study of 194 outpatient clinicians in San Francisco. And what they found was that when using an interpreter, 85% of clinicians, so most of them, were satisfied with their ability to diagnose and treat disease. But fewer were satisfied with their ability to empower patients. And this figure on the bottom just describes some of the problems that clinicians reported hindered their ability to provide quality care during the encounter. And just to focus on the top three, they reported trouble eliciting exact symptoms, trouble explaining treatment, trouble eliciting treatment preferences. So again, difficulty with empowering patients. And you can see how during these encounters with patients with limited English proficiency, how it may be difficult to achieve shared decision-making. Also, there's underutilization of interpreters. And some of the commonly reported barriers to interpreter use include under-recognition of patients' language needs in advance. And for that reason, there's often reliance on ad hoc interpreters, so families and friends, to do the interpreting during medical visits, or reliance on providers' limited language skills. Also, time constraints and inconvenience also make it challenging to use interpreters appropriately. The final patient clinician factor that I'm going to mention is related to implicit bias and the way it may also negatively impact patient-centered communication. Implicit bias is defined as unconscious associations that may negatively influence providers' clinical judgments and decision-making. And the figure on the right is a conceptual model of how implicit bias may negatively influence hypertension control among disadvantaged populations. So for example here, the clinician may be seeing a patient, an African-American patient, who is on a number of hypertension medications to control their blood pressure. But during their visit, they note that the patient's blood pressure is elevated. The provider may perceive that the patient may be resistant to adding another medication, or that it may erroneously think that that patient may have difficulty paying the copay for that particular medication. So they decide, I'm not going to intensify their blood pressure management during this visit. And they may think that they actually came to the best decision for that patient given the context, and may not realize that that decision that they came to was based on this unconscious bias. And there's evidence to show that that has consistently been demonstrated that providers have these implicit biases, including by race, ethnicity, and by socioeconomic status. And it negatively impacts patient-provider interactions, and it's also associated with lower patient satisfaction with care and provider trust. So what are the strategies to improve delivery of patient-centered and cultural competent care that really target these clinician factors? One is that patient-centered communication skills are learnable. Providers can be taught how to appropriately gather information from patients using open-ended questions, or educating and counseling patients by providing information in short, clear statements and utilizing the teach-back method to assess patients' understanding. Also, they can be taught how to engage patients in problem-solving and decision-making during visits around the various medical decisions, and also to build rapport and emotionally support patients during visits. In addition, patients can also be taught skills and how to better engage during the medical visits, how to ask questions, express their opinions, and share their feelings, and feel more confident in doing so. And there's been a very nice systematic review that summarized the evidence regarding the effectiveness of interventions to promote patient-centered communication. These interventions have been shown to consistently improve provider skills in patient-centered communication, but the results are mixed on intermediate and clinical outcomes. But there is promising news in that interventions that target both patients and providers and also include condition-specific educational materials. For example, materials specific to colorectal cancer screening have beneficial effects on patient satisfaction, their behaviors, and their health status. There's also been a number of systematic reviews related to the effectiveness of cultural competency interventions. Much of the work has focused on interventions targeting provider education and training, and those have been shown to consistently have a positive effect on provider knowledge and attitudes and patient satisfaction with care, but there really hasn't been, does not demonstrate an effect on other immediate outcomes or on treatment outcomes. Fewer studies focus on interventions to empower patients to be active participants in their care, but those studies that have evaluated this, again, have been shown to improve patients' perceptions and satisfaction with care, and there's some evidence that it may improve healthcare utilization or adherence behaviors. But again, there hasn't been any evidence to show that it improves clinical outcomes. And it's really important to note that none of these studies really evaluate the effect of culturally competent interventions in reducing disparities. And the final strategy I'm going to talk about is in regards to implicit bias, and I'm just going to touch on it briefly because this is an area that hasn't had as much attention as patient-centered interventions and cultural competency training. But strategies to improve or reduce the effect of racial bias really focus on providing physicians with training to help them be aware that they have these unconscious bias and have the skills to navigate that during the medical encounter. Also, patient registries and computerized decision support may also help reduce bias by not only helping to identify patients who have gaps, but also prompting providers during the visit to let them know that those gaps exist and that they should engage the patients in clinical decision-making around those gaps. So to conclude, patient-centered communication is a key mediator to improved health outcomes. Hopefully I've demonstrated to you that clinicians have experienced limited training in cultural competence. They have suboptimal skills in patient-centered communication, and unconscious bias all hinder development of effective patient partnerships, particularly among disadvantaged populations. Clinician and our patient-targeted interventions to promote delivery of patient-centered, culturally competent care hold promise for improving patient attitudes and skills and patients' perceptions of care. However, evidence is limited regarding the impact on clinical outcomes and on, importantly, whether or not these interventions reduce disparities. What I also want to mention is that most studies that assess patient-centered communication occur during a single encounter, and commonly used process measures are limited in their ability to really capture the dynamic nature of patient-provider interactions, understanding the context in which these medical encounters occur, as well as the nonverbal communication that may occur that may also influence the quality of patient-centered communication. So in terms of key recommendations, in order for there to be high-quality patient-centered communication and for that patient-centered communication to be equitable, interventions really need to be multi-level. They really need to target both patients, physicians, and the healthcare system. They need to be transdisciplinary and theoretically based to ensure that you're targeting the right behaviors and then ultimately also assessing the right outcomes. In addition, use of mixed method longitudinal research designs that use valid patient-provider communication process measures are needed to account for the dynamic nature of patient-provider interactions. And finally, rigorous research describing the impact of interventions on disparities and the cost of those interventions would help to inform practice and policy. Thank you, and I look forward to the discussion.
There we go, wired for sound. So good morning, everybody. I'm Michael Parchman. Thank you for inviting me. It's an enormous honor and pleasure to be here today. And I want to thank the conference organizers for including me in this group. I was asked to speak about creating solutions for health equity in preventive services in rural areas. As prior speakers have said, I'm not sure I have many answers. But I think I have some promising directions that I'd like to point us in. Is this the clicker? Yes. So I've got no information to disclose. Here's what I hope to speak to you today about. We're going to talk a little bit about health equity and rural disparities. I want to talk about drivers of rural disparities. And then talk about capacity building as a concept and its implications for that. I'm going to tell you a story about a project that we recently completed that we called Healthy Hearts Northwest, about cardiovascular disease prevention. Then we're going to conclude by intersecting equity and capacity building, and then talk about future directions for research and implementation. So those of you who are from rural areas, those of you who have worked in rural areas, those of you who are familiar with this setting know that our rural communities are hurting, and they deserve our attention. We heard earlier today that rural residents are less likely to receive preventive services. And I share this slide just to remind us about what we mean when we use the word equity and how it's different than equality. And pardon the rodeo symbol there, but I'm reminded of a nurse practitioner who told me works in a rural clinic, who told me the only way she reaches her population is by consistently going to the local rodeo and the feedlot to engage with the farmers and ranchers in her community. When it comes to preventive service delivery, rural populations face many barriers. And I want to point out that the reason there isn't a line here, and rather a circle, is because these drivers interact with each other. And this is a theme that I think we'll come back to again throughout the discussion. There's a nonlinear interaction between factors at multiple levels in rural communities that are drivers of whether or not clinical preventive services are delivered, especially from the primary care clinic or provider perspective. We know there are provider shortages in rural areas, so we've talked a little bit today about access. We know that rural residents are more likely to be unemployed, have lower levels of education, higher rates of obesity, smoking, sedentary behaviors, and are older and have higher numbers of chronic illnesses. And the reason that is important from a primary care clinic perspective, as many of you who are primary care providers like myself know, is that when you see a patient in your exam room or your encounter room with 5 or 10 chronic illnesses that you're managing and a list of 8 or 10 chronic medications, there are a lot of competing demands during that encounter for service delivery beyond remembering to give that patient a fit kit for colorectal cancer screening. Those of you who may be familiar with the Anderson model of healthcare utilization, I point this out. This is Lillian Gelberg's work, in which she modified that health-seeking behavior model for vulnerable populations. And I want to point out that although she did this work in the homeless population in Los Angeles, many of these same characteristics are relevant to rural populations as well when you compare rural versus urban communities. Age, social isolation, insurance, income, transportation, and great distances that have to be traveled in order to reach healthcare, geographic access, and other factors that all combine in complex nonlinear ways that I would postulate result in this emergent phenomenon of preventive service receipt. I do not like the linear arrows on this diagram because I don't think it's a linear phenomenon. And I think much of what we're struggling with in understanding this is because of our linear thinking and linear approaches to addressing preventive service delivery. So let's talk about a primary care clinic perspective just for a minute. If you're a primary care provider and you're practicing in a rural community, you don't have access to a lot of specialist colleagues. There is a sense of isolation. You are often responsible for both seeing 20 to 30 patients a day in your clinic and being on call for your local emergency department, for rounding on your patients who are in your rural hospital, and for providing coverage for your long-term care facility in your community, all at the same time. There is also a lack of a deep bench sometimes in your community in terms of staffing your clinic. We frequently see staffing shortages in rural clinics. There are also provider shortages that are well documented. But these clinics and these people are also deeply embedded in their rural community, and they feel a sense of belonging to their community and a commitment to serving their community, which is a real strength. They have relationships with their patients, and they can develop a level of trust that oftentimes doesn't exist in other communities. And then finally, as we pointed out before, their patients are older and sicker. So we have evidence-based clinical preventive services. We even have some evidence that there are some evidence-based programs that might help us deliver those services. So why the persistent rural-urban gap? So today I would like to talk about this concept of capacity and illustrate it through a recent study that we were involved in about cardiovascular disease risk reduction in primary care clinic settings. Capacity, as I define it here, is the skills, motivations, knowledge, and attitudes necessary to implement innovations. And this exists at both the individual level, let's say the provider or staff level in a clinic, the organization level, which is the organization of that clinic or the organization that that clinic belongs to, and then outside the clinic, the community in which they're embedded. So there's capacity at multiple levels. And I apologize for the small print on this slide, but I just want to point out that there's capacity at the level of the innovation, and then there's general capacity at each level of the individual, the organization, and the community that interfaces with the innovation in terms of its implementation that we need to understand. And in a minute, we're going to talk about the difference in capacity at both the rural and the urban level in terms of implementation and ability to implement an innovation or deliver preventive service. So here's the story. Once upon a time, the Agency for Healthcare Research and Quality did a really crazy thing. They funded 7 cooperatives across the United States and gave them 36 months of funding to address the delivery of cardiovascular preventive services in smaller primary care practices at a regional level. We were the Northwest Cooperative, and I was privileged to be the principal investigator of an amazing team of people. who did some remarkable work in the Pacific Northwest to engage smaller primary care practices around the delivery of 4 clinical preventive services: aspirin, blood pressure, cholesterol, and smoking. And these were the practices that engaged with us. I want to point out to you that the distances that we covered across these 3 states is the exact same distance as it is from where we're sitting today to Orlando, Florida. And there's a mountain range down the middle of it, with passes that are frequently closed in the winter. These were the practices that agreed to participate in this study. They were very brave and courageous. And I just want to point out that 43% of them were located in a rural area. We were trying to address QI capacity building in these practices. How do you build their capacity to do improvement well, especially around these, with a focus on these 4 cardiovascular risk factors? And we used what's called practice facilitation as a central unifying strategy to help practices with building their QI capacity to intervene and improve these preventive services. Each practice effectively had a coach. And we provided them with 15 months of support, at least quarterly visits in person and then phone contact in between the quarterly visits. So what is facilitation? It really is that at-the-elbow support provided by someone who serves as a change agent from the outside of the practice, who comes by the practice and says, how's it going? What are you working on? What do you need? How can we help you? They introduce new ideas for change in the practice. They help them identify and remove barriers. They establish effective communication channels between people who work in the practice, and they monitor change and are generally an accountability agent for the practice. This person is that person that one day the office manager comes into the practice and says, oh my gosh, Bridget, our practice coach, is coming next week, and we haven't done anything that we said we were going to do since her last visit. We need to get our butts in gear and change something so that we have something to tell her. I want to compare the rural practices to the urban practices for just a minute and make a couple of points. First of all, it was a lot easier to recruit rural practices than it was urban practices. 1 out of 4 of those we approached participated versus 1 out of 10 urban practices. They were also more likely to stay engaged and complete the study. Lower dropout rates. And they had more in-person touches with their practice coach. They were open to more in-person visits. I think this points to the relationship aspect of doing this work in rural communities and the importance that these people in rural communities place on having that relationship with someone who will come by and interact with them. It is a way they address their isolation in doing their work. What we heard from practices were these kind of things. You know, that doesn't always work in a rural environment to be the expert from Seattle. In a rural area, you're asked to do many things. You might be in the emergency room one day, and the next day you're in the clinic. When you're in a rural practice, you have to realize you may be the only option for that patient. Themes about isolation, themes about resources. And because we're researchers, we ask these practices to complete way too many surveys. But one of the surveys we asked them to complete was a survey about their self-assessed ability to do quality improvement well in their practice. And we identified these 7 what we called high leverage changes of areas that we thought were important for practices to engage in. I know you can't read the print here, but I wanted to give you a sense of what this survey looks like, because this survey was filled out with all the members of the practice together in a room with their coach. And they discussed every item on the survey and talked about where they were in each of these areas. And here's what we found. First of all, I want to point to, I don't think it works. There it is. The blue is rural, the orange is urban. There is a difference in overall QI capacity, but there are two areas that I want to point out to you. That is the self-accessibility to provide self-management support and their community resources. Both of these, I think, point to the context in which rural practices deliver care, which is at the community level, and their sense that in their setting and in their environment, they lack the resources and community support they needed to be able to do this well. We also asked practices to report on how well they deliver these preventive services, and I just want to point out the blood pressure measure. So this is the proportion of patients whose blood pressure was less than 140/90. And you can see that at the start of the study in 2015, there was a significant gap in patients in rural practices versus urban practices in the proportion of patients who met that target goal. And that by 2 years later, by 2017, rural practices had significantly closed that gap. I think what we're talking about here is, again, back to the implementation issue and the capacity to implement things well in these practices. And I want to point to this work by Lewison and Fleming from the University of North Carolina that talks about the importance of building relationships and building capacity in the rural community and in the rural practice if we're to implement effective delivery of something like clinical preventive services. They recommend that you have to invest in relationships in rural communities first, that you need to fund and build creative individual and organizational capacity. You need to partner with the community. You need to adapt and translate evidence, and you need to support extending the implementation timelines in these communities, perhaps because of this capacity issue. So what does this mean for equity? I would postulate that capacity building has to occur at these many levels, that these rural clinics and communities really need at-the-elbow support, and that because it's a complex system, small amounts of support can result in big improvements. I think it's important for us to get creative about this. I would think about how we can partner with our rural colleagues to co-create innovations in the rural setting. There are actually very few, in fact, I could not find any, evidence-based models for implementing clinical preventive services that were developed de novo in a rural setting. Almost all of them were developed elsewhere and then adapted to the rural setting, or attempts were made to adapt them to the rural setting. We need to provide a longer ramp-up support time for these clinics and to build these relationships, and we should think about convening work groups to develop strategies that work across levels, the community, the organization, and the individual. So I want to thank you today for inviting me again. I want to close by saying, be innovative, be daring, and be patient. Don't expect rural communities to be your study subjects. I think if we establish a respectful partnership, if we listen to our rural colleagues with unconditional positive regard, we will make great progress in improving delivery of preventive services in rural areas. So thank you very much.
If our other panelists could come up. Thank you very much, Mike. So let's start with any clarifying questions from our panel. Yes.
Can you hear me?
Push the button, I think.
Okay. Hello. Oh. Thank you very much. Those were fascinating, and you did pull a lot out from the research. To add to what we couldn't find in the evidence review, but I have one question. That is, you talked a lot about clinicians and providers. I'm wondering if any of you looked at how some of these aspects of rural care or of communication, et cetera, differed by nurse practitioner providers versus other types of clinicians, because they're trained differently, and might there have been some differences there that we could learn from and highlight?
No, I think you bring up an important point. And a lot of these visits where preventative services would be delivered are with diverse providers, physicians, nurse practitioners, physician assistants. At least in the work that I reviewed, I didn't come across any that focused on nurse practitioners, but it doesn't mean that it doesn't exist. I just didn't see it. And I think it would warrant looking more deeply to really capture that information to assess whether or not there are differences. But at least my initial impression is that communication is important regardless of what type of provider you are. And while training is different, I think the goals are the same. And ensuring that the interactions that you have with patients, you're able to develop those effective partnerships, I think would translate across provider type.
We did do some work funded by the Robert Johnson Foundation a number of years ago about learning from effective ambulatory practices, the LEAP project, in which we looked at very high-functioning teams in primary care and found that one of the characteristics of really teams that had distributed task and role responsibility across everyone who worked in the clinic did much better at delivering clinical preventive services. Now, we didn't quantify that in terms of collecting data, but when we looked at the 30 exemplar clinics we visited, it was pretty impressive because everyone from the front desk to the MAs to the billing staff felt responsibility for delivering appropriate care to the patient and took on the tasks of saying, oh yeah, this patient needs a fit kit. And they would give it at the front desk rather than wait for the clinician to remember to do it, because I would always forget.
You know, I think where you see a literature on the value of the allied health professional multidisciplinary team is really in the management of chronic condition space. When I looked specifically at delivery of preventive services, there really wasn't much there. And I think, you know, understanding the role of nurse practitioners, nurses, pharmacists, MAs, it's a very scant literature from my review, and I would say it's a big evidence gap.
So, I had a question in regard to sort of the research approach. And you described a lot of heterogeneity across these different settings. And we like things to be done on a research basis and rigorously. On the other hand, what I heard is also a more QI-oriented kind of approach can be just as informative and maybe tailored better. And I wonder if you could comment on how we do get to real learnings that make a difference in the, you know, different settings and sort of relative value of QI versus, you know, more rigorous academic kind of studies?
You know, I think there is an emerging methodology for how to study natural experiments. So there actually is a consortium that the NIH and CDC and PCORI funds to really examine natural experiments, particularly in the delivery of diabetes care. But I think as the methodology emerges, one of the things that's clear is that you need robust comparator populations. So get consensus, even in places where there are natural experiments happening with care management, if you can build in those robust comparator populations that are comparable. That's very important. And then the other thing that's really important is consensus on endpoints to track across heterogeneous settings. And I think health information technology holds a lot of promise for getting to manageable, real-time clinical data sets that can be repurposed for that. But we're really at the front end of that methodology and really best practices for how to study those things, I would say. But I think that, that's the direction we're going to have to move, because we can't really do randomized clinical trials at the system level for many of the things that we would like to do to try to improve care.
And I would just point out, to piggyback on that there is a growing thinking in the implementation science community about hybrid type 2, hybrid type 3 trials that is an attempt to build some rigor and some guardrails around study design that I think holds great promise. And I would agree with Carol's comment. It's really difficult to engage health systems and clinics and communities in research if you tell them, well, you may be randomized to be in the control group. We found that in our recent opioid study, in which we told them we were going to do a stepped wedge study design. And when we got the funding and went back to them, they said, we're not in. It's a crisis. We're not going to be randomized to that wave that gets the intervention a year from now.
My question is primarily for Dr. Parchman, but actually it applies to all of you. As you spoke about creating solutions for health equity and preventive services for rural areas, and I looked at the map, and your area is primarily in the northwest of the United States, which of course is very rural. But my mindset, when I think of rural, I think more south in the country, southeast. So my question is related to the solutions that you're suggesting for the Northwest. Would they be appropriate for other rural communities within our country as well? Or doesn't that need to be considered?
That's a really good question. I think rural communities in the Southeast may qualitatively have some differences from rural communities in the Northwest that would bear consideration. I think some of the principles about needing to think about multi-level capacity building are the same. So building capacity at the community level, the organizational level, and the individual level is important to think about if we're going to address equity. So I don't think that's different, but I think the way in which you would go about it would be different in the Southeast, just because of the differences in culture and values. That would be a really important consideration, yes.
Thank you. One more.
Yeah, Dr. Parchman, can you address the issue of sustainability of your interventions and how you would foresee that being addressed?
No, because it's really difficult to get anybody to fund a study of sustainment. Nobody wants to study sustainment, although they claim to. And so we really don't know a lot about sustainability in terms of implementing these kind of changes in systems, unless you can look back and reflect back on things. So doing some kind of retrospective look back and say, that wasn't sustained. I wonder why. Well, let's think about it, and then try to collect some variables that you think you would hypothesize would be a mediator or a moderator of sustainment or sustainability. But it is terribly difficult to study sustainment.
Well, yes, and the intervention that you had, which was basically detailing at clinical level, has to be funded to be sustained. So any ideas on how that could be approached?
Yeah, well, there again, I'm still kind of grieving the fact that The idea of health extension agents to support primary care practices was authorized in the ACA but not funded in the United States. That being the same practice facilitator model of people who are regionally based, who are that extension agent, agricultural extension agent kind of person, but for primary care practices, which is so desperately needed, especially in rural areas.
Thank you. If we could get folks from the audience line up at any mic. I'd like to follow up a bit on the last question. In theory, accountable care organizations could support some of those practices, but have they to date? That's an implementation issue, because they're probably going to want to see what's their return on investment, and for prevention, it's a fairly distal return.
So, I'm sorry, ask the question.
Are the ACOs supporting practice facilitation?
Are the ACOs?
Mm-hmm.
In some places, to a limited fashion, yes. It's not widespread, but you can see a few examples of it in various geographies around the U.S., but it's not as robust or as significant an uptake of the idea as you might hope, given the level of evidence about the effectiveness of the concept of practice facilitation. You really don't see it.
Thank you. Let's start on the left.
Hi, my question is for Dr. Greer. So I was wondering, when you were talking about cultural competency among providers, if they had looked at breaking down location of residency and in terms of like confidence level to supersede that gap.
And just one clarification, when you say location of residency, do you mean by region or?
Yes.
So as far as I know, there haven't been any studies that have focused on regions. There have been studies that focused on type of providers in terms of cultural competency training, where, for example, surgeons may receive feel less culturally competent and receive less training than, say, for example, primary care providers. But that's usually the extent to which they break that down, and not necessarily by region in the country.
Okay.
Yes.
Is this on? Two concerns. One is with the notion of equity that you mentioned, Dr. Nelson. I know this is a widespread notion of equity as, quote, the highest attainable quality of life for all people. My concerns are three. One, I have no idea what the highest level of health it means, and it's impossible to measure. Two, it ignores the notion of injustice, which I think is fundamental to the notion of equity. And third, probably most important, it ignores the fact that we can all have equal health, but if we don't have access to societal determinants of health, the resources that promote health, that health that we all have in equal quantity is going to disappear fairly quickly. The second issue that concerned about is this notion of discordance, racial discordance, which I think is important to track because it shows the effect of race on healthcare. But I'm concerned about what the inference is from that. One way to deal with that would be to have a segregated healthcare system in which black physicians treated black patients, which I think would promote more inequity than it would solve. The other one would be to build into our healthcare or medical educational system the anti-bias, cultural sensitivity approaches that you, I think, talked about. So two questions. Thank you.
Start with Dr. Nelson and then maybe to Dr. Greer.
Okay. Well, describing health equity in a big, broad sense was sort of an entry into the discussion. What we intend is that for each of the preventive services, that the highest level would be comparable for others. So the screening rates would be the same. So applying that for each preventive service in the review is kind of what was intended. So that maybe wasn't explained very, very completely, that was what was intended, if that helps.
And I think you bring up some important points around racial discordant visits. And I think there really are two approaches to addressing that. And one is to recognize that ethnic race minorities and socially disadvantaged populations are more likely going to see someone that is of a different race or of a different class. And so I do think that there should be efforts from a health system level to ensure that they have workforces that are diverse. That's one way to promote improved patient-centered communication and kind of address that concern. But the other is to ensure that in visits where there is racial discordance, that we train those providers to deliver patient-centered and culturally competent care. And that training needs to occur in medical school, be reinforced in residency, and then also be reinforced throughout training, because again, we know that communication deteriorates over time. And those would be the two strategies I would propose to address that.
And I would like to suggest that we have a big research gap, because I think just from observation that in settings with a diverse physician workforce and with training, that we probably get the best outcomes. Because I think when you have colleagues from different groups, there is heightened sensitivity and knowledge that isn't present if you just have a homogeneous group of physicians, even if they're getting the bias training. So probably the bias training is better than nothing, but I think we should aspire to having a more diverse workforce and doing the bias training. And it would be wonderful if somebody would study that, because I think that is another big evidence gap, what you're getting on the margin. And I think for many of us who work in diverse settings, we feel like on the margin it's huge, but I think it really hasn't been studied well.
Thank you. Next question.
Thanks for your presentation. My name is Li Yang. I just wonder, we talk about health, we want to see the people, the access to the health facilities or the health provider go to their community. And now we have to think about a system problem. Now I think that economy will change people's behavior. Maybe they will go back to their parents' house. So, and they go to the south. Now it's sort of changing in a direction. And if they don't have transportation and a car or vehicle because their car was stolen or robbed, and this system is a big problem, especially currently they change it to the direction of PPP, public-private partnership, by all agencies practically. But PPP now is very notorious. It's really reflect extreme fraud and crime, and with all kind of official misconduct, conspiracy with police and government attorneys and court personnel. So there's no recourse for them to complain, and the only way they can do is just sleep outside. They don't even have shelter, and they just, if they don't go to their parents or their grandparents' house, and their health itself is a problem, getting less health and health care, and they go to jail, the deprivation of their sleeping and their food, they make the health even worse. So I think we got to think about system problem to promote the health and promote their family relationship. Otherwise, we go to just every time if somebody, police want the money, you give them money. Training, they ask them to kill rather than training to help people. So I think we got to think about the outside box, just how to promote their health, how to reduce mass incarceration, how to improve their happiness rather than say, deprive of their family relationship. And then everybody feel lonely, and their parents is nobody taking care of, so their assets, area estate will be robbed by this kind of PPP group. So I hope we can think about outside the box, make it real change. Otherwise, our society is in vicious cycle.
Thank you.
Thank you.
Maybe our focus could be on the really special populations that were brought up of incarcerated, homeless, et cetera. which really brings to light some of those access problems that our speakers talked about. Thoughts?
Well, we did see in rural communities a real strength in these communities was that people really did know each other. And they knew when a member of someone's family was released from an incarceration and coming back to the community. The providers and staff in the clinics knew the local sheriff. They knew the members of the school board. They met with each other. They talked with each other about their community. They talked about developing partnerships around addressing the drivers of healthcare in their community. And they felt a commitment to their community, which I think is a real strength of rural areas that we don't recognize.
Thank you. Question?
Yes, Larry McNeely with the American Diabetes Association. Great panel and presentations. Thank you. My question is for Dr. Perchman, but others may want to weigh in. I'm interested in, there's been a lot of buzz about the Project ECHO model of linking specialists, obviously, with primary care, sharing knowledge, and working through dissemination of best practices, et cetera. For a number of disease states, including diabetes. My question is how practice facilitation, as you present it, either fits, complements, or competes with that, either for resources from policymakers or from time from a primary care physician, assuming we had both up and running in a region.
That's a great question.
Maybe start with telling the audience what Project ECHO approaches are.
Sure. So Project ECHO was developed originally out of the University of New Mexico to address, I think, hepatitis C in rural communities where an academic expert was live video conferencing with rural primary care providers and presenting complex patient cases. So there were case discussions about managing that patient with a gastroenterology specialist in hepatitis to help the primary care provider learn how to do this well, because the patients were not going to the academic health center to receive care, and they realized they were going to have to do this kind of Project ECHO kind of outreach. And these were a regular series of telehealth connections between the academic health center and the rural providers in the community. But the question is, this is a funny story. So we were doing something kind of like that, except it was more remote academic detailing around cardiovascular risk calculation in primary care, and we were trying to reach out to half of the clinics in the study to get a provider to join a kind of webinar live with me or someone else about calculating cardiovascular risk and then using that in shared decision making with patients, and we were going to discuss cases and blah blah blah, and we couldn't get anybody to sign up for it. And I thought, oh no, but we've got practice facilitation, so we don't want to contaminate the two arms of the study, so we can't tell practice facilitators about the content of the outreach we're doing, right? And finally we said, this is crazy. It's not going to happen because the facilitator is the one with the trust and the respect of the providers in these clinics. So we turned to the facilitators and said, okay guys, you have got to recruit the providers to get them on the line to do these webinars with us. They trust you, they respect you, and that is the only way we're able to get them to participate in that arm of our study, is through the practice facilitator doing the outreach, and in some cases physically being in the clinic to dial up the connection and get their computer to work so they could make the video connection, because the providers were usually late, they were running behind, they couldn't get there in time to participate. And so the coach was there to facilitate the whole process.
Thank you. Yes.
Good morning. My name is Christiane Delgado. I'm with Latino Connection.
And I'm curious and frankly a little concerned with the findings, especially in the area of cultural competency amongst clinicians. What role does, or really what role, I know what role it should play, but what role does it presently play? What role do national class standards play? And what is being done to track how class standards are being implemented in hospitals and clinics? And when I say class standards, I'm talking about culturally and linguistically appropriate services. Just curious.
No, I think you bring up a very important point. Again, there is a national call that those services be available, and it is important for those to be measured and assessed, and for organizations to be held accountable for that. But unfortunately, I'm not sure of the evidence around that area, and I don't know if any of my colleagues are more familiar with that. But I think I do agree that it's a very important point that it should be tracked.
I'm just curious as to whether hospitals and clinics and, clinicians are aware that it's, federally required and regulated, and it's no longer something nice to do, but actually an obligation across, federal standards, basically. So that's why it's concerning to me that, over 50% of residents feel that they're not culturally competently trained when it's federally required. So just curious.
Again, an unsubstantiated opinion, but until there is audit and penalties, it's unlikely that we'll see broad enforcement. Obviously we have some big federal payers like Medicare and Medicaid, and there could be public policies that actually would lead to better enforcement.
And I will say that I can speak at least for the training programs and academic standards, is that there is that requirement for it to be taught in medical schools, and there's increasing integration of the curriculum at the residency level as well. Right. So I think that there are efforts that are encouraging to going in that direction, ensuring that all providers who complete their training have that appropriate information. But again, I think you're right. It should be tracked in that, but ultimately difficult to enforce.
Thank you.
Thank you. Yes.
Hi, my name is this on? My name is Farah Kudrath. I'm an Emory Preventive Medicine resident. I'm very interested in healthcare workforce diversity. I had a comment and then a question. So the presentation that included the differential in outcomes for African American women with regard to breast cancer mortality, there was a part of the bullet that talked about treatment-resistant forms, which is an interesting phrasing because that's what's seen in the literature. When really what that says to me as a person of color and as a resident physician is that the types of treatments that we've developed have been developed for white women. And so when we talk about treatment-resistant forms, we're creating a language in which black women are essentially told that your cancer is different, it's worse, your disease is worse. So based on that comment and what we were talking about before with the idea of cultural competence, which I think was the first iteration that eventually leads to, well, actually what we really need is healthcare workforce diversity. Two questions. What role do you think language plays in how we present these issues? And then secondly, what role does a researcher have with compiling evidence, but also speaking to their own experience as researchers and clinicians and communicating that with the public, and what role does research have in advocacy? Thanks.
Well, first of all, thank you for bringing up the point. The category of treatment-resistant breast cancer was really something that came up not so much in a racial context because it's something that was noted in the clinical trials, and those patterns of biologic markers don't just happen in African American women, they also happen in white women and in other groups, but they seem to be more prevalent in African American women who have poor outcomes. So, it's still, words are powerful, and I couldn't agree with you more that an evidence gap is that we have not devoted sufficient resources to identify the best treatments for people who, say, don't have estrogen and progesterone positive receptors on their tumors. So I think your point is well taken, and it is a call for research to really study those types of breast cancers more. But also to think about, when we say treatment resistant, we mean by the typical ways we treat, right? And so probably there's a different way to refer to those tumors, much like there would be for, say, a lymphoma that might have markers that would portend a worse prognosis.
Other comments from the group? Thank you. Thank you. It's 12:31, so I think we have an opportunity for lunch. So we will resume at 1:30. Is that right? See you there. We're going to start with key question number 2. Same type of format. I want to thank our panel. Fabulous discussion, which just goes to show that even if there is no literature, we can get a lot out of it. Thanks a lot. See you in an hour. We're going to start the afternoon with a brief video vignette on the importance of health equity and preventive services at NHLBI from Dr. Gary Gibbons, Director of the Institute.
The NHLBI is pursuing a research agenda that engages communities, patients, researchers that are pursuing implementation science that will provide a link between interventions that will have a positive impact on their communities and address health inequities. At our institute, we believe an important approach to addressing health inequities involves the area of prevention and prevention services. For example, we funded a study that recognized that barbershops are an important place of convening and communication and information sharing in certain communities. And the investigators were able to leverage that community resource to promote health and prevention services related to hypertension. And it showed a key benefit to that community. Our institute is committed to ensuring that our research has a direct impact on the health of the nation and the health of everyone in every community. So it's really important that we engage communities to ensure that each individual feels empowered and that the community really is a partner with us as we promote research that develops innovative strategies to really improve an individual's health and the health of their overall community. We hope that as part of our research efforts, we can develop best practices and models that empower people to take control of their health and to act on knowledge in ways that improves health outcomes. We now have the capability of connecting with health and promoting prevention that goes well beyond the clinic walls and permeates all the way to communities. We have a way of now connecting people together, patients together, groups together with flows of information that could be channeled and personalized in ways that are unprecedented. All of these tools and technologies can now be used to extend preventive services in ways we couldn't have imagined before. This is an opportunity to really democratize information and to provide it and put it in the hands and empower people and patients and communities. We think this could be incredibly transformative in addressing health inequities, as again, we involve and engage community to work together toward improving their health.
My
name is Heidi Nelson. I'm from the Evidence-Based Practice Center at Oregon Health and Sciences University. For those of you who weren't here this morning, I'm giving the second part of our evidence review's results for key question number 2, impediments and barriers of populations. I have no information to disclose. And I want to also acknowledge the members of the Evidence-Based Practice Center team listed in this slide. All right, if anyone missed our first presentation on the methods of the evidence review, I just want to let you know that the draft report is currently posted online, and you're welcome to look at the report. It will be up for the next 4 weeks. I'll show you the link at the end of my talk here, and we outline our methodology and all the details around that. And the next few minutes, I'm going to walk you through the results we have for key question number 2. And this question is about the effect of impediments and barriers on the part of populations adversely affected by disparities to the adoption, promotion, and implementation of evidence-based preventive services that contribute to disparities in preventive services, and then which of these are most common. Key question 1 had to do with impediments and barriers on the parts of providers and clinicians, and we found no evidence that met our inclusion criteria for key question 1. The good news is, for key question 2, we do have studies. We have 13 studies that met inclusion criteria. These include multiple different types of study design, randomized trials, prospective cohort study. We included before and after studies, since these are often used in demonstrating a new different intervention or a change. So we wanted to include those in 3 secondary analyses of randomized trials. So different designs. I want to point out, however, that a couple of these designs, before-after studies and secondary analyses of data, have no quality rating criteria. So we went over in the methods part about rating the quality of these studies. We don't have criteria for those designs, so they won't have those in the report. Most of these studies had to do with cancer screening, 3 for colorectal cancer, 7 for breast cancer, and 6 for cervical cancer screening. 2 studies were on smoking cessation. Some of these studies, you see those numbers don't quite add up. Some of the studies report a couple different kinds of cancer screening, so they're listed for each one separately in the results. Populations were defined in many different ways. The most common description was a low-income population, so that's kind of vague in some situations. We have some rural populations, studies done in Hispanic populations, African American, Korean American, and Chinese American. So I'll try to refer you to those as we go. Our goal to try to have any kind of conclusions based on a population kind of falls apart when we only have 13 studies and practically every study is in a different population. So that we can't really do that for this key question. Just a reminder how we grade the strength of evidence and applicability. The strength of evidence is sort of a score of how well the evidence actually makes us feel that the result, that we're confident that the effect in the studies is true. That would be high. Low means limited confidence. More evidence is needed before making a strong conclusion. Insufficient means no evidence or no confidence in the evidence we have. Applicability, which is a measure of how well the study would play out in Main Street, in the real world. If it's high, the studies would be widely applicable. Low would mean it could apply to selected populations. It's still useful, but extrapolating beyond them could be problematic. Insufficient, again, no evidence or cannot determine. And I'm showing you those because we're going to show you those scores in the tables that follow. So for each preventive service under key question 2, I'm going to show you tables that look like this that describe the summary of evidence. Over on the far left-hand side of the table, we list the impediments and barriers that were described in the study. The number of studies, the type of study design, and the number of participants are listed in the next column. The overall effect, and then finally at the far end, the strength of evidence is the first letter, the strength or the applicability, the second letter. So L would correspond to low, the INS insufficient. So it's not too promising at this point in regards to the strength of evidence, but I'll walk you through what we did find as a summary. So again, some of these studies have multiple impediments and barriers, so they're added in under each one. Some of these studies report more preventive services than colorectal cancer. But overall, for colorectal cancer screening, there were 3 studies. For looking at the barrier of low income, one small trial showed no effect among safety net clinics. But one of the problems with this study is that it was in safety net clinics, so the discrepancies in income across that population group may not be enough to show that the low end had a big difference from the high end of income. And it's a small study. So we gave it a low level of evidence. Certainly there are probably more studies that can be done that will answer this question for us. Looking at insurance as a potential impediment or barrier, we had 2 trials, which includes the first one I mentioned, and also reported insurance status. In one of the studies, there was less screening with Medicare-covered patients compared with a different county health plan, but otherwise no difference in other types of insurance with a county health plan. The other trial showed no effect of insurance in any way, so we had sort of a mixed answer there. So evidence strength is low, applicability low. A third barrier that was evaluated in a different randomized trial was attitudes towards screening in an African American population for colorectal cancer screening, and found that higher scores on the attitude scale, which means they had a better attitude about screening, were associated with a higher screening rate. However, we weren't too impressed with this study because they made the scale up. It's not a validated scale, and a very indirect measure, so it's really hard to know if that really meant what was intended. So that would be a study that it'd be good to have a follow-up of that, or maybe another study validating what the attitudes really mean on that scale. So not a strong set of studies here, but at least there's some, and they're trials. So I promise the panel it gets better as we go. So here we are with a little something to talk about. As we go to breast cancer screening, we actually have more studies. I believe there are 7 studies of breast cancer screening that look at these impediments and barriers. One trial of over 1,000 women showed that among non-U.S. born Latinas, women with Puerto Rican country of origin had higher screening rates than those from Mexico, Central and South America, or Dominican Republic. So it seemed to have some effect between those groups. However, it was just one trial, so evidence there is low. Looking at age in one trial of low-income Chinese immigrants, older women were less likely to get breast cancer screening. Again, just one trial in a very specific population. Low income in 2 trials showed no effect. Again, probably among, not a wide range of incomes, so it may not have been the best studies to show that. We had many more studies here about insurance, and actually quite a large number of women enrolled in these studies. But you'll see that we got every answer you could look for. We got more screening with Medicare versus no coverage, which is what you'd expect, and with insurance, so more screening when you're covered. But then other studies showed lower screening with insurance in 2 studies, and then 2 studies showed no effect. So the results are quite mixed here, and it's hard to sort out what the real answer is. As we've mentioned in a number of the talks, breast cancer screening, like all the U.S. Task Force A and B recommendations, are currently covered with no copay or deductible for most public and private insurance plans. So the newer studies may not be particularly good at pulling this out. It may not mean as much. But anyway, we did get mixed studies here for that question. There was a cohort study that looked at a rural location and found that there was less screening the further you lived away from the radiologist's office, and when you lived in an economically deprived area, that was a distance from the radiologist's office. So this study actually went ahead and looked at the effect of mammography vans and found it fixed the problem. So that's the kind of practical study that is useful. So distance from the service had an effect, but it was one study. Looking at the effect of a provider, having no provider, 2 studies showed that there was less screening with no regular provider in one of them, but no effect in the others. And then the study of low-income Chinese American immigrants, same one that looked at age, also looked at language as a barrier, and found that that was really no effect among that group of women for screening for breast cancer. So we have 6 studies of cervical cancer screening, so again confined obviously to women. Some of them are the same studies that were for breast cancer. They looked at both of them. One of these was the study of Puerto Rican-born women versus other non-U.S. born Latinas, showed higher screening rates for for cervical cancer, which was the same as what we found for breast cancer. So that showed some effect there as well. Another study of low-income rural showed no effect of race. The country of origin part of that was a little hard to pull out, so I'm not sure how helpful that study actually was for us to look at. Looking at older age, this study was actually done in older low-income rural women and found less screening for older women in that cohort. Or it was a trial, so among that group of people, it was lower screening for cervical cancer. Low income in one trial showed no effect among rural low income women. Insurance status, again, we had 4 studies, less screening with Medicare versus the county health plans in one trial, and with any insurance in 2 studies. So less screening with insurance, and no effect in one trial. So again, kind of mixed message regarding insurance. And at the bottom of the slide, no provider. The effect of that in 2 studies showed less screening with no regular provider in the one study, no effect in the trial. So all of these really were only reaching strength of evidence of a low level. We thought the applicability was similarly low. They were small and very specialized populations, and the results were unclear how to apply them, but it is a start. We had 2 studies of smoking cessation, and both were done in African American populations. One study, it was an analysis of baseline data of a trial, included both African American and white smokers, and was one of the few studies that actually compared groups like that. And they found that motivations for smoking differed between African American and white smokers, but motivation in itself did not explain the lower quit rate among the African American participants. So how motivations relates to quits was never truly established in this study, so we gave it an insufficient level. We were not sure what to make of that, but there were differences. Maybe they're onto something there. And then looking at the effect of having no provider, the study showed having a regular source of health care was associated with planning to quit within the next 30 days, ever receiving physician advice to quit, and light smoking. They didn't measure actual quit rates in the study, but these are good signs of perhaps thinking about quitting, which is part of the process of actually quitting smoking. So that got a low level of evidence. And that, again, was also in an African American population. So adding these up, 13 studies, but they're kind of all over the place in regards to which impediments and barriers they looked at, and also some of the effects on preventive services. Insurance coverage was the most of the studies and looked at that, but it was, as I say, mixed, increased, decreased, and no effect depending on the study. Clumping together some of these impediments into sort of one category, no regular provider, but also poor patient-provider communication, not knowing where to get screened, kind of that provider issue, showed decreased screening in some studies, but no effect in others. Residing in the remote or economically deprived location for that breast cancer screening study showed decreased screening. That seemed to correlate pretty clearly, but it was just one study. Low income mostly showed no effect in the different studies, but it wasn't particularly well evaluated in those studies. Attitudes and motives for preventive services, we found that positive attitudes for colorectal cancer screening actually improved screening, but the tool was not validated. It's kind of hard to know how to use that in practice. Older age decreased screening, and that was among rural women and Chinese American women. Country of origin kind of depended. Definitely in that one study consistently showed increased screening with Puerto Rican-born women, and that's sort of a starting point to look at that question a little further, perhaps.
So there were a lot of limitations, but we did at least have studies that were trying to get to our question. The studies, again, even though we had 10 preventive services, most concerned cancer screening. And we're going to be seeing that again in the other key questions, that's the most common type of research for these preventive services. Studies differed by how they define and categorize these barriers. So just because I've told you insurance status, increase, decrease, and has no effect, they defined it differently and they compared the groups differently, and standardization around that has not been done. Plus, as you know, things change over time, how the ACA kicks in for different parts of the country, and all these things may have effects that weren't really captured. So we looked at how these barriers were defined and structured by the investigators and took the data as they presented them. But if we were to design the study and make this more meaningful for the question we have today, we'd probably do it differently. Quality and applicability of the studies were low or insufficient, so it's really just a starting point to get this evidence base filled in. And most studies recruited highly selected samples of patients, so applying them to other settings or making big general statements are probably not warranted at this point. It's unclear how they apply to others. So future research needs include research to test effects of these impediments and barriers. As we've said with our methods talk that we're not looking at association studies, so we really want to know some type of effect size. And these studies were able to provide those, but in very different ways. So those are summarized in the report, but to go through that would take more than the time we have. Studies need to include populations and preventive services not yet addressed. I was surprised, though, at all the many populations that were included. You'll see more populations that are included in the different studies that we have. So we do have good representation of some groups, but no representation of other groups. We need to improve study methodology to clarify these definitions, the measures, the outcomes. It will call for some unifying construct around those. Our key messages, as a takeaway, most commonly examined patient barrier was insurance coverage, but the results of studies were mixed. Single studies generally reported additional barriers. Evidence was little insufficient because of lack of studies, small numbers of participants, and some methodologic deficiencies that we haven't had a chance to get into here, but some of these studies were not rated very highly by their quality measures as an individual study. Evidence limited by the high heterogeneity of these studies, the different outcomes reported, and the inconsistent results. So I want to give you the website for the full evidence report, and we welcome your comments over the next 4-week public comment period. We're doing an updated search, so I hope we can add a few more studies to this when you see the final report. I'll stop here. Thank you.
And good afternoon. Thank you very much for the organizers to invite me to be here with you this afternoon. And my name is Nico Pronk. I'm president of the Health Partners Institute and the chief science officer for Health Partners at Health Partners in Minneapolis. And the topic is to talk a little bit about the role of business and industry in improving population health and well-being and focus in on health equity outcomes in particular. I have no information to disclose, so we can get started right away. So I'd like to start by saying, setting a little context for health and well-being in the nation across the next decade. Healthy People 2030 is under development today. And in that framework that has been developed for Healthy People 2030, there is actually a definition of health and well-being to focus in on that additional concept of well-being in addition to the existing health definition that is already there. How people think, feel, and function at a personal and social level, and how they evaluate their life as a whole. Well, how people think, feel, and function very much has an impact on how productive they are and what their performance is like at work. So the linkage to business and industry as a sector is easily made. New to Healthy People 2030 is this grouping of foundational principles that really outline the decisions and actions that are being made by the committee, the advisory committee. And in that framework, you can tell that health disparities, health equity, and health literacy feature very prominently. In addition to that, the context of health and well-being of all people and communities being essential to a thriving, equitable society. So the linkage to business is easily made when you think about the goals for the nation for the next 10 years as they're being put forth. It's also easy to sort of see how business and industry are connected. Business and industry are connected to community. It's pretty clear that both work is an important social determinant, but so is unemployment. We know that people who are healthy and well tend to be at work more often than those who are not. They actually have a higher level of performance while at work. They have more of a physical and mental capacity to do work, and they're motivated to do the job well. Business also, on the other hand, needs productive workers. So the connection between the two is quite strong. Even, or in addition to that, business is the main economic engine for a community as well. So this linkage to an economically thriving community certainly should include business and industry as a sector at the table. Now, every organization, whether it's a for-profit, not-for-profit, public or private, doesn't matter, but every organization has an impact on the public's health. It can do that through a variety of pathways. One would be through community health. What's the relationship that an organization has to the community? The health and safety efforts in locations where business does its work. Employee health, the health and safety of the workers themselves. Environmental health, what's the impact of the business on, and the footprint, if you will, that business leaves behind on the environment. And consumer health, how does the business affect health of the consumers of its products and services? So thinking about what business and industry can do to build, in a sense, a culture of health and well-being inside of its own organizations, when a business does this intentionally, there's actually good outcome. There are lots of indicators showing that in the process of building a culture like that, there is a reduction of cost, there is an increase in revenue and profits, as well as an enhancement of a reputation, business becoming sort of the employer of choice. A couple of examples. One is, for example, the employment sectors that with unhealthy workforces tend to be more likely located in counties with poor health. This is an analysis that looks across more than 3,100 counties across the United States. Manufacturing sector, which is the reddest dots, are associated with higher prevalence of smoking, of obesity, of diabetes, as well as cardiovascular disease-related deaths. So if you are in the manufacturing sector as a business, but you're in a county where health is much higher than in the next county over, you start out with an advantage compared to your competition. So health is important there. At the same time, health and safety tend to be good for business in terms of performance of the company in its marketplace. So this is an example of an analysis using winners of the Corporate Health Achievement Award that is handed out by the American College of Occupational Environmental Medicine based on audits of businesses. When those businesses are awarded a Corporate Health Achievement Award, they were put into a category and then using modeling compared to other companies and the S&P 500 and modeling of the portfolios of investment played out over the course of 12 to 13 years. And basically the annualized returns of those award-winning companies end up compared to the S&P 500, a 5% difference in terms of annual returns. This, of course, is sort of a strong financial performance indicator for business that supports the idea of building strong cultures of health and well-being at the workplace. Now, that said, as a backdrop, what I'd like to do is walk you through two examples of intentional business strategies employed by health partners as a health system to link employers to community, but also with an eye on improving health and addressing health equity. The first one is around personalization to address health disparities, particularly using approaches that incorporate machine learning and using colorectal cancer screening as the example. And this example is probably more of a tactical example, whereas the measurement and reporting of population health and well-being using summary measures of health and well-being is more of a strategic example. So this personalization approach, there are at any given time lots of targeted member campaigns going on in a health system. Now, in a health system that's integrated, where care delivery is connected to the financing of the care, there are strong reasons why you want people to come in for preventive screenings. So in this example, while there are multiple targeted member campaigns going on, the focus would be on those 4 that are highlighted in blue, and I'm going to highlight in particular the colonoscopy reminder systems. But basically think of it as just like you would think about your license tab on your cars. You get a nudge from the local government or the state, that tells you it's time to get your new sticker. And so you follow that process and, everything moves along just nice and fine. If you don't follow this process, you may end up getting in trouble and end up with a ticket or something like that. Well, this is kind of similar. Here we have a population of people that is not in adherence for their clinical preventive services guideline. And so the health system generates a reminder, a nudge. Those reminder systems are now set up to really optimize machine learning so that at every interaction and every iteration, the system itself gets a little smarter about how to connect with individuals. And they are created at the level of the person. So for colonoscopy, we basically find that there is a group of roughly 30,000, a little bit over 30,000 people who are not in compliance with the colorectal cancer screening. We know that the best screening tool is the one that's actually being used. So we offered a variety of options, and in this case, followed up with a fit kit that was sent out to those 30,500 people. Of those, 7,200 were returned, so that's roughly 24% return rate. Out of those, 386 positive tests, 186 follow-ups, so that's 48% follow-up rate. Of those, 120 colonoscopies conducted, 36 no abnormalities, 76 people had precancer polyps, and 4 had a malignancy. So 80 people ended up benefiting from needed care to either prevent cancer with the polyps or to treat cancer in the malignancy cases. At the same time, this effort narrowed the colorectal screening gap between white and racial and ethnic minority patients by more than 1/3, from 11.5% to 7.6% in a single year. So it narrowed the gap as well as increasing the colonoscopy screening rates, which sit now at about 82% in this system. The second example is more of that strategic approach, is related to using summary measures for health and well-being. So in our system, the mission statement for the organization is very much centered around health and well-being and improving the health and well-being of our members, our patients, and our community. But when you're asked to report on progress of that mission statement, it's hard to do if you don't have a set of measures that can actually represent that. So we ended up creating what we call our summary measures, which ended up being 3 indicators. One around current health, which is really an indicator based on a claims-based measure, using a crosswalk between the global burden of disease coefficients and diagnoses coming out of the electronic medical record. and then linking that to morbidity and mortality. So at the end of the day, it's a daily. We're reporting on a disability-adjusted life year. Future Health is a survey-based measure, largely survey-based, of behaviors. So the sustainability of health that you have is linked to the behaviors that you engage in. Physical activity levels, tobacco use, sleep, healthy thinking, which basically asks people to reflect on the good things that happen to them in their life, as well as a summary measure of adherence to clinical preventive services. And then, because we do have this well-being in our mission statement, how do we report on well-being? And it's through the single measure of life satisfaction. So without going much deeper into the methodology itself, some of the learning so far is that we can now actually measure, for example, health burden across the entire organization, but also then unpack it to look at different populations. So this is the example across the membership. The health burden is about 31% so it's basically 69% of what health could be, if you think of it in the positive. Of that 31% burden, in the English-speaking population, 45% of that burden comes from three major categories: musculoskeletal, psychosocial, and neurologic conditions. Among our Hmong-speaking populations, the same kind of drivers of burden, even though they're prioritized differently. So neurologic conditions is the largest burden, followed by musculoskeletal and psychosocial. And that only addresses 40% of that 31% on average. In the Spanish-speaking population, similarly, at 40%, that 40% of that burden is represented by these three, starting at musculoskeletal, and neurologic, and psychosocial. So it's interesting to see that the three drivers are the same, top drivers are the same, but they're not in the same priority. When we look at subjective well-being, on average, we see 43%, a very high rating of a 9 or a 10 out of a rating of 1 to 10. Those are the folks that are thriving in their lives. The ones that are suffering, least satisfied, are rating between 0 and 6. When we then look across insurance product, notice Medicare and commercial are almost identical, but Medicaid is lagging. So that's where most of the burden comes from in terms of well-being. When we unpack that by language again, we see that the Spanish-speaking populations do much better in terms of well-being indicators. The Hmong population, very much of that population, because it's a fairly small population, are actually suffering, 26% across the board here. So that's a significant driver there as well. I should note that these numbers are not adjusted for sort of cultural differences of how do you respond to the question of life satisfaction in the first place. So this is an example where we use summary measures as an indicator to set strategy on the business side of running the health system. So population health strategies across the system help us identify health and well-being disparities using this summary measure kind of approach, and then unpacking that and delving deeper into where these disparities are located. It also helps us look at data specific to populations of interest, again, addressing health equity issues. And it helps us assess the impact of interventions on population health burden. This is, for example, where the increase in preventive services would come in as an intervention to relieve burden. So moving back to the business side and the business and industry sector interest, we believe that public health can really leverage business and industry as a way of improving health and well-being across the community. But for that to happen, business and industry really needs to be actively engaged in this process of shaping a narrative around health equity. They are an important partner in preventing a widening of health disparities. And so what we need to see going forward is much more leadership initiative, leadership on the business side, connecting with leadership on the public health side to create partnerships that are really focused around, designed around creating shared value. That idea of creating shared value would make sure that there would be a substantial societal benefit to these partnerships, while also addressing the long-term viability of the organizations, the business organizations. So as I'm concluding, some of my key recommendations would be to first think about commissioning a review on the effectiveness of mass personalization approaches to improvement of preventive screenings. Secondly, to conduct qualitative research with public health and business leaders about the most important areas to address in achieving health and well-being, eliminating health disparities, addressing health equity, and attaining health literacy. Third, to make disease incidence an outcome of choice to highlight the impact of disease prevention, rather than focusing or spending too much time on prevalence alone. Fourth, to explore unexplained variation in health disparities related to preventive screenings using mixed methods and complex system science approaches, and particularly to think about that as that research could be done in systems that embed research. And finally, to deploy an iterative approach to learning, knowing, and doing in order to connect research to education and practice, to facilitate a much more rapid cycle between research and how to apply that research in practice. And with that, I'm going to conclude and look forward to discussion in a couple of minutes. Thank you.
Hello, good afternoon. My name is Vonnie Simmons, and I'm an associate member at the Moffitt Cancer Center. I'd like to thank the program planners for their efforts in organizing this workshop, and in particular, Dr. Antoinette Percy-Laurie and Ms. Kate Winsek, who are just wonderful to work with in the planning. Sorry, I just need to see how to advance the slides. Okay, perfect. This will work. Thank you. Okay, and I have no financial disclosures to report. So to set the stage for a discussion about smoking cessation, I think it's important to look at where smoking falls in terms of the preventable causes of cancer. As you can see from this slide, when we look at the different preventable causes of cancer, we can see that whereas 2% of all cancer deaths are attributable to the result of sun exposure, over 1/3 of all cancer diagnoses are caused by tobacco use. This makes smoking the leading preventable cause of death, and also means that if we could get everyone to quit smoking, that would eliminate 1/3 of all cancer deaths. The good news with regards to smoking prevalence is that we've seen a drop over the past several years. However, one important thing to note is that smoking prevalence rates do vary by race and ethnicity. As you can see from this graph, smoking rates are highest among American Indians and multiracial individuals, and the lowest smoking prevalence rates are seen among Asians and Hispanic individuals. I do think it's noteworthy, though, that among Hispanic individuals, there's quite a deal of variability dependent on sub-ethnicity. For example, Cubans and Puerto Ricans have very high smoking prevalence rates, whereas Dominican individuals have much lower smoking prevalence rates. In addition to overall differences in smoking prevalence by race and ethnicity, there are also significant differences in smoking patterns. As you see from the bar graph, what you'll note is that there are greater rates of non-daily smoking among particular groups, such as Hispanics and Blacks. And on the other side, you'll see that there's also variability with respect to cigarettes per day. So if you look at those adults who are smoking less than 10 cigarettes per day, you'll note that individuals who are Hispanic or Asian have a much higher prevalence of smoking at this lower smoking rate. So what it means is that these are differences in smoking patterns that must be considered as we think about developing targeted interventions for these populations. Fortunately, to be able to continue to support a decline in smoking prevalence rates, we have several evidence-based smoking cessation interventions to offer to smokers. These effective clinical interventions are summarized in the Public Health Service Clinical Practice Guideline entitled Treating Tobacco Use and Dependence. Importantly, implementation of these guidelines and of these evidence-based strategies really can be best thought of in terms of the 5 A's framework. And what this brief clinical intervention advises is that we should think about making sure that we ask about tobacco use with every patient, that we advise smokers to quit with a very strong and clear message, such as your provider, I must tell you the most important thing you can do for your health is to quit smoking. That we need to assess an individual's willingness to make a quit attempt, actually assist in the quit attempt, and arrange for follow-up. Now, in terms of these clinical interventions being implemented, we recognize that one key way to leverage the implementation of this is to think about the electronic health record and how we may use that to ensure greater reach of tobacco cessation services. With support from the Cancer Moonshot, the National Cancer Institute has really seen this as an important priority area with respect to cancer patients and has provided administrative supplements to 42 cancer centers across the country to help them to increase their implementation of smoking cessation services for patients, and in doing so, really improving the way the electronic health record is leveraged. These efforts are important because we know that only 25% of smokers are provided with some form of counseling or medication in their attempts to quit smoking. So in terms of assisting smokers, we have several evidence-based smoking cessation interventions. We know that the most efficacious intervention is going to be a combination of behavioral counseling plus pharmacotherapy. And pharmacotherapy can come in the form of several FDA-approved nicotine replacement therapies, such as the gum or patch or inhaler. But also we have non-nicotine medications available for smokers, such as bupropion and varenicline. So connecting to these services and being able to provide evidence-based services, again, goes back to the EHR as one promising strategy. In fact, one approach that many hospitals are now taking, which has been shown to be effective, is creating e-referrals within the electronic health record to tobacco quit line services. And this is particularly important in settings in which resources are limited. Despite the fact that the clinical practice guidelines really do apply to smokers of all racial and ethnic minorities, we recognize that there are several barriers for special populations of smokers in terms of receiving services. One such group that experiences unique barriers is Hispanic smokers. Despite being the largest and fastest growing minority group, there are surprisingly few Spanish language smoking resources that are evidence-based. We also know from the research that Hispanic individuals and those of lower socioeconomic background are less likely to receive tobacco screening and counseling from their providers. Also, Hispanic smokers experience a disproportionate burden of financial strain, and that increased financial strain has been shown to be associated with poor quitting rates among those who are attempting to quit smoking. We know that Hispanic smokers are also less likely to see themselves as addicted, which could be a potential barrier and may be related to more of the non-daily and intermittent smoking that occurs among this group. And that they are less likely to use FDA-approved nicotine replacement therapies. Finally, with greater acculturation, Hispanics demonstrate lower levels of perceived risks from their continued smoking. Based on these barriers, our research group has received funding from the National Cancer Institute and the State of Florida Biomedical Program to develop and test the efficacy of a smoking cessation intervention for Spanish-speaking smokers. Our first step in the intervention development was a very systematic process that we undertook, where we conducted formative work with Hispanic smokers to be able to transcreate a set of previously demonstrated efficacious materials for helping English-speaking smokers to quit smoking. And by transcreate, what I mean is to not only translate the information, but to culturally adapt our intervention specifically for this population. In conducting our formative work with this population, several key themes emerged that really were critical to adapting our intervention specifically for this population. For instance, one of the key themes that emerged was the importance of family. And family was seen to be both a motivator for helping people to quit smoking, but also in terms of dealing with stress related to family was seen as a stressor as well. Religion and spirituality was a very common theme expressed by our participants in the focus groups and was seen as a support when quitting smoking. In terms of triggers for smoking, there were some unique triggers that were also emphasized. For example, one was coffee, which is seen very much as part of the social culture and was a strong association and cue for smoking among several of the smokers that we talked to. There was also key stressors related to the immigration experience. These stressors were related to difficulties in language, problems with finances and transportation, and a lack of community really felt to be a unique stressor for this population. And finally, similar to prior research, our participants held several negative perceptions about pharmacotherapy for smoking cessation, and it expressed several myths, in fact, about nicotine replacement therapy. For example, there was a lot of concern that they would become addicted to whatever nicotine replacement product they were using, and there was also a fear that the NRT would not be effective based on things that they had heard. So as I mentioned previously, this information was very informative in adapting this intervention for this Hispanic population of Spanish-speaking smokers. And in comparison with our English language intervention, which was shown to be both efficacious in helping people quit smoking and very cost-effective, we made two key changes based on our formative work. One was that we created a booklet as part of this extended self-help intervention that was specifically designed for friends or family members who were supporting the individual in quitting smoking. The other thing about this self-help intervention that we changed based on our formative feedback was that we learned that some piece of personal connection was desired. So whereas our English-speaking intervention was purely done through the mail, we added a brief telephone contact in the beginning of the intervention to establish rapport and introduce participants to the intervention, as that was feedback that we got during our formative work. We also got a lot of great suggestions with respect to the visual components of the intervention in terms of wanting bold and vivid colors, wanting symbols of different Hispanic sub-ethnicities, and showing individuals with the great heterogeneity among this population. And also to think about increasing the number of interactive components that were complete for participants to complete in this self-help intervention. We are currently have completed recruitment for the randomized controlled trial phase for this study, in which we are randomizing individuals to either usual existing care, which is an NCI booklet, or our targeted intervention. And after participants enroll and complete a baseline, we conduct follow-up assessments every 6 months thereafter to capture smoking status. And we do conduct biochemical verification of smoking status among a subsample of participants as well. We have recruited over 1,400 current cigarette smokers who are Spanish-speaking across the country. About half of our sample is female. And we do believe we have reached quite an underserved population in that 1/3 has less than a high school education, and 41% of our sample has a household income below $10,000. We have a great deal of sub-ethnicity variability within our sample, which is very important to us and really advances the field in that we hope to be able to look at how our intervention might be efficacious among different sub-ethnic groups. Our population also has a significant tobacco smoking history. So before I move on, I just want to underscore that this represents one of the few randomized trials that have been done with this population, and so really a gap and area for future research is to continue to look at developing targeted, efficacious interventions for this population. So another special population that deserves attention due to high smoking prevalence is among sexual minorities. We know that the prevalence rate is higher. For example, 20% of LGBT adults smoke cigarettes as compared to 15.3% of heterosexuals, and this can indeed contribute to health disparities seen among sexual minorities. As many of you, I'm sure, are aware, the landscape of tobacco use is shifting quite rapidly with the growing trend of electronic cigarettes and increasing popularity. And while ethnic and racial minorities are actually less likely to use e-cigarettes, LGBTQ individuals have higher rates of e-cigarette use. And although there are lack of data with respect to e-cigarettes among that population, it's clear that there are many barriers to tobacco cessation and motivators for smoking that have been documented in the literature for this population that very well can be related to e-cigarette use as well. These examples include just feelings of discrimination, negative reactions to disclosure of sexual identity, discomfort with sexual identity, greater rates of stress, depression, and alcohol use, and a great deal of targeting of tobacco companies directly to this population. We had an opportunity to use baseline data from an ongoing randomized controlled trial that we have testing the efficacy of a smoking cessation intervention for dual users of traditional tobacco cigarettes and e-cigarettes. In this study, we had over 500 participants who identified as LGB, and so what we were interested in doing is exploring differences among LGB and heterosexual participants in our sample. And what we found is that these populations demonstrated similar smoking and vaping patterns. However, there were some significant differences as well. Sexual minority individuals in our sample demonstrated shorter histories of smoking and lower nicotine dependence. However, we also saw that after starting e-cigarettes, they demonstrated a lower reduction of traditional cigarette use than what we saw with heterosexuals. We also found that sexual minority individuals reported to a greater extent that they were vaping in places where smoking was forbidden and using vaping as a substitution for smoking in those situations, and that they were less motivated to quit smoking. So together, these preliminary studies suggest to us that sexual minority individuals may be at greater risk for maintaining dual use of both traditional tobacco cigarettes and e-cigarettes, and really underscores the importance of future research on differences based on sexual orientation. And also draws attention to the fact that as we develop targeted interventions, we may need to consider further e-cigarette use patterns within that as well. So I'm going to switch gears just for a moment and talk about lung cancer because it represents the cancer type that obviously is most strongly associated with smoking. In fact, 90% of men diagnosed with lung cancer have a prior history of smoking, and 80% of women diagnosed with lung cancer have a prior history of smoking. There are also significant health disparities, as African Americans are more likely to develop and die from lung cancer than persons of any other racial or ethnic group. And as we've talked about already today, the causes of these poor outcomes are likely multifactorial. Certainly there are healthcare system barriers such as lack of insurance and lack of access to care. But as a psychologist, other areas that can be seen related to be a barrier and result in late presentation of disease has to do with beliefs and attitudes and cultural factors. For example, fatalism is a very common belief among minorities, which is the fact that you believe that individuals lack power over their health or their fate. So what previous research has suggested is that minorities are more likely to endorse the belief that everything that happens is part of God's plan and that they have less power over their health. We also know that medical mistrust is a common barrier in terms of thinking that the healthcare system and its employees are untrustworthy. We know that minorities are less likely to agree with the belief that doctors have their best interest in mind. And these beliefs can result in delays in treatment and less likely to receive treatment. When it comes to smoking, there is also an unfortunate paradox that occurs with African American smokers. Despite smoking fewer cigarettes per day, smoking fewer days per month, having greater motivation to quit smoking and greater attempts at quit smoking, unfortunately, African Americans are less successful in quitting smoking and more likely to die from chronic diseases. And similar to other vulnerable populations, we know that they are subject to targeted marketing efforts from the tobacco industry as well. One promising, relatively new step towards preventing late-stage disease presentation came with the National Lung Cancer Screening Trial Study, the NLST study, in which current or former smokers were enrolled, former smokers who had quit within the previous 15 years with 30 or more PAC years. The results of this study suggested that LDCT scans, low-dose CT scans, resulted in 15 to 20% lower risk of dying from cancer as compared to chest x-rays. And as we've talked about today, this is now given a grade B rating in terms of the U.S. Preventative Task Force. So our research group has actually looked at barriers to screening, and we have talked to high-risk smokers to try to get a better understanding of why uptake of screening is so low. In fact, less than 2% of smokers that are eligible have received screening. And some of the key barriers that emerged as part of our work is that there is a lack of knowledge or existence that a lung cancer CT screening test even exists. What is lung cancer screening, our participants said to us. Certainly there was a lack of knowledge between the difference between a chest x-ray and a low-dose CT scan. None of the smokers that we interviewed were recommended screening by their providers, so there was lack of provider intervention. Lack of knowledge for who qualifies for screening. Concerns about insurance coverage. Fear of results. And again, really related to that knowledge barrier and the lack of communication with their provider. As one participant said, I had my physical this morning and my doctor knows I've been smoking for over 60 years. So how come she didn't suggest to me a low-dose screening chest CT? If you smoke like I do, why wouldn't your doctor say something? As we think about low-dose CT screening, we also need to think about how there may be increased potential for health disparities as well. So for example, given the current criteria for low-dose CT screening and the patterns that I've described for African American smokers, we might wonder if the 30 PAC years criteria would result in fewer screens. And we know also from prior research that African Americans are more reluctant to get screened for lung cancer due to fear of disease. So finally, in terms of key recommendations, there have been many common barriers across groups, such as discrimination, but also very unique barriers. There's really a need for more culturally adapted interventions, and we really need to do some work to dispel myths about FDA-approved nicotine replacement therapies among these groups. And as the landscape continues to change in tobacco, we need to track and keep account of how minority populations are using these products and what impact it has on smoking cessation. There was a lack of knowledge of lung cancer screening, so certainly there needs to be efforts towards public health campaigns. And finally, as newer screening tools become available, such as lung cancer screening, we need to pay attention that they're not being implemented in a way that could potentially widen health disparities due to unequal implementation. Thank you very much.
Good afternoon. I'm Monica Baskin. I'm a professor of preventive medicine at the University of Alabama at Birmingham and also the Associate Director for Community Outreach and Engagement at the O'Neill Comprehensive Cancer Center. It is certainly my pleasure to join an illustrious group of panelists already today and for tomorrow to talk to you a little bit about social determinants of health in rural communities. So much of what I'm actually going to talk about today we've already gotten snippets throughout the day, and so I want to highlight just a few things that I think are really relevant to question 2. So I have no disclosures to make. So a lot of what you've heard already today has been focusing on what are all those different factors that can influence health. So we know that medical care, both the quality and access, is relevant to our health. But also individual behaviors like smoking and diet and physical activity and screening behavior. But there are other things that also have been noted earlier today that influence our health. So the communities and environments that we live in, the policies and the institutions and the larger issues that we call the social determinants of health also play a significant role. And one of the things that I think is really relevant to our conversation today is that there's some research that shows that as little as 10% of health is related to medical care. So yes, there's certainly a need to improve the care and treatment that individuals have, but we've got a lot of other things that we can intervene on that may be just as or more effective in terms of generating health equity. And so this is highlighted in this particular study in this graph, looking at, well, what were some other things that were attributable to death in the year 2000? And so looking here, you'll see that low education, racial segregation, and low social support were associated with more deaths than lung cancer in terms of mortality in the year that this study was done. In thinking about rural health in particular, there are 3 buckets that I list here that are really relevant in terms of social determinants. So there's the social environment, which includes things like your income and employment, also educational attainment, and then health literacy, which we heard talked about earlier today as well. Then there's the physical environment, so the places where we actually live, work, play, whether or not there's adequate infrastructure that's available in those areas, the air quality, the water quality that may be influencing the physical environment, as well as access to transportation. And then that last bucket, again, clinical care. Both do you have access to it and the quality of care when you do go in to receive services. So I think the overarching theme here for me is that place matters. So we're talking about all the ways that we define place, and for here, I'm using the example of cancer incidence. So this study really looked at the difference between living in a metropolitan area or urban area versus a rural area, and what the investigators saw was that there clearly is a difference depending on where you live in terms of cancer incidence. So sometimes that means that if you're in urban areas, you have a higher chance of actually having different types of cancers. Sometimes it means that your risk, if you're in a rural area, is lower. But in general, across each of these cancers, you see that there is a distinct difference in terms of place, whether or not you reside in a rural area versus an urban area. But when you look at cancer mortality, so overall there may be some differences in terms of cancer incidence, but in cancer mortality, the picture is a little bit more clear, that if individuals live in spaces and places like rural Appalachia, the chances are much higher to be
to have have a higher rate of cancer mortality than if you're living in urban areas or non-Appalachian communities. So places like where I am in Alabama, where my colleague, Dr. Vanderpool, is in Kentucky, you see very high rates of cancer mortality in these areas just by way of where you live. And so this is looking at it as the overall state. But there's also data that when you look at it by county, you'll see the darker red counties are the ones in which you see the highest cancer mortality across the U.S. And again, similar to previous slides that you've seen about our nation, you'll see there's a concentration of where we see some poor preventive behaviors. We also see higher rates of multiple chronic diseases, diabetes, heart disease, as well as cancer. So let's then we talked about place, so where you live in the country, which communities you live in, even within a particular state. But one of the other things that is also similar in some of these maps is who is living in these communities. So this is a map of Black or African American individuals looking at the latest 2010 census data. And we'll see that some of those same areas that were highlighted in previous maps of the U.S. are in these regions where you have higher concentrations of Blacks or African Americans. And we certainly know that that population in particular has higher rates of many of these kind of chronic diseases that we've been talking about today, and also have higher mortality as a result. So I have us to think just a little bit about this intersection between race, place, and cancer. And this particular table really highlights that very nicely, I think. So this is looking at cancer mortality, looking at all cancers, and then some select cancers here with regions called the Delta region, so 252 counties across the country that make up the Delta. Then it's compared next to the U.S. as a whole, and then looking at non-Delta counties, and then non-Delta counties within the Delta region, and then the Appalachian counties separated out. So what you'll see is that across each of these different areas, with very few exceptions, you'll see that if you are a person living in the Delta or the Appalachia region, you are more likely to have higher rates of mortality across these cancers than any of the other groups. So that's the place. You'll also see that there are other differences there by whether or not you're white or Black as well. So it's hard to tease out, is this only about a racial issue, only about your place, in terms of trying to figure out where the differences are. So it's that intersection there that I think is one of the things I want to highlight for our discussion. The first of those buckets that I mentioned in terms of social determinants was your social environment. So this is data looking at metro versus non-metro communities, and we'll see across the U.S. that the highest rates of poverty are in those non-metro communities. But in the area that I work in, and largely the Mississippi Delta and the Alabama Black Belt, you'll see that there's even a greater percentage of individuals that are living in poverty. So income, employment, all of that we know already influences who is healthy, who gets sick, and who's going to live the longest. In terms of the physical environment, some of the research that we have done over the last several decades within the Alabama and Mississippi areas has been looking at that physical environment. So this is just one study where we actually use a combination of some, actually a mixed method study where we looked at photo voice and having individuals in the community go out and take pictures of their community environment to see what was supportive of a healthy environment and preventing cancer. And then we also use some more objective measures to look at walkability and connectivity within the environment. So overall, what we see, very much in general is that there's a lot of heterogeneity within rural communities. So one of the questions that came up in an earlier panel was about, does a rural community look the same in the Northwest as it does in the Southeast? And the chances probably are that they are not the same, and that we have rural, but rural is very, is very broad definition. So we have frontier areas,
We also have areas that are sort of considered to be maybe smaller towns, and those are very different. But in the communities that we have worked in, largely within the Cancer Center at UAB, we find that many of those communities, the infrastructure really is not very conducive, for example, for the prescriptions we give to get out in your community and walk. We have individuals living in rural areas where there are highway systems, they're not sidewalks or buffers. It's literally not safe to walk. We also have areas where people are living in areas that are near swamps and so forth, so things like snakes and other things come out that are factored in there. And then even when you have communities where the built environment has recreational facilities, great equipment, you'll see from a couple of those pictures, when it rains, that infrastructure is not there, and therefore you end up with lots of flooding, and it makes it more difficult for people to utilize those resources. Another area of the physical environment that we looked at was about the nutrition environment. So we know that one of the ways to help to prevent a number of these chronic conditions have to do with our diet. So similarly, we asked people to take pictures in the Photo Voice project about what's in their environment to consume and to follow the prescriptions that we're giving around, consuming a healthy diet. And what we found both in the qualitative work and then again some quantitative work where we dispensed local community members to go out and measure what was in their grocery stores, overall we found that again, there's a great deal of variability, but in general, people in these communities were not able to follow the prescriptions we were given, even if they really wanted to, because of the lack of access to healthy, affordable foods with a lot of variety. What we also find is that oftentimes many of us who don't live in rural areas, we have this perception that, you're in rural communities, got all the land, you can have gardens and so forth, and that was not necessarily the case in many of the communities that we work in. So there were some smaller community gardens or even home-based gardens, but oftentimes people were consuming from stores, both smaller grocery stores and convenience stores, where there were lots of red meats, organ meats that were being sold, lots of fatty meats and so forth. And then there were also areas where there were a lot of fast food restaurants. So even when people were eating out, so not only the food deserts in terms of not having fresh, affordable foods, but you also had what people call food swamps, where you have a lot of restaurants in which they were high calorie, high fat, and so forth. So again, a good deal of variability, but as we're thinking about people being able to follow our prescriptions, some challenges there within our rural community. And then the last bucket of those social determinants is around clinical care. So often we've already heard that a lot of, there's missing a lot of primary care within rural areas. We definitely know that there are even greater constraints in terms of specialty care. But it's also important to note that over the last couple of decades, we're also seeing the closure of many rural hospitals, and in particular the areas in which I work in the Southeast. You'll see the greatest number of hospital closures that are happening. So thinking about when people don't have primary care or don't have specialty care, or even if they can't get in those urgent areas to have these procedures, they're having to drive, several hours away. That plays a role in terms of late stage diagnosis, but also in their treatment. So on the brighter side, what are some things that we've found in the evidence in terms of how to address some of these issues? And these are just a couple of things. Some of them have actually already been talked about today. So culturally relevant prevention strategies we know work. Our team has utilized a community health advisor model for nearly 2 decades, in which we've been able to see a significant decline in the disparity between Black and white women receiving mammograms in this span of time that we've used those community health advisors. We've also utilized community health workers, so people who are much more formal, have a little bit more advanced training, that are connected in with the health system to help to navigate patients. And that care has also shown in the evidence to be able to improve the treatment that's happening. It also has been shown in a larger CMS grant to reduce costs, especially when you're thinking about later stage cancer and hospice care, to try to minimize individuals coming in for treatment in the last months or weeks of their life. We also have seen that mobile screening units, so mammography units, and then even more recently we've seen the low-dose CT units to be able to go out in those areas that are much more remote, so that individuals are not having to drive multiple hours, or particularly when transportation is limited. So those have been shown to be quite effective in terms of increasing the reach of these much-needed preventive services in these rural communities. Another strategy that's been used is sort of non-traditional settings for delivery of health messages. So it was mentioned earlier in the little the vignette from the NHLBI director about utilizing barbershops or beauty salons, churches and other non-traditional places. So in doing these preventive strategies, we've got to go where the population is, as opposed to expecting them to come in to our clinics. And so that's another strategy that's been successful. And then lastly here, innovative channels for delivering health communications messages. So there are a number of studies that have shown that radio dramas or film, other creative ways to get across messages beyond pamphlets and things of that nature have been very much able to resonate with certain groups, particularly in our rural, smaller communities, where they want to get together around a social event and have something that's more than someone to sort of going over and over again, the cancer messages. So what I highlight here are sort of three gaps that I think exist in this population. The first of which is what role does intersectionality play in the uptake of evidence-based preventive interventions for rural populations? So much of the data that's been presented so far, especially around question 2, so there are more studies, so we're glad that there are more studies, but the overwhelming evidence is that it was, of low quality, and so there were lots of mixed results. And one of the things that I would posit is perhaps because we're lumping everyone together. There's a great deal of heterogeneity within populations, and if we don't account for that, we may not actually know what works well for whom. The second bullet is about, what are those most impactful individual and or social determinants to intervene on for maximum uptake. So we know that we have limited resources. We're not going to be able to hit everything in that continuum around social determinants or all of those different behaviors. So I think we need to know which are the ones that are giving us the most bang for our buck. And then the last gap, I think, is around what infrastructure is needed to sustain prevention services in rural communities. Again, as rural hospitals are closing, you have a limited number of primary care. What's that infrastructure that's going to be able to stay there and be there and be embedded that we can, place in and start partnering so that those strategies are there after the grants are over and other things are not going to be around. So with that, my recommendations are, one, conducting more community engaged research. We heard earlier today how important it is to have the people that we're intervening on to be at the table and help us to design those that work. So more community engaged research to examine the impacts of intersectionality on preventive services. We also, my second recommendation is about demonstration projects so that we can start to tease out, well, what are the things that may be most impactful in those culturally adapted interventions. And then lastly, I think to the point of the first presentation within this panel was around these, perhaps doing more public-private partnerships. So how can businesses be engaged with academic medical centers and clinicians to be able to deliver much-needed high-quality medical care into remote areas that will improve not only the business in terms of the workplace and the workforce, but also the larger community. And with that, thank you.
Thank you to the speakers. That was remarkable. Let's start with questions and comments from our panel.
Thank you, for, excellent presentations. And thank you, Dr. Baskin, for elaborating even further on my question relative to the heterogeneity among the rural population. And actually, my question relates specifically to what you've mentioned. And I'm not familiar with your direct work at UAB, but I do know the University of Alabama, Birmingham, and Tuskegee and Morehouse have several partnerships that are looking at disparities in many of these arenas. And so my question is, two questions, related to whether or not you see heterogeneity among the rural populations in Tuskegee, in Atlanta, and in Birmingham, similar to what I asked North versus South. And also some of the interventions that you're suggesting, whether or not you've tried them in these three regions or not, and whether or not you've seen similar outcomes, because the disparities are grievous in all three areas, even though the characteristics of the populations in these areas are very different.
So, yes, thank you for the question and a chance to elaborate a little bit more. So, in the partnership that was mentioned, so there's two states then involved, Georgia and Alabama, in those partnerships. And I think there is some heterogeneity even within those two states. And then, again, we've also worked in Mississippi. So thinking about that region, there are distinct differences, I think, that I've observed in those three areas. Some of it and some of my thinking about how things might be a little bit different than the Northwest rural areas is also, again, the makeup of the racial and ethnic population, the history related to slavery and discrimination and Jim Crow, the issues around racial segregation. So in the graph that I showed in terms of how that's still a major issue in terms of its association with mortality still is on top of mind in communities that we work in across, particularly in Alabama and Mississippi, that the communities, even the rural communities where there might be more diversity so that you have, either an equal distribution of whites and blacks, you still see the community, the physical environment is still very much racially segregated. The amenities that are available in the side of town or the side of the tracks that are for African American communities, the amenities are much more limited. Those are the communities that you saw the pictures where the infrastructure is not as nice. So I think there are some issues there. The things that I think almost all the panelists have brought up around medical mistrust. So you brought up that we have a partnership with Tuskegee. There's still vestiges of people having real grave concerns around the Tuskegee syphilis study and experimentation, being involved in clinical trials. So yes, there is heterogeneity within those three states that I've worked in. There are some things that are the same. And then one of the things that, certainly in my role in the Cancer Center now, as we are, our catchment area is the entire state. So we also are working in largely white rural communities within the state of Alabama. And so those issues are also different. So I think, to my point in the recommendation, you have to have community engaged research. You go into one community, you know that one community. And so that's how the community engaged research to help you to understand what are the subtle nuances, how do you need to culturally adapt for that community in order to ensure the uptake.
Hi, thank you. This was really great. I think it was Dr. Simmons, you got me thinking more about this issue that is a concern of mine quite often when you were talking about increasing the availability of low-dose CT scans and the degree to which we need to be cautious about making something like that widely available so as not to increase disparities, right? So could you talk a little bit about the degree to which or how you think about in interventions, in the interventions you're describing and what you recommend, how you think about that at the same time, that we mustn't inadvertently increase disparities through our interventions, and how you would recommend folks thinking about that?
Great question. And I think that it really relates to some of the things we've talked today around patient and provider communication. So one thing that I didn't have time to talk about was some of the data we collected also with primary care providers around this topic. And there really was a lack of knowledge and prioritization of lung cancer screening, particularly with dealing with high-risk populations who come in with several comorbidities. The conversations around screening just aren't happening. And what we know in terms of smoking cessation is those conversations tend to happen less frequently with minority populations. So that's something that I worry about in this space as well. And then in terms of looking at the actual eligibility for screening and appropriate minority representation in trials, and how screening criteria may need to be adapted for minority populations who have very different smoking patterns. That's something that I think deserves future research attention as well.
I have a question for, I think, Heidi and a couple of panelists around this issue of mass customization. I don't know if it was intended, but our literature base is getting more robust as we work through our questions. And several of the speakers this afternoon talked about the need for adaptation of interventions and instruments either to sub-ethnic groups or to communities or to geographical areas. When does that stop being a research study, which NIH should support generously, and when does it start being implementation, improvement of care? And is there risk that we can actually slow things down by making everything a research study? Which gets to future research needs, which we're tasked with.
And one thing that I think about as we talk about adapting interventions is similar to efforts around personalized medicine or precision medicine, we might need to start thinking in the prevention arena along the same lines, that to make sure in terms of populations that have unique needs and barriers, that our interventions are adapted to meet those unique needs and barriers. And we might think about also leveraging the electronic health record system to create targeted education that providers can relay based on some of those unique concerns as well.
So I agree with that idea that we need to be careful. At what point does something like a research project turn into really operations? And I think that's sort of the place where implementation science, dissemination science sort of comes into play, but doing it in a real world setting so that you can understand what are the principles that operate whatever is happening, as opposed to finding out that there's one place that does it this way and then needing to redo everything to find out there's another place that does it a little differently. So I think figuring out what are these cross-cutting design principles is a very important area of research. And to do that well, you almost have to be in the real world setting to figure it out.
And I would just add, I think it's the same thing around, mentioning the idea of precision medicine, but precision population health as well, or precision public health. I think that's really the idea, and even specifically my wording on the recommendation was sort of demonstration projects. So I do think we have the evidence and the types of adaptations that at least I'm thinking about are really in that realm of dissemination and implementation. So how do you get these evidence-based treatments out to the populations that need them the most? And your delivery of that may need to be changed depending on your population.
Thank you. Let's go to members of the audience. Dr. Parchman.
Hi, Michael Parchman. I want to return to the lung cancer screening and health equity conversation because I'm a little concerned as a primary care physician who's spent my lifetime in academic health centers caring for vulnerable populations that we consider what will happen if we push the lung cancer screening conversation. What will it displace in the primary care setting? And for the patient who has limited resources, what will they choose to replace getting that lung cancer screening with? So if you're limited in terms of transportation and time and money, and you decide to get the lung cancer screening, will you eliminate other preventive services because you've used up all your time and your resources on that preventive service? So how do we prioritize?
I think certainly the issue of competing demands for both the providers and individuals is certainly a real one. And in speaking with some of the providers that we did, they felt that there were ways in which, again, pointing to the electronic health record, could be used to help prioritize what screenings may be most appropriate for the patient. And they also recommended having appropriate patient education tools in waiting rooms so that they could prime individuals to have those conversations with their providers. So, but certainly it's a real concern as additional screenings become available, trying to prioritize. But I will note that in speaking to the high-risk individuals, they were very hopeful, and as smokers feeling that finally a screening was available for them, that they were unaware of it, and many were eager to get it, but they just didn't know about it. But again, a lot of hope around, there's finally a screening for me.
Thank you.
If I can add to that, I think actually what you're asking is what's the solution to a replacement issue of one service. And so if you do this one, you're going to have to do something else not, because there is no room for it anymore. Which to me begs the question, does that really call for a system redesign? And that's the tougher question to handle, because the solution isn't so readily available, but that's really what needs to happen.
Nico, I'm going to be a little bit devil's advocate here. I don't quite believe what I'm going to propose, but it seems to me that the whole business orientation of the bottom line being financial gain and profit is anti-community and anti-equity, in the sense that companies are more interested in having cheap labor and making profit than in promoting equity and community. So the question I would like to ask you is, how do we, and there are certainly some counter examples, the Gates Foundation, but how do we create an orientation in our business community that makes them community oriented, that makes them value equity as a project, as a goal?
Thank you for that question, Robert. This is a big issue. So by no means was my intention to make it seem like this is an easy deal. I think it's a dialogue that needs to happen and needs to evolve. I think there are companies today that are on the, that are really pushing this idea and align their efforts with things like the social or the Sustainable Development Goals, the United Nations approaches, and the idea that you can do lots of good for society and thrive as an organization, as a company. To do that, you need to have a long view, which flies in the face of quarterly returns for your shareholders. And that's where I think a lot of organizations get sort of, okay, well, that's not going to happen because we have to get, this done by next Tuesday. So that kind of a thinking isn't going to do this. I think we need to continue that dialogue around what's the reason for business in the first place. What's the, and those are lofty kind of, questions to put in front of a small business owner. But if we start thinking about organizations, associations, business associations, chambers of commerce, and start that dialogue there and continue to push that forward, I think there's an interest there, a pent-up demand almost, to do well, to do good for society in general. there is another sort of phenomenon in the marketplace, which is the younger generations are coming in with a very different attitude. So the younger generations come in and oftentimes interview the company. You know, how are you operating? What kind of operating ethic do you have? Are you going to make this place better, as opposed to are you just here for quarterly shareholder return? And that's a very different kind of dynamic as well. If you're interested in top talent and you want to attract that to your organization, you're going to have to pay attention to that. So larger organizations tend to make more of an effort to work with that kind of a context in the communities that they're in, as opposed to perhaps smaller companies that don't have the resources to necessarily respond to that. On the other hand, smaller companies tend to be more connected to their community in the first place. So I think there is room and opportunity there to really change the dynamic. And I haven't even talked yet about the changing nature of the community social responsibility reports, the changing nature of how organizations are reporting in general on the business that they're in, which increasingly is starting to include health and along with safety.
So I just had an additional thought about that. So, we're thinking about, what's good for the community and in terms of business. So whether or not a business is going to endorse social responsibility or a value around equity, we can probably put that aside. But if they are having wellness programs, ensuring that the workforce is healthy, that they have a diverse and inclusive workforce that we know leads to a better bottom line, whether or not they endorse a social responsibility or not, that is good for the community. So the community having viable companies, having people to go back and invest in the communities, to have better resources across the board, that still is going to be a benefit to the community and to the outcomes of the individual, whether or not that company endorses and says, we're explicitly doing this for health equity.
Yes.
Robin Vanderpool, University of Kentucky. I wanted to revisit the comment that Michael Parchman made about the having patients choose and replacement, and it made me think about two concepts we really haven't brought up yet today, and that is overscreening and de-implementation. So, I think about often, how many times I keep hearing in the clinics and programs that I work in that they're still doing annual Pap tests because the insurance companies will pay for it. And, we know the guidelines have changed, that some women only need Pap tests every, 3, 5, it depends on obviously their age and their HPV testing status. But I think about we may be making patients choose when they don't have to. We shouldn't be pushing some of these tests on them anyway. Or their age, breast cancer screening at an older age. I mean, I know that's probably another talk for another day, but I'd love the panel, if they could, to just think about areas where we may need to be de-implementing some of these services.
So I think that is a great topic to chew on for a while. But actually, there is an entire research portfolio there too around de-implementation in of itself. But I think what you're really asking is how do we make it so that it's simple for people to move through the medical care system and affordable, so that you don't have to make choices about what to get or what not to get based on your $5,000 deductible, which allowed you to have insurance, but you can't afford care. And again, that gets me to the need for redesign around these systems. The systems don't seem to make much sense anymore. So that's where I keep coming.
And I would disagree. I mean, I think we certainly need to look at that. So some of our older patients in the rural areas thinking about even colorectal cancer screening and still at, well into 70s and so forth, say, I need my colonoscopy, and trying to have that conversation. Many of them whom don't really go in regularly for primary care, for someone to have that conversation about, well, is that really necessary, that informed decision making? So I absolutely agree with you. And particularly in communities where there's lower health literacy, when we keep pushing, cancer saves lives, and all these messages, and then we say, oh, there's a screening out there, but you don't need to get in anymore, it's really difficult. So our messaging has to adjust.
Thank you. Yes.
Yeah, thank you. My name is Li Yang. Thanks for your presentation. I just wonder, for all your research, how do you verify your data is correct and your personnel, staff, or aid, or government, anybody involved, they are accountable? And then from there, I think in your society, in your community, or in the area you want to do research, or actually from local to federal to global, everybody, especially those areas who is advocating for PPP, public-private partnership, whether they involve any official misconduct. Let's say there's a group or gang from private to government, they go work together, they take, let's say, conspiracy with police and force arrest with people, and handcuff, shackle them to the detention center, to the jail, or to the mental hospital for months and months without any criminal charge. And whether anybody's suggestion that there's a school student or university student who say something against official misconduct, maybe staff or teacher is wrongdoing, instead of helping the student, they are just label them in mental health problem. And then maybe this involves a lot of social program, benefit problem. They don't give it to the target population, so they will be instead deprived of their property, their asset, their account, their car, and their civil rights, their human rights. So have you really examined those? So you'll be sure every personnel involved in your district jurisdiction, from core personnel to the CEO or civic organization or NGO, they use a PPP and doing something right. And if
thank
you
you very
don't
much.
have anything right, you go to examine the local city town center, and also mention about the National Academy of Science. They can conspire with police, they can force police report and send people to jail. And that's
Thank you,
National
ma'am.
Academy
We
of
need to move
Science
on.
doing scientific research. So I hope you examine those and see if we can respond to their accountability.
Thank you very much.
Thank you.
Comments from the group?
So just a couple of quick things. I think in the approach that we've certainly used, I mentioned before, we have a community engaged research process where we have partnerships with individuals that are in the community. We hire local community members, and we use volunteers. We also have, over the course of 20 years in the 20 or 30 plus counties that we've worked in those two states, we have formed partnerships with local leaders from the faith-based organizations to public safety, to government, to secondary education and primary education and so forth. So we have partnerships. We definitely have a practice around being very transparent and having conversations, being open to, bringing up issues that may be very difficult and challenging. We have a community advisory board. I can say specifically in the project that I lead, I tell the advisory board to hold me accountable for things that, I'm saying I'm doing in the community. I think, to the larger, my response to your larger, commentary is that, yes, we all need to be holding one another accountable for what's happening. And when we engage the community instead of working on them or, to them and have them with us, we're partners, and you're less likely to have some of the atrocities that may have happened in the past to reoccur.
I would just add that in terms of responsible conduct of research and research ethics, it's really a matter of continuing education and focus, and something, we take very seriously, and also ensure that staff and even students and trainees who work with us learn the culture and learn about conducting responsible research very early on in the process.
Thank you. I have a question for the group, and this is a clinical anecdote from yesterday's clinic for me. A patient with multiple chronic conditions was telling me how she was having difficulty coming in to see me. And one of the reasons she was having difficulty was she's a school teacher in an adjacent unnamed county. She had to actually hire a substitute teacher that came out of her take-home in order to get the time to go to a physician's visit, and which shows sort of publicly funded folks moving more and more to what is often called the gig economy. And while we would like employers to support healthful behavior, I'm concerned that the environment is actually moving in the opposite direction. And what is our role as health equity researchers in those issues? I find it hard to imagine how one would research that. I guess one could investigate from an observational study how that does affect care access, those types of negative incentives. Is there work being done in that area?
Well, I can't speak to the work being done currently, but there are models of alternative delivery. Immunizations at pharmacists that are open till 10. In Oregon, contraception is also administered through pharmacists, open till 10. There are other ways to do this that take the burden off the traditional appointment with the PCP during office hours.
8 to 5.
And there are probably more models that could be tested and used. We just haven't quite stretched that far yet. But those are encouraging first steps, and they seem to work really well, at least in the health system I've been involved in.
So the burden is on us in the delivery system.
Well, if we can get some evidence to show this works and people have access, and these barriers that you described with getting off work, which is huge, that can change things, I think. So that's one way.
Thank you.
Yeah, I would think that research can be very helpful in making sure that the outcomes, the negative impacts, are visible, whether that's on experience, whether it's on health outcomes, or other burdens of a population. So doing research in that area, I think, would help make the case that this is a burden on multiple stakeholders across society.
I recall, too, in doing the interviews that we did, several patients mentioned, offering screenings after work hours sure would be helpful in terms of my availability to do so.
It shouldn't all be about us.
I was going to say, and one other thing that I know is happening in a few areas that we're working in is having school-based healthcare. So that's another area where, having providers that are within the school and having Medicaid to actually accept the school-based healthcare as the primary care provider for children, and then we're trying to, open that up for adults as well.
Yes, ma'am.
Hi, thanks so much for these really interesting and comprehensive talks here. I'm curious whether you can speak to the mechanisms through which disparities influence the ultimate outcome, like receipt of some sort of preventive service, right? When we might be taking an approach like changing the default and creating opt-out policies and removing the individual decision component, as one mechanism, as opposed to taking a more kind of promoting shared decision-making, informing the patient, and going that route to achieving our ultimate outcome, and whether disparities might play a different role in each of those approaches, and if we might want to think about the importance of considering disparities when we're making our decision about the intervention approach that we take.
That's a good question. And speaking with tobacco cessation as a preventive service, exactly what you said in terms of moving towards an opt-out approach is really what we're looking forward to. I can speak to our own cancer center and several oncology settings. In terms of the impact that we know continued smoking has on cancer outcomes, it's really critical that every cancer patient is provided evidence-based treatment to help them to quit smoking and maintain their smoking abstinence. And so rather than offering it to patients, we're really moving towards an opt-out approach where every patient is given that opportunity rather than having to opt into it. And we think that that will certainly have a positive benefit in terms of health disparities. As we know, those conversations around tobacco cessation happen less frequently with minority populations.
Thank you. And last question.
Hello, everyone. Happy Juneteenth. My name is Shanina Armstrong Merchant. I am with HRSA, and I'm a doctoral student at Morgan State. Dr. Baskin, you mentioned a recommendation for additional exploration of telemedicine, mobile units, et cetera, and I think others mentioned it as well. But as many people now have cell phones, have you seen many evidence-based interventions that are incorporating cell phone usage or video conferencing methods as part of the intervention?
So I'll give a shout out and tell you to stay till tomorrow. Good colleague, Dr. Gary Bennett, is certainly going to be talking a little bit about his work in primary care around using more mobile interventions. But yes, the evidence clearly is growing in that area, even in some of the more vulnerable populations that we've been talking about. So rural areas, African American women in particular around obesity, which I think is what Dr. Bennett will be talking about. A lot of those interventions are now being, the findings from these RCTs are coming out and with some really promising results. On the telemedicine side too, especially I know at our academic medical center with as many rural hospitals that have closed, that's been a major push that we've been putting out. And also thinking about, cancer treatment and oncology, there's not enough individuals in that specialty area. So we've been getting a lot of traction to tell people you don't have to drive 4 hours to come to Birmingham to get your care, that our providers can work with the providers there, give them additional continuing education and consult. And so people can get care where they are. Well, we know, sort of as a psychologist, we know that it's better for them to stay in the social support system that they have.
Could I just add, we're going to talk about some of those studies tomorrow. Okay. So tomorrow morning, that will be key question 4. So there's a little bit there to talk about tomorrow.
Awesome.
Yeah, and we have several discussions regarding shared decision-making tomorrow as well. And the circumstances in which it is helpful and in which we should just give advice. And they're not the same thing. Because for some of these preventive interventions, we're not at equipoise. It's like, you should get a mammogram. I want to thank all of our presenters. This was a great session. 10-minute break, and we'll be right back and power through the rest of the evening. Thank you. We're moving on to not our final question, but our final question of the afternoon, which is key question 3. What is the evidence of different approaches and strategies between providers and patients that connect and integrate evidence-based preventive practices in reducing disparities? And we'll start with the systematic review team. Amy Cantor is going to be up next. And I think she is about ready to go.
It's green. Okay, great. Thank you. Can everyone hear me? My name's Amy Cantor. I'm an associate professor of medical informatics and clinical epidemiology, and also family medicine and obstetrics and gynecology at OHSU. I'm here as one of the investigators from the Evidence-Based Practice Center. Waiting for the screen to come up. Great. And I'm going to talk about key question 3. Let me figure out where I scroll through. Okay. So key question 3 is evaluating the evidence around patient-provider interventions. this was particularly interesting to me because I'm also a primary care physician. So although I don't have any disclosures or anything to disclose, that's certainly a perspective that helps inform my experience in this particular topic. Again, want to recognize our excellent team here from the Evidence-Based Practice Center. And here, key question 3, I want to read it, and then as I move through, I also want to describe what we mean when we're talking about providers and patients. And we've heard a lot about this already. People have mentioned the importance of this particular dyad and this dynamic. So key question 3 is looking at the effectiveness of different approaches and strategies between providers and patients that connect and integrate evidence-based preventive practices for reducing disparities in preventive services. So what do we mean by that? I wanted to review briefly the P codes, the inclusion and exclusion criteria that we used in general and then specific to this particular key question. So importantly, we're talking about populations adversely affected by disparities and providers serving these populations. I want to differentiate this particular question from key question 5, where we're actually going to be looking at the health systems approaches for these connections, where in this particular question, we really are focusing on interventions where a major component of care is based in the clinical provider setting. When we're looking at comparisons, we'll be looking at those receiving an intervention versus not, or usual care, and those who are adversely affected by disparities versus populations who are not. The outcomes are both measured and intermediate outcomes, such as screening, access to preventive services, screening rates, et cetera, and then clinical outcomes as well, which would include incidence of disease, morbidity, mortality, burden of disease, and others. Also specific to this particular question is the setting, looking at the clinician to patient-based interventions with a major component in that setting or in the context of the clinical interaction. Study designs for this question are controlled clinical trials, randomized controlled trials, and prospective cohort studies. So I'm bringing up a slide that we saw a bit earlier today for those who weren't here, but for those who were here, just jogging your memory. And here we're looking in this particular bubble where the clinician interventions occur. And these can be connected to the community, but we certainly wanted to make sure that we're recognizing those and including those that are connected to that patient-provider interaction. So for key question 3, there were a total of 9 studies that, in 10 articles that looked at 4 different preventive services, the majority of which, similar to other key questions, were related to cancer screening. There were 7 RCTs. 1 was non-randomized. It was also a trial and then a cohort study. And you can see where the majority of the evidence was colorectal cancer screening, a couple for breast cancer screening. 1 had an overlap of cervical cancer screening, which is why the numbers don't add up in the same way. And there was 1 study with a follow-up that was obesity management. And the populations that were included in the studies for this question included vulnerable, low income, safety net clinic, rural, Native Alaskan, American Indian, Latino women, and other racial and ethnic minorities as described by the studies and reported in the outcomes. Again, a quick review, and this has been said a couple times today, so I won't spend too much time here, but looking at how we graded the strength of the evidence as well as the applicability. And you'll see as we go through the evidence that we provide ratings for those for each individual study, and then have those abbreviated. So you'll see high, moderate, and low, and where the evidence was insufficient or there weren't any studies in that particular outcome or service, there was no evidence there. And then applicability, again, looking at how would this apply widely to practice. If there's a study that was conducted in a very specific population, it was likely had low applicability because it could apply to a more selected population where some of the studies that were more broad could be applied on a broader level. Importantly for key question 3, although we're looking at the patient-provider dyad and looking at that particular clinical setting, we wanted to make sure that we found studies that offered ways offered interventions that connected patients to providers, and that can include using patient navigators, for example, and so defining those here to differentiate patient navigators from other types of health workers. So the patient navigators are trained health professionals who might work in conjunction with physicians or directly coordinate screening. Some studies use lay health workers, which were often community health workers or health aides with intervention-specific training, but hadn't undergone formal medical training in the past. And then some other studies also utilize promotoras, or lay health workers or health educators specific for Latino and Hispanic populations. Some studies use mailed or telephone-based materials for the interventions, but ultimately those connected the patients to their providers. In studies that use someone other than the physician or their clinician directly, all of these people, the patient navigators, lay health workers, promotoras, really served as links to connect the patient to the provider and helped facilitate screening in that context. Navigators were sometimes considered healthcare coaches, so you might hear that language as well, but those were definitely synonymous with the patient navigators, or healthcare workers that were trained to guide patients through the healthcare system within that clinical setting. So for key question 3, I'm going to start with evidence around colorectal cancer screening. There were 4 studies that provided evidence around patient-provider interventions to facilitate colorectal cancer screening, 2 of which were looking at patient navigation. One was a very small trial that included 21 patients. It was a pilot study who were Hispanic and African American, and they looked at a community health center where the primary care provider referred patients to the patient navigator, and that patient navigator facilitated scheduling the colonoscopy and also discussed risks and benefits, and they compared that to someone who didn't have a navigator. And it was found that screening was increased, and there was improved screening compliance, meaning that there was completion of the colonoscopy among a very small population of low-income minorities. So there were about 13 people who received the intervention in that particular study. Another trial of patient navigation was a bit larger, over 400 patients included in that one, in a low-income population of patients. And they received a letter from their primary care provider and then also had a follow-up call in a language concordant, with a language concordant patient navigator. So that was a little bit different, but certainly recognized the needs of that particular population. And screening was increased. So in both of the studies using patient navigation, there was increased screening. Another trial looked at the effectiveness of printed materials and telephone counseling and found that increased screening among first-degree relatives of colorectal cancer cases amongst a population of Latinos, Asians, and whites, but also included African Americans, but did not find the increased screening rates for that group. Importantly, this was, again, a narrow population because they identified first-degree relatives of known cancer cases and utilized sensitive, culturally appropriate telephone counseling to facilitate screening and connect those patients to care. And those were culturally tailored printed materials as well as the telephone counseling. For that particular study, any colorectal cancer screening modality was included as a completion of screening. So that included FOBT, colonoscopy, as well as flexible sigmoidoscopy. And then for the last RCT for colorectal cancer screening, there was mailed materials that were sent to a group of African American patients, as well as whites, and that was the comparison group. And they received mailed educational intervention from the provider. So it was a letter from their provider as well, and some additional tailored messages, and that increased screening as well. So overall, you can see that colorectal cancer screening, all of these interventions that connected the patients tended to lead to increased screening overall. The next cancer screening is breast cancer screening. There were 2 trials that addressed breast cancer screening, and both utilized lay health workers to send patient reminders and connect patients to screening with their providers. Both were conducted in a population of low-income women, and one used a letter from the patient, from the patient's clinician, and additional counseling from lay health workers, and found that increased screening rates. Another study in a similar population of low-income women sent reminders from lay health aides on the physician's behalf. So that was the connection there, and they were referred to culturally sensitive women's cancer screening clinic. And both of those interventions increased screening rates for mammography. For cervical cancer screening, there were a couple of different interventions that were effective to increase screening among a few different types of populations. So lay health workers, again, were employed to increase screening for low-income women in one trial. And this was actually the same trial where we just saw breast cancer. So in that particular study, they looked at the effectiveness of lay health workers for increasing breast cancer screening and cervical screening, but reported the outcomes separately. And the reminders from the lay health aides on the physician's behalf were effective for getting those women referred for cervical cancer screening. In another population of rural Latina women, an educational video and connection to the clinical setting using a permatora did increase screening rates for cervical cancer screening as well. And then in the last study of cervical cancer screening, the trial demonstrated that using patient education with patient navigation also increased screening rates among low-income Chinese women. And so cervical cancer education combined with that navigation versus just general health education did increase screening rates in that population as well. The last preventive service that was addressed in this group of studies was obesity management. And so this included one trial that reported data at 6 months and then a follow-up study that reported the same data from the same population of patients at 9, 12, and 18 months. And so what was interesting about this particular intervention, a little bit different from the other ones, is that the providers were actually trained. So the primary care providers received about 4 hours of additional training on obesity management, guided from the NIH educational obesity module. And then what they did is over the course of 6 months had 15 extra minutes with each patient to talk about obesity management. Everything from diet, exercise, and all of the components that would potentially improve their obesity. And so this tailored weight loss that was delivered by the primary care physicians directly to the patients improved weight loss at the 6-month mark, and at the 3-month follow-up, which is the 9-month mark, was also effective. However, when they did a post-intervention follow-up at 12 and 18 months, there was no difference in BMI at that point. So interestingly, there was improved weight loss during the intervention shortly thereafter, but that difference was no longer significant at 12 and 18 months. So in summary, for key question 3, there were 9 studies of patient-provider interventions, which included different approaches and strategies between the providers and patients to connect and integrate these evidence-based practices and reduce disparities in 4 preventive services. So patient navigation was effective for colorectal cancer screening. Telephone calls and prompts were effective for both colorectal and breast cancer screening. Lay health workers were effective to improve breast and cervical cancer screening rates. And promotores were also effective for breast and cervical cancer screening. Provider training was effective in that it helped obesity outcomes in the short term, but after that, patient contact was lost and there was follow-up after the intervention. Those effects were no longer significant. Printed materials and counseling on the provider's behalf were effective for colorectal cancer screening. And mailed materials from the provider as well were also effective for colorectal cancer screening. So as you can see, for all of these studies, there were a number of different types of interventions that connected patients to providers that had different types of trained professionals or lay health workers working on the provider's behalf. to connect the patients to their providers, and they ultimately, overall, really improve screening. And whether or not that they were high-touch interventions or that there was some way that patients were connected to their providers, they all seem to work on some level. The limitations for key question 3 was that the number, quality, and applicability of these studies varied. As I described, there were a number of different types of interventions, sort of variations, and they were done in populations, somewhat specific populations. Many of the patient populations that we recognize as being at risk for disparities were not studied in these particular trials or studies, and most studies recruited those highly selected samples of patients. Not all preventive services were addressed by the studies. So the ones that were not addressed by these particular studies included lung cancer screening, aspirin use to prevent CVD and colorectal cancer, high blood pressure screening, type 2 diabetes, and healthful diet and activity for CVD prevention, as well as smoking cessation. Future research for this topic, just based on some of the conversations that we were hearing today about shared decision-making, directly engaging patients with providers, the idea of a medical home and how we could have providers or clinicians, primary care clinicians at the helm, and see how those could potentially be effective for connecting patients to these preventive services. These would certainly be helpful in terms of guiding future research. So studies of these interventions should focus on evaluate the effects of shared decision-making on preventive services, evaluate care management approaches that might be provider-driven or team-based approaches, effectiveness research on the patient-provider dyad that could identify the most effective components and the most effective interventions, and then maybe evaluate those in different populations, but the same types of interventions to see which ones are really effective and whether or not they can be applicable in more than one population. Importantly, to define services, measures, and outcomes in multiple patient-provider settings, and to evaluate the effect of bundling preventive services. If maybe you're not having as much patient contact, could you try to do opportunistic screening where you could bundle certain services together? And then to measure additional benefits, such as patient adherence, improved access, health literacy, et cetera. Key messages for key question 3, again, looking at the patient-provider dyad, is that few studies focus specifically overall on the patient-provider dyad. We had about 9, and related disparities in preventive services. Notably, screening improved with involvement of patient navigators, lay health workers, or prematuras, and patient populations that were studied may not have been well-defined or were highly specific. Applicability in terms of moving forward and looking at future research, thinking about how we can assess how these interventions might work in different populations, and then again, thinking about those patient-centered interventions where the primary care provider could be at the helm, using shared decision-making and potentially thinking about how we've heard today the importance of primary care and coordination of care to really connect patients to their providers. So with that, I know my time is up. Thank you for your attention, and we'll look forward to hearing from the rest of our speakers.
Well, hello, and thank you for the invitation to this meeting. This is my title, Integrating Shared Decision-Making Tools into Healthcare Delivery Systems. And maybe a little bit of background about myself. I'm a family doctor originally from the UK, and I've been at Dartmouth College now for about 6 to 7 years. When I thought about this title, I thought, well, what would be an alternative? And I think I came around to the idea that if it's not in the electronic health record, just forget about it. Because actually the workflows of most clinicians now are governed by the electronic health record. If you can't click that button to get to the next screen, you're stuck. And a lot of people have left because of that, as you know. So it's important, I think, that we realize the implications of that last talk, which is that there's relatively little work about the interaction between the clinician and the patient around these screening or preventative issues. For those of you so inclined, there's a Twitter handle. I do have some competing interests, and I worried about this a little bit because there's been so little mentioned so far. But I try and get things done in the real world, I guess, so I get conflicted a little bit. I want to mention them briefly. The Shared SHARP network is a virtual training network for practitioners who want to become really skilled at shared decision-making. The second one, the Access Community Health Network, is I work with a group of federally qualified medical centers in Chicago, implementing shared decision-making in the south side of Chicago, essentially, which is one of the poorest areas, you know. And the tools that I imagined a few years ago now, called option grids, they've been taken up by a company called EBSCO. And I will mention them briefly, but the EBSCO makes Dynamid, some of you may know. And of course, I have non-financial interests, which are intellectual. I use this definition of shared decision-making because it will apply to any walk of life. And it was fascinating to hear the small discussion that happened there about should we allow opt-out or opt-in to preventative or screening issues. That's such a fascinating issue. But the challenge here is that even if it's opt-out, somebody's got to turn up and usually have a colorectal examination or a vaccination or a procedure. So there's not quite opt-out. There's always an opt-in. My feeling is that these screening issues, as we've heard a little bit of mention of overdiagnosis and overutilization, they also come with harms. So I'm not quite sure you can always adopt an opt-out situation to preventative issues. This is a more academic kind of definition of shared decision-making. This working together is pretty critical, understanding what we're getting into, why we're doing it. And I believe a lot of people don't fully understand the invitations they get about screening issues. To trade off the likely harms and benefits. And this is particularly relevant, I think, for a situation like lung cancer screening. The incidentaloma, the small nodules that lead to other investigations, and the cost of other investigations, which is not always borne by your insurance, is something people worry about, or they would worry about if they knew about it. And look at this last line, where patients are supported to arrive at informed preferences. People hate making decisions. It becomes a responsibility. If they're in a domain of unknown destination, please tell me what to do, most people will say, unless you support them to really balance the harms and benefits in a way that they can fully understand. This is a model that myself and colleagues, a lot of colleagues, put together to try and simplify this idea of sharing decisions with patients. And I want to emphasize the top talk. I think there are 3 basic talks. The first one is called team talk. Essentially saying, we've got an opportunity here to maybe investigate whether you're at risk for a cancer or a cardiovascular risk of some sort. But let me help you understand what we're getting into. And I'm here to help you make the right decision for you and your family. I call that team talk. It's laying out the options, but also saying to them, I'm not going to, what Timothy Quill said, abandon you to make the decision on your own. Second is the option talk. Very easy, you might think. But the data that you need to give the probabilities of harm at the individual level and the probabilities of benefit are really difficult. for most practitioners to get hold of. They don't exist easily. And then this last bit, which if you look at transcripts of clinical encounters, it hardly ever happens. Basically, the question would be, now that you've understood what we're getting into, the options, what's your view about it? What are your preferences? What would you like to do? And pause to let people speak. That simple pause after that question is very rare in transcripts. So that's the model. And the challenge we have, I think, is not just in screening or preventive, but to do this kind of approach, which I think is relatively simple but very difficult to achieve across medicine, not just in preventative services. Now, over the last 20 years, it's kind of started in the 80s in Boston with people like Mike Barry, Jack Wenberg, and Al Mully, making what were called shared decision-making programs at the time. You've maybe heard about these tools called patient decision aids. At the last count, there's 105, maybe 111, I can't remember. It changes a little bit depending on the criteria. But there's over 100 randomized trials of using these tools, but not always in the encounter. There are a few in the encounter, but not many on the screening side, of course. Essentially, they're tools that have been extremely well designed to help people understand what the options that they face. They can be leaflets, they can be video, they can be websites on the pre-encounter side, where you send something to the patient ahead of time. And screening and preventative services is perfect for this because you've got an eligible population. You can identify who to send these tools to. Then there's another group called encounter-based tools. I'm going to show a few examples of these. They're tools that would help you have a better conversation face-to-face with the patient in front of you. And then there's the post-encounter tools, things that you send or give to the patient to walk home with or to discuss with their family. There's a lot of science around what it takes to make a good one of these. There's even accreditation now in Washington State, and a few tools have been accredited for the quality of the content, for the quality of the way they lay out risks, and so on. And that's important because these influence decisions. The Cochrane Review, now taken over by Dawn Stacey, it used to be Annette O'Connor, has shown very conclusively that the knowledge gain amongst patients goes up by about 15 to 20%. Easy. They have a better risk perception as well. So they really understand things better. The critical issue is that people make different decisions once they've gone through these kinds of tools. They are powerful. And so therefore, you don't want conflicted evidence in them. You want the very best evidence in them. And here's the issue is that I've neatly categorized these into pre-encounter, encounter, and post-encounter. The truth is that many of these encounter-based tools, they're brief, but they're being used pre and they're being used post. Because actually, believe it or not, people want brevity, they want to get to the point, they want to get to the gist. They're not interested in looking at a website that takes 40 minutes to read. They'd rather watch Netflix. Here's one. It's a decision box by Annick Giguere in Quebec. It's designed actually for the clinician and the patient to have a conversation. And I think this format relies on the clinician explaining some of the terms to the patient. It's quite a lot of data. Here's another tool that Victor Montori, some of you will have heard of Victor in Mayo Clinic. Very different approach, very minimal, comparing what diabetes medication you should take on these issues of, will it affect the blood sugar? Will it affect my weight change? Will it affect cost? What time of day will I have to take it, and so on. So basically one attribute at a time, and then comparing each of the medications. And the patient is asked to pick which card they want to focus on, and maybe a second card, and maybe a third card. But it's interesting that patients normally have one or two very important attributes where they want to make the comparisons. Here's a tool by John Keyville. It's a very different approach which sucks data out of the electronic health record, integrated fully into EPIC, takes the age, the blood pressure, the cholesterol level, puts it into the personalized risk of the patient, and creates what's called an icon array. This is called an icon array or a pictograph. Basically, establishing for you what's your risk of a stroke or clot in atrial fibrillation. And as you can say, you could choose the aspirin or the warfarin and see this icon array change in front of you. But the important bit is the degree here of integration into EPIC. The clinician does not have to type in the age, the gender, or the other morbidities of this particular patient. And that's a step forward. Clinicians are excited about this. User testing with patients, there's a lot of way to go here, because some patients, I think, might find this a bit complex. Here's a tool that I've been responsible for. I disclosed that. We've called it an option grid. Here I've focused on lung cancer screening. The data is about having screening or no screening, and we're listing, if you like, and I know you can't read it at the moment, it's too small, but the data comes from the lung screening trial, of course. The issues here is that we're integrating this into the EPIC or Cerner or Allscripts menu in the electronic health record, so it's available to the clinician right in front of the patient. And you'll see these little buttons at the top here. We can make what's called a frozen link in time and send that to the patient by email or SMS for them to read afterwards. Or we can print a PDF for them to take home if the printer is working in the clinic room. Not always the case, even if there is a printer, right? But the important thing here, I think, is that we've got high-quality evidence comparing numbers that are relevant to that patient in time. And of course, there are risk models. I was talking to Mike Pignoni earlier about what kind of risk model might modify this risk if the patient, for example, has been a very heavy smoker or has got COPD. These numbers might change if you could plug that in. So, where are we in terms of these kinds of tools being integrated into healthcare delivery systems? Not very close, I would say. And there are issues here. I think that in current primary care or internal medicine in the US, there's a cultural resistance to preventative work. It's not what people do as a routine. The identification of eligible people is really difficult unless you've got a population that's registered and fixed. You don't know who they are. If you don't have their contact address, how can you invite them? What about, are we into persuasion or are we into balanced information? There's a big debate about whether we leave off the harms of screening in invitations. And do we have accredited, evidence-based, accessible information at the kind of 6th grade reading age 10 or 11? Most materials are not there. They're really very far from that. Some workflow solutions might be that you create a register if you had a fixed population. For example, a really good register of heavy smokers. You have a criterion-based invitation system. Smokers who are alive, not dead, that happens, don't have terminal illness or existing cancer, you don't want to invite those people, and maybe you don't want to invite people who've got very difficult dementia, and so on. This register is difficult to maintain. You have to keep an eye on the results and the interval invitations. And basically, when you invite people, you need to send them very good, in my view, patient decision aids or shared decision-making tools, which are certified, balanced, evidence-based, and patient-facing that have been user-tested. How much did you say? 5 minutes? Did you say 5? Very good. Okay, so what would it take? Well, it would take this, I think. It would take these kinds of resources to build this into systems. If you're in private practice, this is pretty tough. But if you're in Kaiser, maybe it's more easy. Maybe if you're in a kind of organized healthcare system with vertical healthcare, you can achieve this. But this is really difficult in the current state in the US. Has this happened so far? Has the EHR helped us on shared decision-making? Well, we did a review, a group of with me and my colleagues in Miami did a review. We found 5 studies, only 5, that had looked at this issue of electronic health records. And remember how I started. If it's not in the EHR, it doesn't happen. It really doesn't. And basically, this was our conclusion. Few EHRs have integrated any approach to shared decision-making. Even fewer evaluations exist. So I don't have much data to tell you. Here's the studies. They were in pre-diabetes, asthma, osteoporosis. I asked a very prominent internal medicine physician in a very well-known health system in the East Coast. You will know this health system. And this is what they said. We offer FIT, the colorectal fecal test, or colonoscopy. Aside from both being options being things I can order, I don't know if we have anything else formal built. Oh, she mentioned, oh yeah, we have the cardiovascular wizard. And that's about it. In terms of the organized structure that made that conversation work in the clinic. So, some challenges. I think most healthcare is reactive. You come with a problem and we'll sort it out versus preventative. There's the issue of informed choice versus persuasion, and public health has to grapple with this. Are we into persuading people to go for screening, or is it they elect to do so? This issue of the right person at the right time, every time. The tools that you need to make the right invitations, certified and highly accessible for real people. And then the skilled use of these tools. As I mentioned in that model, very few people offer the preference elicitation. Is this something that suits you and your family? And then the coherence across teams. This is not a one clinician story. You need a team approach to this because the medical record and the updating and the register doesn't happen just because one clinician wants it to happen. I'm going to finish with this kind of bullet list of if you could have a dream, this would be it. Enforce federal level certification for patient decision support. You need these tools to be very good, and you need them to be conflict-free. Require these tools to be integrated into EHRs. Meaningful use, I've heard about that. Require population-based prevention registers. You cannot do this work without a register. You just can't. And reward ethical preventative work. There's a lot of ethical underpinning to good screening. Thank you.
Okay, good afternoon. Thanks everybody for hanging in there. I know it's been a really information-filled day and a lot of good content, and it's really great to go after Glenn, who's someone I've worked with throughout my whole career and really have a lot of admiration for his work. So I think what we're going to do is a little bit deeper dive into some of the same issues of shared decision-making and decision support in colorectal cancer, which is an area that I've worked in across my whole career, from the time that Dr. Carey gave me my first job in the late 90s till the present day. So I wanted just to let you know about the funding for some of this work. I've had a number of different federal and non-federal funders, as well as the Informed Medical Decisions Foundation, and then also that I'm a former member of the U.S. Preventive Services Task Force, but the content I'm going to deliver here is really my own opinion, not necessarily that of the task force although I will mention some task force recommendations. So just again to somewhat reiterate some of the points that Glenn made, I think the take-home message is that high-quality decision aids are really important means of disseminating evidence and implementing guidelines, and that their use in vulnerable patient populations can help improve decision-making and reduce health disparities. My background, and this probably will dovetail with what we've heard throughout the day, health disparities, as you all know, are multifactorial. Unequal access to high-quality care is an important cause of health disparities. Obviously, there are a lot of things that outside the care environment that matter a lot in producing health disparities, but as a care provider, I feel like we need to deliver equitable care as well. And while that may only influence 10 or 15 or 20% of health outcomes, that 10 or 20% is important as well. So really a goal that I've had throughout my work and some of the work I'll show here today is to improve access to high-quality care by improving high-quality decision-making, okay? And I think as Glenn has iterated in his talk, there's a lot of room for improvement in decision-making in clinical care. We're going to dive deep into colorectal cancer. Why colorectal cancer? Well, it's an important cause of morbidity and mortality, and there are some important disparities. There's strong evidence that colorectal cancer screening is effective but underutilized. And what makes, I think, decision-making about colorectal cancer screening particularly interesting is that there are multiple screening options, which, you know, even the decision about whether to screen or not screen for many preventive services is challenging. But when you have multiple options, it becomes even more challenging and introduces some particular factors that need to be accounted for when you think about how to support patients. So I want to start with some good news. We've talked a lot about problems, but colorectal cancer overall is an amazing success story. Now, I've been giving this talk for like 20 years, and I've been talking about 50,000 deaths a year in the United States, second leading cause of cancer death. You would think, like, gosh, we're not making any progress. But remember, the country's growing and getting older. And what I showed here on this slide is the age-adjusted death rate. That's the blue bar. And you can see that the age-adjusted death rate for colorectal cancer since the mid-70s has declined by at least 50%, maybe a little bit more, even as the number of cases has stayed relatively similar. I put this slide in just to remember that we really are making progress. It's just there's still a lot to do as our population gets bigger. This was alluded to in the morning session, but there are important race, ethnic differences in colorectal cancer mortality. Here I'm showing mortality rates, men on the top, women on the bottom, and the red line going across is African Americans. The yellow line is whites, and the green line is everyone together. So what you see from this, first of all, African Americans have a significantly higher colorectal cancer mortality rate than other race ethnic groups. Everyone's getting better over time, right? You see the lines are coming down, but that disparity has continued to persist for a number of reasons. The other race ethnic groups are actually at somewhat lower rates than whites, but there's still plenty of room across the race ethnic groups for improvement for both men and women. And men, as in many things, are a little bit higher risk than women. There's been some really great modeling work done that has shown that about 50% of the observed reduction in colorectal cancer mortality over that time period that I was talking about, the last 35 or 40 years, has been due to the introduction of screening. Some is due to the improvement of risk factors, some, although not very much, through better treatment of colorectal cancer. But again, about 50% is thought to be due to screening. So this is obviously a pretty important part of the overall attempt to reduce colorectal cancer burden in the United States. These are some data on screening from the National Health Interview Survey from the mid-'80s up to 2010. The lines have flattened out a little bit, but continue in basically the same direction. And what you see over that time period is colorectal cancer screening going from something that no one got to something that's now, at least in the majority of race ethnic groups, over 50%. Latinos, which are the lines in purple, continue to lag other race ethnic groups. There is some difference between African Americans and whites, but just the difference in screening alone does not account for the differences observed in colorectal cancer mortality between whites and African Americans. It's more complicated than that. and it's not equally distributed across the country. And I think one of the important points, and I think you guys are going to talk about this more tomorrow, this is a map of the United States. The darker colors are the states that have higher screening rates. Even within states, screening is not equally distributed, but you can see here there are important differences at the state level. And especially the states in the Great Lakes and Northeast have really achieved higher screening rates, and they're lower across the South and South Central parts of the country. Also, not coincidentally, many of the states that have not adopted Medicaid expansion. Now, this is only from 2014, so you wouldn't see the full effects of Medicaid expansion in these slides, but the trends are in a similar direction. So just really highlighting the importance of insurance coverage. This is another way of looking at that same kind of data. This is data from MMWR from 2017, looking at colorectal cancer screening rates by a number of different demographic variables. So if your income is greater than 400% of poverty, your screening rate's about 70%. If it's under 139% of poverty, it's about 47%. As a primary care doctor, I'm very sensitized to the fact that not having a usual source of care is an important marker for low colorectal cancer screening rates. If you don't report a usual source of care, you're only screened at about a 26% rate. That's obviously related to insurance, and you can see here that if you have public or private insurance, your screening rates are over 60%. If you're uninsured, they're 25%. So one important take-home message is getting insured does matter and would substantially improve screening rates overall. There's a considerable difference between non-Hispanic and Hispanic populations. On the left-hand table, you can see that difference, about 17 percentage points. Those are not adjusted screening rates, and a lot of that's due to differences in insurance status, okay, because the Latinos also tend to have higher rates of uninsuredness. And you can see that, as other speakers have said today, the Latino population is not monolithic. The table on the right shows different rates across different subpopulations within the Latino population, with higher screening rates in Puerto Ricans, lower screening rates in Mexican and Mexican Americans, and Central Americans kind of in between. Some of the work that I'll talk about today has been done in federally qualified health centers. I think solutions to reducing disparities in colorectal cancer and other preventive care screenings need to incorporate FQHCs as one of the most important sites of care for patients that are likely to have low screening rates. You can see that the FQHC screening rates, which are the blue bars in the middle, or the blue line in the middle, is about 40% compared to, using BRFSS data, over 65% for the entire population. The one in the corner down there is our local FQHC, where we've done a lot of work to improve screening, but started at even lower numbers. So plenty of work to be done in the FQHC population and setting. Colon cancer screening, just to get to Glenn's point about whether or not we're going to promote screening or not, colorectal cancer screening is one of the evidence-based preventive services with the strongest evidence. It receives an A recommendation from the U.S. Preventive Services Task Force for adults 50 to 75. I'll not talk a lot about younger populations or older populations. You need to have much more individualized decision-making in those cases. But the evidence is pretty strong in support of screening in that 50 to 75 age range. However, the evidence about which method you should be screened by is much more, there's much more equivalence and equipoise between the different options, making it a great target for shared decision-making. So you have a bunch of different options. Most of the screening in the United States continues to be done with colonoscopy every 10 years. Stool testing with FOBT or FIT testing is the other main alternative. I will talk mainly about those today because most of our interventions have focused on those two means of screening, but they're quite different, right? So stool testing, you can do at home. It's done annually. It requires ongoing adherence, but is a little bit easier per episode of testing. Colonoscopy screening every 10 years, a little bit more involved. You need to get somebody to drive you back and forth to your colonoscopy because of the sedation you're going to receive. And, it has probably a little bit higher rate of complications rather than doing stool testing. And importantly, and what makes this even more complex for shared decision-making, is that if you decide to be screened by a means other than colonoscopy, you have to be willing to have a colonoscopy if your initial screening test is positive. So if you have an FOBT or a FIT and it turns positive, you have to go on and have a colonoscopy. If you don't do that, you're not going to get the reductions in incidence and mortality that we expect when we offer screening to someone. So that's very important. People oftentimes ask me, well, can we just say you should do stool testing if you don't want a colonoscopy? I said, no, not exactly. It has to be a more nuanced discussion with that. And that's some of that quite intricate dance that Glenn described that needs to happen around this particular topic. So how have we been able to increase screening over time? A number of things have helped increase screening, but not necessarily reduce disparities. And they include increased awareness and advocacy, better clinical systems, and more screening options and coverage. So in terms of increased awareness, we're in a much different place than we were 25 years ago. When I started work in this area, this is a CDC public service announcement with Katie Couric, who's been an important advocate. The amount of awareness and discussion in the general population about colon cancer screening is much higher than it was before, but is not by any means universal. So particularly in populations that may be more isolated, have less exposure to health messages, less contact with the healthcare system, there's still room to move in just delivering that message. The CDC Community Guide to Preventive Services has done a lot of good work at looking at the particular techniques that help increase colorectal cancer screening. I've shown a whole variety of them here. I don't have time to go into all of them. The most important thing I think that I want to emphasize is what's in yellow, which is that multi-component interventions that hit on different barriers seem to be a particularly effective way to address screening, and when implemented, increase screening by about 15 percentage points over practices or settings that don't adopt that kind of an intervention. So the idea that hitting it more than one place in the healthcare delivery and provider-patient interaction system is, I think, an important one. We know that if you offer stool testing in addition to colonoscopy, you get a higher rate of screening than if you only offer colonoscopy. Okay, this was a randomized trial done in San Francisco in a setting where people had access to both forms of screening, and they found those results. So let's talk about then a little bit about how shared decision-making and patient decision aids might work in colorectal cancer screening, because I think that's really the other implication of the fact that offering more types of screening leads to higher screening rates. So this is just a little bit different conception than Glenn used, but I think it's very consistent. Decision aids are tools that help people understand that, A, they have a decision. That's very important in preventive care, where you're not necessarily coming in with a symptom, and we have to discuss with you that this is a condition that you might be at risk for. You have to recognize the possible options and know the pros and cons of each option. That's the information about the different options that Glenn mentioned. You have to recognize the uncertainty in the decision. That's kind of a fairly advanced concept that we've not done really well in. When is the evidence uncertain versus when is the choice balanced? Those are potentially different things. Helping people clarify their values is something that doesn't happen routinely, and I think with decision aids is much more likely to happen. And then, importantly, come to a decision and then interact with the healthcare system to make that decision actually happen. And I just want to reinforce what Glenn said. If we do not integrate these tools into the care environment effectively, then they will not be effective. There have been over 21 trials of decision aids to improve colorectal cancer screening decision-making. Like the overall evidence, they invariably increase knowledge. In most cases, they lead to increased screening interest and intent. In some cases, they increase actual screening. There almost always is a voltage drop between increased knowledge, then interest, and then ordering, and then completion, right? So we've never been perfect in making the pathway from a good decision to actual test completion seamless. And they tend to produce more varied test preference and uptake. So essentially what that means is when people are exposed to decision aids, they're more likely to choose stool testing, at least in the United States, than they would be in usual care. This is some screenshots from some of our colorectal cancer screening decision aid work. We had two versions we've developed and iterated over the years. The English language version is called Choice, the Spanish language version called Opciones. We've tested them in a number of different settings and populations. This is some of the trials that we've done. I want to really focus on the two bottom lines. First, two of my former mentees, Dan Royland at UNC, led a trial that used an iPad-based decision aid in practice, followed by navigation by nurses in that same practice. We increased colorectal cancer screening by 41 percentage points over usual care, got it up to 68%. That was a very effective intervention in a community health center, two community health centers, one in New Mexico, one in North Carolina. And then, navigation can be expensive. We didn't really talk about that earlier. It's very effective, but it can be expensive. So we did another trial that was published in Annals of Internal Medicine in 2018. Dave Miller from the Wake Forest system in North Carolina. Again, an iPad-based patient decision aid that allowed patients to directly order their own screening if they knew what they wanted. If they wanted to discuss with their provider, they could do so, and then use text messaging in support after that screening. Again, quite vulnerable patient population with a high degree of Medicaid or uninsuredness, and we were able to increase screening by 15 percentage points there. Not quite the same size of effect as with navigation, but still a positive result. This is from the JAMA Internal Medicine paper and Dr. Royland and my work. And what this shows is that we looked at whether or not the effect of the intervention varied by a number of different demographic groups, right? So you can see the forest plot up and down here. Overall, the overall effect is in the diamond at the top. And then for each of the demographic characteristics, you can see there was a little bit of difference in a few of the variables. The intervention tended to be more effective in women than in men, but was effective in all the race ethnic groups. And if anything, Latinos seemed to benefit a little bit more, although that result was not clearly statistically different. So we were pretty heartened by the fact that we were able to make improvements across different literacy groups, across different language groups, across different income groups when there was navigation support. Just to reinforce again the challenges of implementing decision aids, we got to think about when and how to offer. Before the visit, during the visit, after the visit, all have pros and cons. Thinking about issues of literacy and the digital divide. So our iPad-based intervention is very good. It has audio with it so that people don't have to be able to read the words. That helps overcome some of the literacy barriers, but people don't necessarily have computers or internet access in their home. Using cell phones and text messaging helps overcome some of those barriers. There really isn't that same kind of digital divide when it comes to cell phone usage and really actually now smartphone usage. Just another plug that this has to be fit within the EHR workflow. That's not an easy thing to do on the fly. The systems are oftentimes not easily manipulable. We talked about how many options to present. You could present 5 options, 2 options, 3 options. Those have implications for the length of the decision aid and how well it fits into practice. And then how do you make sure the patient has access to or gets testing that they prefer? So in conclusion, my last minute, I think, what I would conclude is that decision aids can improve decision-making processes for health issues like colorectal cancer screening. Well-designed decision aids, and again, reinforcing the point of well-designed, can reach vulnerable populations effectively, but they need to be designed with and for the population that you want to implement them in. And then effective post-decision support is key for reducing or at least not increasing health disparities as we improve both groups. I think if we implement these tools in settings that have large numbers of vulnerable populations, ones without insurance, ones that have typically not been well served by the existing healthcare system, we can reduce health disparities, but it won't happen unless we make specific efforts to bring that about. Thank you.
Good afternoon. Thanks for hanging in there with us. So about a year ago, I was actually standing on this very stage. I'm Robin Vanderpool, and I'm from the University of Kentucky, both the College of Public Health and the Marquis Cancer Center. And about a year ago, I was standing on this very stage. We were hosting on behalf of the National Cancer Institute a rural cancer control conference. So it's thrilling for me to be here again a year later and have rural communities be part of this workshop today. With that, I am the last presentation of the day, so I kind of have two thoughts. One, everything that is in my talk literally has already been said today. But then two, it's reassuring to know that we're all on the same page and that we, have identified many of the same barriers and gaps and concerns, but also many of the same opportunities and strategies going forward. So with that, I'll go ahead and get started. So I only have one disclosure. It's a textbook that we actually published for public health students. And let me tell you, it was not on the Oprah Book Club list. And you can see it's actually quite dated right now. So quickly, I am going to go over rural cancer disparities, and we've heard many of these points and facts earlier today. And then I'm going to dive into some of the evidence-based strategies that we've used for cancer control and patient-provider relationships, and particularly with the backdrop of Eastern Kentucky, Appalachian Kentucky. If any of you all know, this is one of the most medically underserved, under-resourced, low-income areas of the country. And we have a lot of work to do, but we are in it to win it, and we are in it to change these outcomes with unique, innovative partnerships and strategies. So many of you all, again, may know there has been, I would argue, in the last 2 to 3 years, a large focus on rural communities, and particularly our cancer disparities. CDC, among others, has published several reports that show that while rural areas actually have lower incidence of cancer, we do have higher cancer mortality rates. And the reductions in cancer rates over the last few decades that we've seen, that progress has been much slower in our rural communities. And that's particularly the case for what I call the preventable and screenable cancers, like lung, colorectal, and cervical. And what I think is really concerning is that we are also seeing higher premature mortality rates among all age groups in rural areas and decreases in life expectancy. And that could not be more pronounced in my backyard of the Appalachian Mountains, where 8 of the 10, so 80% of the U.S. counties with the largest decreases in life expectancy are in rural Appalachian Kentucky. In these maps, Monica actually had several of these maps in her talk as well. You can see the hot spots for all cancer mortality, colorectal cancer, and lung cancer situated primarily in eastern Kentucky, but also, again, in the Mississippi Delta region. And then Kentucky has the honor of having we have the highest rates of HPV-related cancer incidence among men and women. So much of this was presented in some of the other talks, particularly Michael Parchman's remarks, that we do have higher prevalence of the risk factors that lead to cancer in many of our rural areas. And that's everything from smoking, traditional cigarettes, smokeless tobacco, issues with overweight and obesity, lower HPV vaccination rates, which I'm going to argue and advocate needs to be on the next round of our services for the next report. Cancer screening rates are also lower in rural areas. Concerns around physical inactivity and poor diet, and that's not just about having, for example, high-calorie, high-fat foods, but also not enough food as well, and the rates are around 13% for food insecurity. Increased comorbidity rates, so I think we know that if you have high rates of cancer, you likely have higher rates of other chronic conditions as well, like diabetes and heart disease. And I think you all could probably have me back in about 10 or 20 years, and we could be here to talk about the rising cases of liver cancer in our rural communities because of the opioid epidemic and then the hepatitis C infection rate. And then once rural patients are diagnosed with cancer, we do see lower quality of life, including stress and depression, among others. And so what does this look like for Kentucky? We do have the second highest adult smoking prevalence, so a quarter of our adults are daily smokers. We rank 7th in adult obesity, and we are number 1 in hepatitis C incidence in the U.S. And if our behavior doesn't get us, then even our geology impacts our cancer outcomes. So we have elevated radon levels, which then impact our smoking and our lung cancer rates, as I showed earlier, and then concentrations of heavy metals that are part of the mountain landscape. And then if you think about the composition of rural America, you also see an outmigration in some cases of younger individuals, which leaves, again, older individuals, or even in-migration of older individuals who are retiring to rural areas, and you have more deaths than births. Socioeconomic disparities, which we have covered repeatedly today. And then I think if we are going to promote cancer preventive services, we need communities that have healthful policies that support those. So if I ask you to quit smoking as a clinician, and I'm not a clinician, I only play one on TV. I have a doctorate in public health. But if I ask you to quit smoking and then your community is, for example, not smoke-free, only 30-some-odd% of Kentucky counties are smoke-free, then you don't have a supportive environment. So I think policy is a huge player of supporting these preventive services that we are trying to promote. Cultural beliefs like fatalism, we heard that mentioned earlier in Dr. Simmons' talk, and whether that's a religious belief and or the notion, there's a phrase called cancer collectivism, meaning cancer is everywhere. In some of these communities, that's the case. Everyone they know is diagnosed, has been diagnosed or impacted by cancer. The family, friends, church members, relatives. And so the notion of you got screened, they found your cancer, and now you're going to die. And so that's something important to consider. We even had a study where we found that young women, 18 to 26-year-old women, those who had higher fatalistic beliefs did not complete the HPV vaccination series. So it's real. The historical influences, I thought Monica did a fabulous job covering this earlier, particularly around medical mistrust and discrimination. And so again, what do these factors look like in Kentucky? You can see here that we have limited racial and ethnic diversity, particularly in Appalachian Kentucky. We have lower median income, almost $20,000 less than the national numbers. A quarter of our population lives below the poverty level, and only 3/4 are high school graduates. And again, I won't repeat what Monica said, but I think we also have to remember that there's an intersectionality with race and place, and you can see here this organization, the Rural Health Information Hub, which is a website, actually maps out the distribution of different populations and where they're concentrated in our rural communities and how those both come together to impact health. And, part of this is context, right? It's the actual landscape of where our rural communities are situated, and the topography, and the mountains, and the deserts, and the water, and the difficult climates and weather conditions. And we have to think about geographic isolation, the distance, and transportation challenges. You have to think about the jobs that are present in many of these communities, and then the infrastructure. And that's everything from the roads to the water and sanitation services. And it hasn't been brought up too much today, but also this push that's actually having access to the internet or broadband as a social determinant of health as well. And particularly if you look at some of the new FCC maps that are out, you can map rurality with low broadband access, and then even if you have access, low internet adoption. And distance really does matter in the care of these patients. And as you can see, that if you live more than 50 miles away from a hospital, more likely to be diagnosed with advanced stages of disease, lower adherence to recommended treatments, worse prognosis, and decreased quality of life. And this has been covered also today. We've heard about the hospital closures, the limited access to primary care services, cancer screening services, and a whole host of even oncology specialists as well. And so here's a map that shows, again, what this looks like. Those green areas are our rural, non-metro areas. And so if anybody's here from Nebraska and can tell me what you're doing right, because I know it's quite rural state, please let us know. But, really all of this comes together. The context, the environment of these communities, and then the composition of the people who live there and their health outcomes. It comes together in this almost perfect storm. But we know, this was a report that just came out last year from the American Cancer Society, that if we can get everyone equitable access to prevention efforts, high-quality screening, and effective treatments for cancer, that we'd have almost a quarter reduction. And that's if nothing else was ever invented. If we had access, again, equitable access to all the services that we've been talking about all day today, particularly those that are in the cancer domain. And so I guess I'll get on my soapbox now and tell you about a project that we've had in Eastern Kentucky that, again, resonates with many of the talks that you've heard already today, particularly around working with the community, listening to the community, having them design the project and implement the work. And again, I just can't emphasize enough working with the community. And so academic community partnerships are vital, I think, in promoting these preventive services. And I think we just heard it in Michael's talk as well about the importance of federally qualified health centers. And so I had a colleague, a CEO of White House Clinics. It's a FQHC that has 8 sites in 5 counties in Eastern Kentucky. And she came to me and said, I want to do a project. I know what I want to do. I heard about it at the IHI conference. I want to come home. I want and implement it in my clinic system. I want to help my doctors practice medicine again instead of having their noses stuck in the EHR trying to figure out what button to push while they're talking to the patient. I want to take control over the clinical guidelines that we're using for our care. We were at a Medicaid expansion state in Kentucky for the time being. And we had, different payer groups, managed care groups, the different professional organizations, even some of the nonprofit groups knocking on the door saying, you need to do it this way. No, you need to do it this way. No, this guideline, that guideline. And she said, no, I'm taking control and I'm going to do what we need to do best for our patients. And so essentially we said what I think was said this morning. We put primary care at the center. And what she wanted to promote was what's called the proactive office encounter. And it was actually developed by Kaiser out in Southern California. So this is the case where we're taking an evidence-based practice and adapting it for an FQHC in Eastern Kentucky and adapting it to the setting and the population and the resources. And so to Glenn's point earlier, this is, again, you've got to change the culture. This is not reactive, it's proactive. And even our conversation earlier this afternoon about precision public health, precision population health, where you look at each patient as they come in for every visit. So you may be coming in for your asthma medication refill appointment, but you may very well leave with a fit kit. Or you may be coming in for a back strain, and we are going to talk to you about smoking cessation and lung cancer screening. At every visit, they screen the patient's EMR chart and then gasp. They get a piece of paper out, and they literally check off what the patients need and have the provider work from that piece of paper. We call it a scrub sheet because they've scrubbed the chart to figure out the guidelines. I'll come back to this. And scrub the chart and have the patient and the provider work one-on-one together on that list from a piece of paper. And then it gets inputted back into the EMR. But this actually promotes that patient-provider relationship because they're able to sit and talk with one another. But it also involves the rest of the staff. So this also involves task shifting, where they actually hired what we call, again, scrubbers, but they're called patient care coordinators on the job title, where they are office staff who now scrub the charts and look for those preventive care guidelines that need to be met and alert the provider team about that. And then we've also implemented standing orders so that immunizations can be given without waiting on the doctor to order those, for example, or fit kits can be handed out, or they can prep the room for a pap test. All of these things are done ahead of time. And so, again, it does take a culture shift to do this, but this group was really committed to doing this at every appointment. And I will, so the CEO said, I want this for all health conditions. I don't want it just for cancer. But we all know sometimes our siloed funding mechanisms. So I wrote a CDC grant about cancer for this. But it impacts immunizations, diabetes control, pain management, all of the above. And so this is a quick view of what it looks like. Again, we expanded the scope of practice of the staff. We have standing orders, but it happens all the way, again, from pre-encounter all the way through post-encounter. And this also, we talked about rural communities having travel issues. This saves that appointment when you say, oh, we'll just come back and we'll do all that wellness stuff. And we know they're not coming back. And so you have them there, a captive audience. And yes, you may have patients at the beginning who have 30 care gaps, but you can whittle away at those and chip away at those over time and then get the patients on a regular schedule with their work. We've talked about this all day, having participatory research and doing this stuff in the real world. And that's exactly what we did. And we also talked to the patients. Because, again, if you're coming in to get your asthma medication refilled and I'm now giving you a fit kit, you're going to want to know why I'm doing that. And so we talked to patients, and then also the whole notion of concern about, well, will my insurance pay for that if you're ordering all these things? So we wanted to get the patient's perspective, too. And so I love the term that Michael Parchman used earlier about us providing support at the elbow. And that's what we provided as the university, the technical assistance. We helped with strategic planning and evaluation. We hosted a motivational interviewing training because now you may have LPNs who are talking to the patients about colorectal cancer screening. And so we wanted the staff to feel empowered to have those conversations. One of the pieces we did, and again to resonate with what we've talked about today, was what's called a failure modes and effects analysis that came out of the business world. It helps you figure out where things might break and fall apart because we're all creatures of habit, and you'll go back to the old way if you can't shore up policies and procedures. If the backup generator that runs your hospital breaks down, you need another backup generator. And that's kind of what that premise was for us to put a lot of this work in writing and to formalize it within the entity. And then, having the patients on board was really important. And so if we are talking to the patients about fit kits and taking aspirins and your statins, this was a kind of who, what, when, where, and how often patient education sheet. And the provider could circle which one of those tests we just talked about and why you're having it. And we have now also translated this into Spanish as well. And what happens is these conversations happen repeatedly. I may not be able to get you to get a mammogram today, but if you're back in a few weeks or a few months, I'm going to bring it up again and again and again. And that's actually what happened in some of the cases where we have documented cancer diagnoses, is that the patients told us, the doctor just kept bugging the heck out of me, and I finally did it. So it's that continued, repetitive, strong conversation to help, again, age-appropriate, sex-appropriate, all the right criterion to do the screening test, but to help these patients do it. And so for the sake of not having any more data slides, I did want to share that we had, over the past few years, 20% increase for breast and colorectal cancer screening rates across the organization, 13% for cervical cancer, and then even things like just implementing hepatitis C screening for the right age group, that almost went up 3,000-fold from the first year to the second year, and that was simply implementing a guideline. And so I can't advocate strongly enough. We borrowed actually a leadership model to retrospectively look at what was working and not working within this organization, and it goes to creating a climate. You have to engage the whole organization, and you have to sustain that change to, again, support the provider having that one-on-one, very targeted and tailored conversation with their patients. I help support some of this work with the grant funding, but for the past 3 years, this FQHC has done all the work on their own and sustained it, and it's part of their organization and their culture now. And we've actually been working on disseminating this to several other FQHCs and healthcare systems in Kentucky. So in closing, my recommendations are to, we've heard this today too, we need more evidence-based health interventions that are situated in rural communities to begin with, develop there to begin with, but then if not, we need to adapt to our specific context. Preventive services can be promoted at all clinical encounters. We need to leverage those rural health clinics, those FQHCs, the local health departments. We need to engage all parties in the development and implementation of these strategies and consider context, capacity, readiness, quality improvement, which we heard about earlier, and sustainability when we go about doing this work. And with that.
Thank you to the panel. That was just a marvelous discussion of some very complicated issues. Let's go to our panel for questions.
Yeah, so we all know that coverage is a big issue. And with USPSTF recommendations A and B being covered through the ACA for commercial health plans, there are some nuances when it comes to colon cancer screening. So you can get a screening test, but the polypectomy is not covered. If you have a screening test that's not colonoscopy, is the subsequent colonoscopy covered? These are real question marks that come up. The USPSTF could solve that problem very simply by wording your recommendation to include those things. And when I say you, I mean in the past. So I don't mean to put you on the spot now, but perhaps you could address, I mean, the task force has done that for other things. For instance, screening or counseling for genetic testing for breast cancer. The first recommendation was they recommended counseling, but then the test wasn't covered. So now they say we recommend testing or counseling, and if a test is desired, the test should be had. So the test is now covered. So could the task force, and do you think they would be willing to address this issue through a recommendation change in the wording? They didn't when they had the chance this last about a year ago.
Yeah, I can't speak for the current task force or ARC or HHS in that regard. I think it's an issue that the task force is aware of. It's a role that the task force was not actually actively involved in putting itself into. So I would actually look to HHS and CMS to help resolve this through, better legislation as a citizen now, not as a task force member.
I will say Kentucky actually solved that at the state level. So they changed the policies that if you're a payer in Kentucky, you have to, if they find a polyp on a colonoscopy, it still has to be charged and billed as a screening colonoscopy. And then if you get a positive FIT or FOBT and you have a subsequent colonoscopy, it still also has to be marked as screening. And so we've written that into state level policy in Kentucky.
Other comments from the panel members? I have a question, and I think this is for several of the speakers. A future research need that was brought up, I think by Amy, was should we try to sort out through future research projects the bundle versus the individual component of these interventions that often have multiple components. There may be something in the EMR and then a navigator and then the email or whatever. Often when we disentangle the components, you can wind up with a negative study, which is a bummer if you're doing the study, but also is that the best way to spend our research dollars? Now, ultimately, that's not going to be up to us. It's going to be up to study sections and other groups. But I think there are some methods issues of when is it worthwhile to do those disentanglement studies? Could you comment on that?
I think that's a very nice observation. The question I would have is, when do you stop disentangling?
Yeah.
Because these are complex interventions. I think the culture of the organization that says, what you were saying of scrubbing the record as to what opportunities do we have today and what can we put in front of the patient legitimately, but also in terms of the work it takes to have an organization that's signed up to informed preferences, essentially, put that in front of people, and to every member to look for those opportunities, embed them in the EHRs. These commercial EHRs organizations are not well equipped to do this right now. And then to follow through with the kind of skill development that it takes to use these tools well. And then, when you get to these policy issues, of rewarding good ethical practice when it comes to that. Because many people, not just in screening now, but when it comes to use of decision aids for more elective procedures, hesitate to use them because they'll lose income from a procedure that they miss out on, because people are more conservative when they get into what they want to do. So I completely agree with you, but it's probably like a social ecological model of not just the dyad, but the EHR, the system around that, and the policy and the incentives around all of that. So I would urge this kind of systems thinking we heard this morning to take care of this. But I'm not quite sure how NIH can get to the system thinking at the health service research level, but I would urge that to happen.
Thank you. Mike?
I agree, Glenn, and just to add on to that a little bit, I don't think our traditional randomized controlled trial 5-year study of A versus B that's unchanging is the best way to learn going forward, partly because of the, what's in the intervention package or not, but for a number of other reasons. I think an implementation science and quality improvement framework where you're testing repeated iterations, much more in the IHI model, is better. And if I could, one personal piece of advice that I've observed over the time of doing this kind of work, I'm seeing a trend to large studies with short time frames. And I think that's exactly the wrong way to go. I think we need longer time frames. Oftentimes the startup to getting into doing this work is incredibly time-consuming, appropriately time-consuming when you're working with practices. And having more time and less money, you actually would learn more things. And so I'd love to see some thought about that at the funding agencies.
Thank you. Why don't we start with right microphone and then left?
Hi there, Tiffany Avino from the University of Michigan. So my question for, I guess, all of the panelists is, when an intervention works in this space, do we know why? So what I'm getting at there is, what is the role of theory as one of the explanatory tools that we might have for how an intervention actually works? And obviously there are some shortcomings with the prevailing behavioral theories, given that many of them were not developed in marginalized groups or necessarily validated in them. So I'm curious as to what you think about the role of theory going forward as we try to develop and improve upon interventions. So that would be kind of my first question. And a related question that I have related to colorectal cancer screening in particular, so a question for Dr. Pignon, would be whether you've at all disentangled some of the issues related to the complexity of the actual type of screening. So colorectal cancer screening can be very complicated and a multi-day process. And I'm wondering whether you've looked at complexity reduction type strategies as ways to try to promote screening, and also whether, given that the National Health Interview Survey now includes things like work arrangements and work hours and things like that, whether you've disentangled some of the socioeconomic status issues with some of the occupational issues. So there's a few issues there. Thanks.
Can we work our way back? I'm really interested in using more informative data like newer NHIS data to better understand the particular barriers that patients face. And, the characteristics of the unscreened in colorectal cancer are different today than they were 20 years ago. We're much further up on the tree of fruit. We need to continue to evolve our understanding. So there probably are barriers and interventions that we haven't thought about that we could still, so there's plenty of work to be done still. I think with respect to complexity reduction, that is at the heart of a lot of these interventions. The more steps where things can fail, the more likely they are to fail. So really thinking about that and making the simplest system possible, standing orders rather than having 2 people have to sign off for immunizations, things like that, I found to be highly effective. And I'll leave it at that. Maybe somebody else can comment about theory.
Theory?
I'd like to address that theory piece a little bit. One of the favorite theories I have moving forward at the moment is called normalization process theory. What does it take to make something normal? I think the smartphone is the fastest technology piece implemented ever. So now we have 7 billion smartphones on the planet, more. I know some people have 2. But that's a very interesting take on what it takes to make something normal practice. And that is worth looking at. It was developed by a sociologist in London called Carl May. It dovetails with the Consolidated Framework for Implementation by Dan Schroeder. That works very well with that. In fact, we're using both those theories in our work. Because I'm fascinated, if you like, by what these randomized trials of one intervention A versus B doesn't get us very far. We actually have to work within complex systems because the behavior of people inside them is modified by the incentives and norms in which they are embedded. And so that's very interesting. In terms of more micro-level theories, I would go take you to self-determination theory about what motivates people to behave in different ways. People mostly behave to reserve energy and also in their interests. So if it takes a lot of energy or effort to do something, it's unlikely to happen. But if they realize that it's in their interest, they're more likely to do it. So these there's another theory called collaborative deliberation about if you involve people, they're more likely to do it. And the favorite overarching thing for healthcare for me at the moment is the work of the economist Eleanor Ostrom, which came up with the idea of co-production. People who live in forests or fisheries actually have to work together or you get a tragedy of the commons. If you use all the available resources, there's nothing left for anybody. And with 18% of GDP in America going to healthcare at the moment, it really is at risk if there's nothing left for education or roads and so on. So that, I think, is the kind of overarching theory that I would urge people to look at for health service research.
I guess a follow-up question then would be with regards to those theories. Oh, sorry.
We need to move on.
Okay, sorry about that.
Thank you.
Okay.
Happy to discuss more.
Left side, yes, after.
Thank you. David Goff, NHLBI. In a previous life, I was a general internist and a public health doc, so really have enjoyed today. Want to thank the organizers and the speakers for a really tremendous day. Questions about this area of navigation or health coaches, lay health advisors, promotoras, that whole group. So it's maybe for Dr. Cantor, but for anyone else to weigh in. Given the evidence that you showed today, as well as evidence in the literature that this same group of kind of healthcare workers can help change individuals' behaviors around diet, physical activity, smoking, can also lead to changes in biological outcomes like weight and blood glucose and cholesterol and blood pressure. What are the information needs, also known as research opportunities, what are the information needs of policymakers to move forward to make this a sustainable part of our healthcare system writ large?
Sorry, I appreciate the question. I think we have 9 studies that showed us that really various iterations in different populations were effective, whether it was a lay health worker, a patient navigator, a promotora, and generally they were tailored for the patient, they were culturally sensitive, they were appropriate to the healthcare environment, and they connected the patient to the provider. So it connected that clinical environment and sort of created what we're hearing about patient-centered medical homes, or kind of striving towards that goal. And I think looking at opportunities to evaluate the implementation piece, where if we're seeing things that are helping in terms of effectiveness, showing that if patients are connected to their provider, even if they're getting a letter from their provider, that seems to be meaningful. If they're getting a follow-up call that's helping them schedule a colonoscopy because maybe they left the clinical interaction with questions, but someone's there to follow that up, there's lots of, it seems like, seemingly lots of opportunities to close that communication loop, and those would be opportunities to evaluate that implementation piece. It seems like we have the groundwork to move forward with good questions about this, and so that can be used to maybe inform what might be most effective and how you implement that on a bigger scale in other populations or more broadly.
Can I just add that in my experience, and I don't know if this is really fully borne out by the evidence, but having a warm touch first before entering into navigation is more effective than a displaced call center. So what really worked in our study in Albuquerque and in North Carolina was that the navigator met the patient in the clinic and then navigated them, mostly by phone after that. But there was a warm handoff first, and I think that's pretty important. I also think we need to learn what makes good health navigators. Like right now, it's so kind of one-off and rare, oftentimes in research studies, that we can recruit great people. But if we're going to implement this at scale, we've got to know, how do you take somebody in high school, identify them as just, they're a good helping person, give them the training they need to be great, and really build this as a career path. And I think it's going to be doable when the payment model changes from pay per procedure to pay for outcomes and value.
Yeah, thanks. I think these sorts of research opportunities and information needs will be really helpful for all of us, so thank you.
Thank you.
I'm sorry. I was just going to, same thing. It's the touch. It's the warm touch. It's the human touch. We have a program in Kentucky. It's called Kentucky Home Place. It is state funded. Of course, they're waiting for Medicaid to change and Medicare to change so that they can be covered entities. But they serve as and I heard a story on Monday, but they serve as the intermediary between, the patient and the healthcare system, and they're that trusted local, they're their neighbors, and I think that's invaluable.
Yes.
Jessica Anker from Weill Cornell Medical College. It's great to hear these perspectives. I wanted to ask about the larger, the role of the incentives in the misaligned incentives in the healthcare system, that simply providing health insurance coverage for these is not sufficient to deal with. In a so far unsuccessful project in my medical center, we're trying to build a multi-stage intervention facilitated by the EHR to do some shared decision-making around lung cancer screening. We found the misaligned incentives so far have derailed this project in a number of ways. One of them is that the quality of the smoking data in the EHR is quite poor. We've got about 20% of patients who have internally contradictory smoking status. So it's hard to tell who's actually eligible. We have primary care. Right now, there's a Medicare, as you know, pays for a shared decision-making visit for lung cancer screening because the risks are so serious. So the radiology department has taken on that shared decision-making visit. Primary care is less interested in this because they are not getting reimbursed for their shared decision-making visit. And then also we tried to build in, I'm still hoping for this one, we're hoping that an outcome might be lower rates of inappropriate lung cancer screening from low-risk patients. At the same time, this gets to Dr. Vanderpool's point about de-implementation, simultaneous with higher rates of screening for the high-risk patients. Radiology is not on board with this. They really want more screening across the board. So, we're sorry. Also, actually, a lot of my projects are in collaboration with a federally qualified health center that's a family medicine practice, and they entirely opted out of this one because the American Board of Family Practice has not endorsed lung cancer screening. as a preventive measure. So anyway, these are snapshots about a much larger misaligned incentive problem that I'll be talking about health information technology tomorrow, but I'm saying the EHR is not going to fix it.
Comments?
I think you should write that up very carefully and explicitly, because you've just identified a whole series of misaligned incentives, and actually that is very diagnostic of the issues. My feeling is that this screening process of lung cancer screening should start in primary care. That's where that conversation should take place. They should be equipped with the tools and the data. I'm sure most generalists don't know those probabilities of incidental findings and so on, so they're not really equipped right now, and they should be heavily incentivized if that's the right place to do it, and they should identify the right patients for the right procedure. I just want to advocate for, we're not going to get this right until we have a measure of the process. The process is the conversation, which is careful, it's kind, and it's got evidence in it. And you may know that I'm advocating for patients to record clinical conversations and for us to use artificial intelligence to assess what's going on in these conversations. That, I think, will change healthcare, because we're beginning to see inside the box of why are people doing something and what are they explaining.
And for those of us who have done audio taping studies, it's pretty ugly. We're just not where we need to be, in regular care. And some of my colleagues at UNC recently published a paper looking at some of the lung cancer screening conversations that happened in a randomly selected number of audio tape visits, and they were not where we need them to be. But again, as Glenn's saying, until we have a means of, assessing good informed decisions versus not good informed decisions, I think we're going to struggle. Just like we're struggling in a payment environment where we're kind of trying to do value, but we're also still living in the, gosh, we get $1,000 for that CT scan. And that's, the old system's pretty strongly entrenched. So I do think it's an interesting QI question about collecting smoking status. So we collected smoking status in the past for one reason, and the EHR fields were set up really to enable smoking cessation. And the questions we asked were about current or not current, but you need different information to also guide the lung cancer screening decision. So literally half of our QI work was about improving that part of the process, because everything else flows from there. So I think we have to be humble about, these are not easy things to change, and stuff that we might think like, well, it's not very technologically sexy, but really figuring out exactly what questions we want to ask patients about their smoking status and how we record that information is vitally important.
Yes.
So this question comes from our online group. It's for either Dr. Pignone or Elwin. To foster research on effective and shared decision-making, SDM, for screening or treatment, are clinical decision support, CDS, tools needed, or can research on SDM be encouraged and conducted rigorously without the use of CDS tool?
I think Glenn made that his point of that, but I'll just say I think at this point, if you really want something to be implemented going forward, you can do research outside of the EHR, but if you want it to have lasting opportunity for implementation, I think it has to be done within EHR workflows at this point, or at least be prepared to be implemented into EHR workflows. Sometimes when we start on a QI project, we start with the paper version, but we're always thinking about, so we can change it every day, literally, if we need to, but we're always thinking about, will this work within the EHR workflow? And if it's not going to ever work within the EHR workflow, I guess the one thing I would add to that is that what we call the EHR now, I don't think we've really incorporated the patient portal side of the EHR, and that we need to metaphorically expand the space of what we consider to be our shared interaction space and incorporate the patient portal as well, because then you do have opportunities to do things outside of the real estate of the clinic, but still within the information environment of the system.
Just to address the question directly, I don't think you need a tool, but it is really helpful, because you need skill. Well, actually, let me start at the beginning. First comes attitude. I want to help this patient make an informed decision. That's the first thing. Secondly is you need some very good data in absolute risk terms. What's the baseline risk? What happens if you do something? In ways that the patient can understand. And interestingly enough, when we make good decision aids, you know who likes them best? It's the generalist who didn't know this data in the first place. So they learn a lot by using these tools. So they're not even necessary and they're not sufficient, but they help a lot. That's my answer to that. Do we need a tool? And of course, in primary care, there's so many thousands of decisions. We'll never have a tool for every decision. In fact, what I think happens is that once you begin to think this way, what can I do here, A or B or C? You begin to generalize the skill set. And then you seek the information, if you're a good practitioner, to help your patient.
Thank you.
If you could, y'all could expand a little bit. The EHR vendors, they're not in the decision aid business. They're in the EMR business. And they, in at least conversations I've had with them, they shy away from that because of liability issues. You're the providers, we just do the EHR. Yet they need to be able to support these tools. And how close are we to those conversations having fruition? No brand names, please.
Right, no brand names. But you'll know that there are major EHR companies. They recognize that they're not skilled at this and they can't keep up the evidence for the tools. They can't keep them up to date. There are commercial people whose livelihood depends on making these tools. And what I think is happening is that the EHR companies and some of these other organizations are saying, who is going to be our third-party vendor? And there's a discussion, I'm sure, going on as to we need less of these third-party vendors than we have at the moment. So some consolidation of that will happen, I would imagine. But I don't think it's going to be possible for an EHR company to go forward without some of these tools made easy for patients and clinicians, especially given the portal work. So I think watch this space. There's a lot of conversations going on.
I honestly think there's as much challenge in getting the right context as there is in delivery. Like, if you give me 6 hours and some reference materials, I can give you a decent tool for almost any question. It's not that challenging. It's challenging to do on the fly, right? But it's more like, how do you get it to the person at the right time when they're in their right decision-making window? And then how do you follow up? I think we really can't neglect at all the downstream follow-up. We've been able to deliver decision support to people, help them make good initial decisions, and then the whole thing falls apart without good follow-up. And that's for things that are discrete actions. If you imagine something like, we've done work on alcohol screening, right? So a lot of screening, relatively small number, but not very small number of people who need intervention. But then how you get them to the right intervention and make sure that they can follow through with the right resources, that's a challenge of how we organize our whole system, not just the decision aid.
Can I make just one more comment from the one place I heard about the gap between the fact that an EHR exists, but it's only as good as the data you have. And so if it's not being entered by the MA or the provider, if it's up to the provider or whoever in that clinical setting is responsible for entering the patient data, then it's only as useful as the data that you have. And so if the smoking data isn't correct, you're not going to identify the right people in the screening group. So that's kind of, I don't think that the EHR, we'll hear a little more about technology tomorrow, but sort of as a bridge to that idea, thinking about the ways to use it to inform what we're doing, but not as the only tool necessarily.
Thank you. We have time for one or two more questions.
Okay, thank you.
Panel guest presidents. Doug?
So this informed decision-making presents a real dilemma, because particularly if you look at the ethics of it, and as Dr. Elwin said, let's present absolute risks rather than relatives. When you talk about cancer screening, the average person really has very little chance, or small chance, of being helped by it. They have a chance of being harmed by it. Sometimes those are balanced. But if you sit back and look at it, to the average person who sits there and says, well, my chance of getting colon cancer are X, the absolute risk, that's, much higher risk than chances I'm not going to get it. It's a hassle to get screened. I'm wondering what the research shows when you actually present data objectively like that.
I can answer that for colorectal cancer and have some experience in the others. And with colorectal cancer in the United States, it's on the order of 92 to 95% of people elect to have some kind of active screening. Now, they don't all complete it, but if you ask them to make a decision, most people choose an active screening compared to no screening when given good information. That's, of the preventive services, that one's not maybe as much equipoise as some of the others, but that's what we're seeing. In lung cancer screening, we're seeing 40 to 55% in different studies electing to be screened and others electing not to be screened.
Thank you.
So I have sort of a follow-on question to that one, which would be, what are the outcomes then that we should be looking at if we're taking this shared decision-making approach? I mean, the studies we looked at, the outcomes were increases in screening rate, and we've been talking about the incentives and informed choices, and that an informed choice may actually be not to get screened, and the precision with which we can identify the populations that should or shouldn't be screened make those basic statistics about what proportion of particular populations are screened maybe even less useful. So I'm just curious what recommendations you would make about other kinds of outcomes that we should be thinking about, and then what kind of an impact would that ultimately have on health disparities? Because that's why we're all here today. So I'm curious about that.
In the field, I think in the shared decision-making, there's been a big debate about this, because if you've got an equipoise situation where, by definition, nothing is really remarkably superior, and you go for B versus A, then the chances of the health outcome being dramatically different are not that large, right? It stands to reason, is in equipoise. And so where you've got a public health imperative, say mammography, cervical screening, you've got a population benefit that's been calculated by usually decision analysis or some policy incentive, but the individual himself or herself may not stand to gain a lot. And so in that situation, I think the ethics are pretty balanced. My own view, and I've come down to this, is that you allow the individual to make a choice where the evidence is pretty much in equipoise. Whether or not the public health view can live with that is a big debate. The outcome measure that's been promoted in the field of shared decision-making is decision quality. Did this person understand the trade-off between the benefits and the harms, and did they elect to make that decision when they were better informed? So that's a metric that hasn't really been developed to the extent that it's easy to use and it's widely used. But it is something that I think we should be thinking of.
I think that the main point being there that you can't just automatically go to measure screening rates for all these decisions. But in some of them you can. I think it's a reasonable measure in colorectal cancer screening as long as you also have informedness at the same time.
Steve.
So following up on that discussion, do you include cost and to the individual, the downstream costs of all of these procedures? And what's the impact then on equity for the people who really will find that burdensome? And won't that, I mean, if we believe that the screening should occur and it's a matter of which test perhaps, they might be opting out to a greater extent. So to what extent do you include this, and to what extent does it affect equity?
Okay. I've worked a lot on this topic, and it's not an easy one. I think you have to have some element about cost uncertainty in your materials, because people are going to face uncertain costs. And I think it's actually a greater sin to not tell people about the possibility that they could be given a surprise bill, or a bill that actually bankrupts them or means they can't pay the heat bill for the next month. That said, it's very hard in any individual circumstance to say, for you, this person sitting in front of me today, I know exactly what costs you're going to face. It's complex, period. It's complex for healthcare providers. So we've tended in our materials to default to recognize that there may be costs associated with downstream work, right? That's, oftentimes how we've approached it, which is better than not saying that, I think. But it's very hard to get precise. This will cost you $325.
Can I just follow up? I've lived in a country where that doesn't matter so much.
Thank you.
Where it was decided societally to not make it matter at the point of care.
Right. One last brief comment.
Thank you. Thanks for the panel and for your effort for rural area health. But I think anything applied to rural area should be able to apply to the urban area, especially like the national capital area. The problem is they can always exile people out of town. So if we have the system, they go to a higher bid because of the money they have, whether their money is robbed from the people's assets or account or their house or their car. So if you don't have a proof whether you are methodically necessary to use PPP, public-private partnership, or you have a good analysis for cost benefit, that you must use government abuse of power or money or deficit or government deficit or budget, whatever, go to the sky high. So how do you say you want to promote a rural area without considering the urban area population? So if you have witnessed anything happen in an urban area, would you be able to present to the government officials, say those misconduct or misdiagnosis of unjust injection or medication should be put to jail or should be prosecuted or even put to death?
Thank you very much. Any comments?
If an intervention works in a rural area, I think you can adapt it to an urban area and vice versa. And that's what implementation science is certainly about. And so I think any gains on either side of rurality and urbanicity can be shared across the continuum.
I want to thank everybody here for staying past time, but also this was a great discussion that was pretty wide-ranging, and I think sets us up well for tomorrow, where we're going to have key questions 4 and 5, which are going to be about health technology as sort of single modal interventions, and then a very complete discussion of health systems, which kind of brings it all together and has a fairly robust database that we'll be hearing about tomorrow. I want to thank our speakers. So think about questions and comments for tomorrow. It's going to be a fun day. We start at 8:30 sharp here. And everybody have a good night, safe travels home, and thank you very much.